Good morning, respected dignitaries, distinguished guests, esteemed faculties, and dear delegates. On behalf of All India Institute of Medical Science Bhopal and National Academy of Medical Science, it is my proud privilege to warmly welcome you all to the Dissemination Workshop and CME, the first regional CME of NAMS. This academic initiative brings together eminent experts and thoughtful leaders to deliberate on two transformative domains: organ donation and transplantation, and artificial intelligence in healthcare, areas that are shaping the future of medicine and saving lives. To invoke the auspicious beginning, may I now request our dignitaries to kindly join us on stage for ceremonial lamp lighting. Professor Dr. Madhvanand Kar, Executive Director and CEO AIIMS Bhopal, Professor Dr. A.K. Mahapatra Sir, President AIIMS Bhopal, Professor Dr. Digambar Behera, President NAMS, Lieutenant General Dr. Venu Nayak, PVSM, AVSM, VSM, President-elect NAMS, Professor Dr. Y.K. Gupta, President AIIMS Kalyani, Professor Dr. Rakesh Agarwal, National Chair for Disease Elimination ICMR, and Professor Dr. Rajneesh Joshi, Dean Academy. Professor Dr. Y.K. Chawla, former Director, dignitaries. We now move to felicitation of our esteemed senior dignitaries. May I request Professor Dr. Madhvanand Kar, Executive Director and CEO AIIMS Bhopal, to kindly present mementos. To Professor Dr. A.K. Mahapatra, President AIIMS Bhopal. Professor Dr. Digambar Behera, President NAMS. Lieutenant General Dr. Velu Nair, PVSM, AVSM, VSM, President-elect NAMS. Professor Dr. Y.K. Chawla, former Director, PGI Chandigarh. Professor Dr. Y.K. Gupta, President, AIIMS Kalyani. Professor Dr. Rakesh Agarwal, National Chair for Disease Elimination, ICMR. Thank you very much, sir. It is now my proud privilege to invite a visionary leader whose guidance continues to shape the academic and clinical excellence of this institute, Professor Dr. A.K. Mahapatra, President, AIIMS Bhopal, to kindly address the gathering.
Good morning, Jai Jagannath. I am from Puri, Lord Jagannath, Master of the Universe. So we always beg or seek a blessing of Lord Jagannath, whatever we do in our life. Because without blessing of the God, that is what a spiritual life is. When we define spiritual life for the doctors, we found doctors are very bad. In 1948, we thought health is defined as physical health, mental health, and social health. They ignore the spiritual health. And we are all going to be health professional and heal other people when we are sick. Two paper in Lancet say doctors live less than other people. They are more stressed, they are mentally disturbed for the patient or administration or anything else. So keep yourself healthy, both in mind and spirit is very important. That is the reason after 50 years of 1948, when WHO re-evaluate what is the condition of doctors and what is good health. So they found 50-member committee constituted in 1996. They gave a report to UN and WHO that world is living longer, people are living longer, but they are unhealthy. So I say, don't make your stomach dustbin of medicine. 70 years, my experience, I don't know how Dr. Chawla, Dr. Behra and other thing, 70 years people who can see public, they take two medicine for diabetes, two for blood pressure, one for sleep, one for joint pain, one for backache, one for constipation. It makes 10. If they are not COPD, cancer, diabetes, neuropathy, if they are, they will take 10 more. So if God is kind to you, for you survive 10 years, 70 years, 10 medicines. So what you have to do now? You have to make yourself healthy so that you don't landed in 15 medicine at 70 years of age. NAM is, when NAM was started 1959, small. but the act was approved in 1963 because I started my junior residency. The NAM was in a C1 quarter, C2, which is now the faculty club. You have seen Dr. Behra, you have seen the faculty club. Dr. Gupta have seen. I think the C116 was a small room of one bed. Somebody was trying to give one bedroom drawing room in Canada. That is why the AIIMS Act, if you read about AIIMS, that Jawaharlal Nehru called several people, including Susila Nair and all those past person, that we should have a medical academy which maintain and give their input and see that medical profession improves, flourish, and expand in the country. Because we have very little survival. Average survival at time of independence was 33 years, and now we are surviving at 40 years more. So in 75 years after independence, we are now surviving 73 years for ladies and 72 years for gents. All over the world, it is proof that ladies survives longer than the gents, whatever reason may be. Less stress, good life, relaxed life, no administrative job. Very few people. Are you looking at how many presidents of America are female? Not a single one. From 1771, America got independence. In last 200 years, not a single president of America was female. So many places you go, the female, we claim that one by one, 50-50, but it's not 50-50. Sachin Tendulkar got much more money than female. So also Shahrukh Khan, Aishwarya Rai. But I always encourage that there should be 50-50. In my university, girl students are 63% and boys are 33%. And if we tell out of 2,300 faculty is 47% and 53, but boys are 33% versus 67% girls. So I always feel happy. The girls have done well in my university, which now is the 14th rank amongst the 800 university. And if you see the medical colleges, my hospital is now better than AIIMS Bhubaneswar. AIIMS Bhubaneswar 14 and we are 12 amongst 875 medical colleges in India. Why I am telling so? Having spent 43 years at AIIMS Delhi, I saw AIIMS Delhi had a 500 beds. Now it is 6,000 beds. Today the AIIMS Delhi has 6,000 beds, around 7,000 crore budget. When you look at the grandfather, great-grandfather, then we feel small, how bad we are. So don't compare yourself like AIIMS Delhi. You can still run with your grandfather, but may not be very strong like him. But see that you are one day will be bigger than your grandfather. If you look at to be bigger than grandfather, when you are small, don't get upset. So today for the resident, don't get upset because big people are sitting in the front. You may be someday much higher rank than what we are. But my point is that medicine is still a very important branch of science, but yet neglected. If you look at all the doctors, they have downgraded the director post of AIIMS. When AIIMS started 6 AIIMS, they are the secretary rank. When there was only one AIIMS, 1956, 2012, but 6 AIIMS, and all are secretary rank. And we have now 23 AIIMS, and the director is Johnson. While the IITs, I told many people, asked Dr. Mahar, why don't you fight IIT's director is secretary, IIM director secretary? Health is so bad, the health is so neglected that director post from secretary has come down to general secretary. And our professions are not together to fight. Why the IITs are better paid than I? Night duty, more duty, 24 hours duty, you do Sunday duty, Dasara ka duty, सब करते, लेकिन our salary is less. We are all sitting here. Can you not explain to the government why the director post AIIMS is less than a director of IITs? Why should IIT secretaries and AIIMS director be? I don't know. They have only left AIIMS Delhi, Chandigarh, NIMS, Pondicherry, and one more. If you take out the 6 institutes, those are little more senior in the age, are left as a secretary. All other 22 AIIMS are downgraded. So my table is that in a medical science, the purpose which aim this society this trust of structure or organ started 1963, and Pandit Nehru told his first speech that see Doctor. I think there are about now 20 presidents. Was a president tenure is 3 years. नाम का. In last 60 years, from 63 till now is 62 years. And I expect 20 presidents have to go on. But none of them thought that we should be equal with the IITs and IIM. I always believe you work more, get less. If we are Buddha or Bhagavan, then it doesn't matter. We heal human being, so that is a blessing by God. हमको पैसा क्यों चाहिए? लेकिन money is also important. Because I always feel money is as important for everybody and for the doctors so. But we cannot believe that we are the servant of the money, but we should be master of money. In the profession we see lot of people do malpractice. People come to me, malpractice. I ask them, which lawyer is not malpractice? Which engineer has not? Why you do point only doctors? When the budget of AIIMS is 2,000 crore, 1,000 crore go for helping the contractor, IS officer, secretary, president. I know 50% gone. The budget is so that 50% will be given to Chanda. But then why doctors are told you are corrupt? Why doctors are paid less, work more, and consider they are the practicing doctors make too much of money, lawyer practice, engineer practice, teacher doing so much of tuition. Tuition का नाम तो हम सुना नहीं था. When I was a student, we never believed that you should have bad enough student to go for tuition. ना बिना tuition तो बहुत सोचते हैं MBBS नहीं मिलना, नहीं? That was I would be surprised if a single student appear NEET who has not gone tuition. That means we ourselves think we are bad students. We record the lathi for walking. So I don't believe in that. Be strong, behave properly, be gentle, have spiritual life. I stop three aspects of life: physical health, mental health, and social health. In 1998, they added spiritual health. Does anybody know what is spiritual health? Defined by WHO. So WHO defines spiritual health. Know who are you. Are you a body or a mind or a soul? They say first you know who are you. Second thing, WHO say, what is your destination? What for your doctor? What for you have come? For making money? Having good life? 10 houses? Mercedes car? What do you want? If you do not want, what is your destination? Serve the people, then become Mahatma Gandhi. Vinoba Bhave. They don't expect anything. No? But where are they and where are we? So if you want to be a spiritual doctor, behave like them. That is the reason Swami Chidananda wrote a book. I don't know how many know Chidananda. How many know Chidananda? Sivanand. Sivanand was a doctor who did MBBS from Madras Medical College. The second one in the country after Calcutta Medical College. June 1838, Calcutta Medical College started. June 1838. After 3 months, they say, why not? Why Calcutta? Why not Madras? Because Madras has a consulate. Calcutta was the capital. Because Delhi capital shifted in 1911. So when they did second medical college, Bombay, so why not Bombay? So they had already JJ group of hospital started in 1838. So after 6 years of JJ hospital, they started JJ medical college. So if you think 3 medical colleges, Calcutta, Madras, Bombay. Then by 1900, we have 7 medical colleges. By independence, we have around 40 medical colleges. Then Boer Commission. How many of you know Boer Commission? If you are medical science, you must know your history. If you know the रावण का क्या कितना बल का था, अकबर का क्या है, मुगल शासन क्या है, why don't you know history of medicine? What is Boer Committee? Boer Committee was by Royal Society of Medicine. They say India requires too many doctors because they are now not having medical college. All the doctors have to be coming by ship to India. So it was very difficult for the doctors from UK to come India by ship. So they started thinking, हम इंडिया को तो ट्रीट नहीं करेंगे, ब्रिटिश लोग को तो ट्रीट करेंगे ना, हमारा लोग जो इंडिया में है, एडमिनिस्ट्रेशन देख रहे, शासन चल रहा है, उनको कौन ट्रीट करेगा? So that is the reason they started with college, not that to help you. British was not kind enough to start medical college, Calcutta, Madras, because they are very much concerned of the health of the Indians. No, they would have rather you be just like slaves. So we don't believe that. We like that all people should be blessed like you or like me. If that is the cause, we should create healthy people. So today you are here, and today we are talking about AI. First lecture I gave about AI to a group of doctors at Calcutta 10 years back. AI is called like a old wine in a new bottle. It's software package. Started first time in 1945. When the computer came 1932, it was a first computer was a room size, 20 by 20 feet. Go and see the history of medicine. When the first computer came to function, it was a room. So they are trying to make computers smaller and smaller. So 1945 they had software who can was a much faster computer. So then 1952 say which faster, can it be better than human brains performance? So that's all. Okay, let us say AI. So the name came in 1950. After that, they tried to make software more and more sophisticated. And there are two companies used to make AI, Boston Surgical and one of the IT company in, I think, America. So AI is nothing but a software package used for complicated. Suppose neurosurgery, we have 27 faculty, and one person come with brain tumor who is going to die. Controversy in middle of night, we should operate, take 8 hours to save one person life, or he should go peaceful to heaven. It's not controversy. All the money we spend for a person who comes to coma with a brain tumor at AIIMS, we have 27 faculty. There will be 2 groups, 3 groups. Then what will do? Somebody say, life is not like, let him die. If he survives, rest of the life he will be vegetative. What you have done? If you look at the 50 years of neurosurgery, I am going to talk as 50 years of neurosurgery tomorrow. If you look at the, from death, we have converted vegetative. Because then somebody have died. We had done an international study on survival head injury, severe head injury. Dr. Mehta and me are involved. That was about 25 years back. We analyzed what you have done, really what you have done. Then we have analyzed data from US, 200 patients, and data for AIIMS. The average survival was better than we have 22% survival, and US had 21% survival. So what we then analyze? 6 months, 1 year, and 2 years survival. If a person has a head injury in coma, he goes home, his chances of dying at home are another 30%. So he died another 30%. The house doesn't have the facility to manage head injury patient. And we cannot afford to stay in the hospital for one patient staying for a. I saw a patient when a Sanjay Gandhi director was referred to me because they are from Lucknow. That boy remained in Apollo in 2006 to 2007 and spent 3 crores. When the father spent 3 crores, then he realized I am become poor. So he came, sir, ये जिंदा रहना चाहिए ना मरना चाहिए. I said there is no euthanasia. if euthanasia wouldn't approved by our government, then mercy killing would have been done. I would say kill him today. You don't spend 2 more crores for maybe survival rest of the life. The question is that where do you stop? For that AI is important because there is multiple opinion depending on the number of years of service, your age, your place of working, and facility available. We are telling, I was in MCI, Ethics Committee Chairman. They say, who will do cesarean? When it was by AIIMS, they say all should be done by gynecologist. उनका क्या सारा सीजन एम्स होता नहीं, पेरीफेर में होता है. What happens? A person come in obstetric labor at a PSC, you send to AIIMS, send to center, तो मर जाएगा. तो हम बोलेंगे wherever the facility available, gynecologist there, it should be done by gynecologist. If gynecologist is not there, surgeon is there, by surgeon. because पेट तो खोलना है, मैं गॉलब्लैडर निकाल सकता हूँ, बच्चा क्यों नहीं निकाल सकता? Then I say nothing is there, MBBS doctor. We cannot a blanket rule. All cesarean in the country should be done by a gynecologist. We don't have a gynecologist. During the COVID, I analyzed gap analysis. I saw for medicine, surgery, gynae, pediatrics, we have gap of 80%. We need 80% more doctors. Then I analyze how many doctors are required for the population 1.5 billion. We require 20 lakhs. In the last 200 years, we have produced 7 lakhs. If in 200 years we have produced 7 lakhs, how many hundreds you will take for making 20 lakhs? Because people come and return and die. So when you reach 20 lakhs, 5 lakh would have died. So the question, where do gap analysis? It's a continuous process. So I will thank all of you. I have told ground reality today. If you fall sick in a village, my village, what will happen to you? This year, I was traveling in Calcutta. I had a speech arrest. I could not speak. I went to the dispensary. Was डॉक्टर सर, आप तो डॉक्टर है, आप क्या करना है? मैंने बोला मुझे हेपेरिन दे दो. I have a TIA. They gave heparin. For travel from Calcutta airport to Delhi, to Bhubaneswar. That was 15th October. I had a speech arrest. I thought TIA होगा. 75 years में क्या होगा? Stroke. When I saw that, they have produced hemorrhage. So I took it because 90% stroke are ischemic stroke and 10% hemorrhage stroke. So probability of me sitting in Calcutta airport having a sudden speech arrest is likely to a TIA. On that concept, I went to the doctor there. They were very junior doctor. Sir, आप जो बोलेंगे हम कर देंगे. आप यहाँ जाओगे काट कर. मैं कहा नहीं, मेरा फ्लाइट है. I am at there 7 o'clock, 8 o'clock flight. I reach Bhubaneswar 9 p.m. So I 9 p.m. reach and straight went to AIIMS, my hospital, not AIIMS, some, and got a scan as a clerk. But we managed conservatively and found, I thought probably, ischemic area by giving heparin, it becomes a hemorrhage. So for that, if I had AI in my software, I would ask, I am 75 years old, suddenly I have a speech arrest, I don't have diabetes, I don't have blood pressure, what are the possibilities for treatment? They have sorted, yes, don't take. It is better to wait for, if you have recovered speech within half an hour, you can wait for getting a CT scan and go for treatment. So this is the where AI matter. You have a AI package in your computer, sit down there, because this can happen to anybody. All of us, many of us are 75 years. We are traveling every day. Suddenly you have a speech arrest in the airport. What do you do? And they say, you are senior doctor, हम क्या advice करेंगे? आप जो बोलेंगे हम दे देंगे. Then you take heparin, develop. So thank you very much.
Thank you very much, sir, for your inspiring words. I now have the honor to invite a dynamic administrator and an ardent academician whose leadership continues to drive AIIMS Bhopal towards excellence. Professor Dr. Madhvanand Kar, Executive Director and CEO AIIMS Bhopal, for the welcome address to the participants, delegates, and faculties.
Thank you. Good morning, all, and welcome all here. All the dignified dignitaries and legendary uh, teachers and legends in their field are all here. First, this I am fortunate, and we feel fortunate as AIIMS Bhopal faculty, students, everyone here, that NAMS National Academy of Medical Science bestowed their faith that they are going to start this first task force CME. Then by National Academy of Medical Science, what is today, this is the dissemination workshop come CME on two very important and futuristic visionary CME. That is, one is the organ transplant, another is artificial intelligence to Bhopal to start with. And they will do subsequently other states. This is a proud moment for AIIMS Bhopal that we are holding this the first task force CME by NAMS. I thank Sir President Sir Professor Behera, who is a Padma Awardee and legends in his field. And you all know that 3 to 4 Padma Awardees are here as our uh, resource persons and guidance and moderator here in front of you. And all the resource persons are legends in their field. That's why we feel fortunate that they are here and we will listen to them. And they've given responsibility for, we have to organize this with 4 states. All the resource persons, they will deliver all the, like in organ donation and transplantation with AI, the deans, policyholders, and senior leaders from all 4 states like Jharkhand, Chhattisgarh, Madhya Pradesh, and Maharashtra. All are here. I welcome you all. This will be a very learning experience for everyone, and I welcome you all to be patient and be involved and take this message, because this is the like awareness for this both. One is the organ transplantation, that is the very complex life-saving procedures, and I think that is in medical science one of the challenging subjects which carry the robust systems, ethical frameworks, and multidisciplinary efforts. Simultaneously, this is the giving what we see in the future, no one can imagine. Though our Puran stated the Adhicha is given that first and noted and in his Puran, that is he is giving their bone for the betterment for the society, for the life saving. Now this is giving even in carrying all the cancers, even whole body we can create with organ transplantation, that we can see. Another is artificial intelligence. Already Mahapatra sir told that is the futuristic vision. This is the change whole concept. What we've seen, the database system, coding, all this is gone now. This is the AI. This I am not taking time. I welcome you all. And Bhopal, this AIIMS, all the faculties are very dynamic. I think you can see they will take care of everyone and you enjoy your stay, but simultaneously my request is to involve yourself, take the message, and be a messenger to your state, your area, and develop these 2 things which will transform the patient's life and everyone's life. Welcome you all. Then thank you all. Yes, sir. Thank NAMS that's giving this opportunity to us to all here. Yes, sir.
talk about organ donation, where do we stand? When I joined at AIIMS Delhi in 75, 7 kidney transplants were there. Kidney transplant started by Dr. Dhawan in 71. 7 were there. When I was doing resident in general surgery, we are posted for 3 months. One case go home, 3 months used to stay. Rakesh, have you ever posted in there? No. So we are doing 4 to 5 transplant in a year. Now people are doing 300 transplant. Regarding heart transplant, it is 4th of September 1991. We had a patient who died of organ failure. It was my unit, not Dr. Mehta's unit. We had Ajay Bakshi, a very brilliant student at AIIMS. He talked, I don't know how many of them know Ajay Bakshi. He was a neurosurgeon, gone to America. He talked to the female patient and the patient agreed for organ donation. That time, no organ donation law, which came in 94 and approved in 95 in the parliament. So the question is that where do we stand legally? With a good faith, we say we have no law, we write down, we have excellent, that even the give organ donation, we cannot give them money, unethical. We cannot tell who is getting, unethical, and he will not, donor and recipient will never meet. That is what after that I incorporated this. So we had done 150 heart transplant when Dr. Venugopal celebrated 150th heart transplant between 1994 and I think 2007 or 8 when Dr. Venugopal retired. 50 cardiac transplant was done, and the first transplant we went to Dr. Bajpai, Mr. Bajpai's house. They say we will award Dr. Venugopal Padma Bhushan. So we went to his house. He said, "This is your team?" He said, "Yes." So he congratulated all of us, and then that year, then he said, "This will be called as Organ Transplant Day." I think 3rd September. So August. So that is the how Indian Transplant Day, Organ Transplant Day. But the law was approved in 1995. So we must know, I was involved in 100 cases of cardiac transplant. I have to go to students.
We now move to a deeply meaningful segment, the inauguration of organ donation card. Organ donation is a gift of life, a noble act that continues to live on beyond one's lifetime. May I invite Professor Dr. Madhvanand Kar, Professor Dr. A.K. Mahapatra, Professor Dr. Digambar Behra, Lieutenant General Dr. Velu Nair, PVSM, AVSM, VSM, Professor Dr. Y.K. Chawla, Professor Dr. Y.K. Gupta, and Professor Dr. Rakesh Agrawal. A big round of applause, everybody. A big round of applause. May I now invite Dr. May I now invite Dr. Vikram Bhatti, Assistant Professor, Department CTVS, to kindly lead us in the organ donation pledge.
Thank you, ma'am. I request all dignitaries, seniors, and colleagues to please stand on their place and raise their hand for pledge. Kindly repeat after me. मैं आज एम भोपाल के इस पावन मंच पर पूरी चेतना और सेवा भाव के साथ यह प्रतिज्ञा करता हूं कि मैं मानवता के प्रति अपने उत्तरदायित्व को समझते हुए अपनी मृत्यु के पश्चात अपने अंगों और ऊतकों को दान करने का संकल्प लेता हूं। मैं यह समझता हूं कि मेरा यह निर्णय किसी जरूरतमंद व्यक्ति को नया जीवन दे सकता है और अंधेरे में डूबी आंखों को रोशनी प्रदान कर सकता है। मैं समाज में अंगदान से जुड़ी भ्रांतियों को दूर करने और लोगों को इस महादान के प्रति जागरूक करने का निरंतर प्रयास करूंगा। मैं अपने इस संकल्प के बारे में अपने परिवार और मित्रों को सूचित करूंगा ताकि समय आने पर मेरी इच्छा का सम्मान किया जा सके। अंगदान महादान। थैंक यू।
May I now invite Dr. Digambar Behra, President NAMS, to address the gathering.
A very good morning to all of you, ladies and gentlemen. Professor Mahapatra, the President of AIIMS Bhopal, Lieutenant General Nair, President-elect of National Academy of Medical Sciences, Professor Madhavanand Kaur, the Executive Director, cum CEO of this institute, the Honorable members of the Executive Council of National Academy of Medical Sciences, Professor Y.K. Gupta, Professor Rakesh Agarwal, Professor Ashok Kumar Gupta in absentia. I think he is going to join very soon. Then the chairperson of the National Task Force on Organ Transplantation, Professor Chawla, the ex-director of PGI Chandigarh, the resource persons for this disseminated workshop, and ladies and gentlemen. At the very outset, I am very thankful to the Director AIIMS Bhopal for organizing this nice workshop, dissemination workshop today. I'll just brief you about the academy. You know, you have already heard from Professor Mahapatra. The National Academy of Medical Sciences, in short NAMS, was established in the year 1961 by the Government of India to act as a think tank for policymakers in all spheres of health, including medical education, research, and cost effective healthcare delivery to help the national and international needs in particular and humanity in general. Like many other national and international academies of medicine, it holds a unique influential position at the intersection of science, policy, and public trust. As trusted voices in the country, its role is vital in guiding evidence based policy making and advancing public health principles and priorities. Some of the important and prominent activities of the Academy are promotion and support for continuing medical education, award of fellowships, memberships, etc., promotion of knowledge of biomedical sciences in India and its application to problems of national health and welfare, recognition of and encouragement of merit in all branches of biomedical and allied sciences. As part of many such areas of its activities, the Academy identified 18 important health issues of the country to start with and formed task forces with eminent experts in their respective fields, and the reports were published and submitted to the Government of India for further necessary action. The Executive Council of the NAMS further decided that some of these needs to be disseminated and spread out so that they reach to various medical colleges and institutions of this country. The current disseminated workshop and CME include organ transplantation in the country and the future and prospects of artificial intelligence in healthcare delivery in the country. Such dissemination workshops will be held at 6 different regions of India in partnership with important institutions like AIIMS that will include and cover different states and union territories of the country. As you all know, organ transplantation is an unmet need for the country. There is a huge requirement for organ and there is a widening gap between the requirement of organs and the transplants in patients with the end stage organ failure. Despite a well established law, deceased organ donation has not been picked up across the country except for states in the south and west because of the proactive action taken by individual state authorities along with non government bodies. There are also technical issues and a lack of expertise in adequate numbers, and in many institutions, it is not affordable. We need to plug this gap, and these issues need a wider discussion. Artificial intelligence, the another topic that has been chosen, that is an upcoming technology that is being claimed to change our future healthcare, including medical education and research. At the current time, its exact role is not fully understood, and many of the end users, that is, the medical professionals, are not fully literate about it, its utilities and drawbacks. We need to understand these issues fully. These two important areas chosen by the Academy for the workshop will help the participating institutions to go back and start working on these areas so that more colleges and hospitals start the transplant facilities in their areas. NAMS will act as a fulcrum for this network and will try to facilitate establishing these centers. Understanding the concept of AI will help in educating the faculty to become future ready. As you know, the organ transplantation is known to save lives. There is a huge unmet need for organs, as we said, and there is a widening gap, as I said. I am sure all these issues will be discussed in detail during the course of our deliberation. Then the what are the needs? I'm sure the chairman, Professor Chawla, is going to take care of all these issues. So, what, ladies and gentlemen, the purpose of this workshop, besides dissemination of these two important areas, I think the another important thrust that we'll be giving is to reach out to different institutions of the country. National Academy will like to reach out to each and every medical college, whether government or private, that is in the country, so that you become a part of these great institutions. Uh, as I'll invite you all, and I will urge all of you to become a part of this National Academy, be at its fellow or be at its member. We have got various facilities that to be included in the academy. That is, we award fellowships, associate fellowships, memberships, and associate memberships, etc. So that you contribute to this, the apex body of the country. So again, my appeal to all of you to please be part of this great organization. The second thing is, as I was telling you, we had requested this the director AIIMS of Bhopal to uh, invite and include people from 3 or 4 adjoining states, and for all the 6 regions that we are planning to have our this dissemination workshop, so that the entire 36 union territories and states of the country will be covered, and will be reaching out to these institutions and vice versa. So with these few words, ladies and gentlemen, I am again thankful to the director AIIMS Bhopal for kindly agreeing and helping us. I could see there is a huge gathering, and also this yesterday, the I think half a day, Professor Chawla and Dr. Bipin Kaushal, that actually Dr. Chawla is one of the important pioneers in the movement of organ transplantation. While he was the director of PGI Chandigarh, he had I think pushed the organ transplantation movement in the institute to a greater extent. Dr. Bipin Kaushal, who was the medical superintendent, he has also, pushed this transplant movement in the institution to a greater extent. So we tried, and again we are very happy. We are very happy to note that this institution, there is a very group of enthusiastic, the people of the all the disciplines, they are there, and they told us the various activities they are doing. We are really impressed that they had already done 3 heart transplants, and then the kidney transplants, and they are going to the other areas also. That is really very welcome step. And I think the obviously there is no need of every medical college should have an organ transplant, because that may not be possible, or that may not be needed, but that the experts will be discussing that part. But I think in a regional level, the areas should be identified, and then the country should move in that direction. So, ladies and gentlemen, besides these 18 task forces which are report prepared by NAMS, we are having created now 3 or 4 newer task forces, like particularly the One Health, then the climate and the air pollution. So these are some of the areas that we are also going to work on. And again, I will be at the end. I will request you all, please become a part and then try to contribute as much as possible to the academy. You can see that the academy is represented here in full force. Our next president and our senior members are here. Dr. Gupta, Dr. Agarwal, and Dr. Ashok Gupta, they are going to be present here. And then I am really very much thankful again to all of you that you have come here to listen to us and to know about these two topics that we have chosen. I think during the course of another thing which we have done now, we wanted actually to show you how the artificial intelligence is being really used in the field. We had requested I think one of the organizers from Odisha, actually they are doing good job. So we wanted to see, they have requested us to become their knowledge partner. So I think we have given him the Professor Kaur has given him a slot. So he is going to show us how actually the artificial intelligence is being used in the field, what they are doing. So that we will see, so that we become a part with that and a practical application of artificial intelligence. I think Mr. Bhagat and his team are here, so they will show us how they are really using it in the field. So with these few words, ladies and gentlemen, thank you very much, and I wish this workshop and the CME becomes a great success. Thank you and Jai Hind.
Without any further delay, we'll start the scientific program. And as sir has told that the two topics are organ donation and transplantation and artificial intelligence. We have resource persons not only from NAMS but all over the country and participants from the 4 states, sir. And we also have experts from DBT and IITs for the artificial intelligence section. So we'll start the CME. The first I invite Dr. Sunaina Tejpal because Dr. Ketan Mehra had some family issues, urgent issues, so he had to leave yesterday. So I request Dr. Sunaina Tejpal and the chairpersons, Professor Dr. Rehanul Haq, Dean Research, AIIMS Bhopal, Professor Dr. Kavita N. Singh, Dean Gandhi Medical College Bhopal, and Professor Dr. Satya Ranjan Patra, Professor and Head of Surgery, AIIMS Devghar, to chair the sessions.
A very good morning to all of you. To straight away go with the first scientific session. Our speaker is Dr. Sunaina. She's going to speak on disease burden and status of organ donation and transplantation. And disease burden, Dr. Sunaina, would we all agree that it gives us an idea of the gap between the existing current scenario and what is the ideal, and to understand that gap, how we can cope up and make our policies and interventions, innovations to take care of the problem. So over to you, Dr. Sunaina.
A very good morning. Thank you, dear chairpersons. A very warm welcome to all the dignitaries present here. It is a proud privilege to present this first talk. So what I'll be stressing on is the zonal overview. What is the status of organ donation and transplantation in our zone? I'll do it from here. So when we look, before we move on to the zone, let us look at the national data. If we look in the last decade, the graph is slowly going up. So we are improving, we are getting there, but we are still far short of the capacity building needed, of the actual number of organs needed from the deceased donors. So we have reached, in 2024, we have had a 16% increase in the last year as compared to 2023, which is remarkable, but still we are not there yet. If we look at the state-wise data, we see that South leads and Maharashtra is third. We have 172 deceased donors, and we, as the heart of the nation, Madhya Pradesh, are somewhere far behind. And in fact, states like Rajasthan and Orissa are doing better than us. So this is a moment to reflect where we are going, why we are lacking, and to think on this. If we go on to Maharashtra, Maharashtra is the nerve center of transplantation in this zone. So it was the Roto West Coordinates Transplant Governance across the Western Zone was established in 2017 with the office located in KEM, Mumbai. So it is under the aegis of NOTO, and it corely functions to maintain the transplant registry, promote transplantation, monitor and do surveillance of the transplantation. The various areas which come under its jurisdiction are Maharashtra, Chhattisgarh, Goa, Gujarat, Madhya Pradesh, and the Union Territory of Daman and Diu. Here, Mumbai functions as the regional coordination anchor for the entire Western Zone. We all are aware of the governance architecture. We have the NOTO, then the ROTO, the SOTO, and the Zonal Transplant Coordination Centers. From the National Organ and Tissue Transplant Organization, we have the ROTO in Mumbai, which caters to these places. Maharashtra is the only state in the zone which has a multi-city zonal coordination center. So this substructure with having 4 areas identified as Mumbai, Pune, Aurangabad, now known as Sambhajinagar and Nagpur, it helps in improving the governance. Maybe that is one of the reasons Maharashtra is doing so well. So this is the organizational flow chart with their websites displayed. If we look at the data of 2023, in Maharashtra, a total of 419 organs were retrieved. 236 donors were identified. Pune led in the retrieval of organs, followed by Mumbai, Nagpur, and Aurangabad did a decent job. So kidney and liver formed the largest share of the retrievals done for the organs. If we look at what translated into the number of transplants, 426 organs were transplanted in a total of 410 recipients. And the leading center in transplant was Mumbai. Most transplanted organ again was kidney. So we see that mostly the transplant activity is coordinated in the zonal transplant coordination centers. 2023 also reflected that advanced procedures were done. The data reflects that there was a good interstate sharing. Organs were received from outside of Maharashtra. And what is beautiful is that they have done an audit of the organs wasted, which is very important, because if organs are taken and not transplanted, then what is going wrong? Is it the management of the deceased donor? Is it the transport? Or maybe the organ were not good enough? So it is the screening. So that is something we have to take and learn from these centers, which are doing very well. If you look at the organ retrieval data of 2024, it increased 14%, a good number. 477 organs were retrieved. Again, Pune led, followed, and a new center joined, which was Sambhajinagar. But the transplant volumes, as compared to 14% organ retrievals, there was a 10% increase in transplants over 2023. Again, this points towards maybe organs were wasted. So Pune overtook Mumbai as the leading transplant center in 2024. There were a lot of procedural advances. A major landmark is that there was one donation after cardiac death, which was recorded. This was done in Nagpur and from 2 donors. So this is something we have to really think on. Maybe in the act also, there are some gray areas regarding this. That is something the organizations can work on and guide us about. Again, auditing the organ wastage, there were 4 organs which were wasted. It happens in real world, this happens. But what is important is that there is data to reflect this and what is going on where, which is very important. So the disease donor transplant activity remained high across 2023-2025. And 2025, if we look at this, the most consistently top organ transplanted was the kidney. Coming on to the heart of India, Madhya Pradesh, we have had a gradual rise in cadaveric donations, but we contribute only 2%. We are practicing green corridors, air ambulance, transport systems are being mobilized, and till now, private sector ruled the transplants. Now, government sector with institutes like AIIMS Bhopal, GMC Bhopal, they are also getting in the area of transplant. We have shown consistent year-on-year growth, which is driven mostly by the living kidney donations. And disease donations is small, though it is growing. So what we have to work on is maybe tapping this source, that where we can improve, for which we seek your guidance. These are the total organ donations year-wise. The kidney donations have increased, but the ones in blue are live. The one in yellow are cadaveric, which are still lagging far behind. Liver donations Again, life-related are more as compared to deceased. Heart, lung, and hand donations, very few numbers. If we go on to Chhattisgarh, the SOTO Chhattisgarh was established in 2021. They have the Nodal Institute in DRS Super Specialty Hospital, Raipur. Permission has been given to 25 centers for transplant, but the centers actively doing donations are only 5. This is something to reflect on. Main organs, again, which are being reflected are kidney and liver, which is emerging. What is also important is to state that how many applications have come. There have been a total of 221 applications, 32 transplants have been completed, 34 tissues organ donations have been received. So though they have the structures, but the scale of activity is still needs improvement. A lot of hospitals are doing kidney transplants, followed by cornea, heart, skin, liver, limb, and tissue. So there is a lot of scope for development of infrastructure. If we look at the organ-wise applications received, we see that most transplants have been done for kidneys and livers, though donations were received for skin, cornea, heart walls, and liver. So if we look at the year-wise transplant activity, we see that we have hovered somewhere around 88 per year total. And the dominant procedure again is the live-related kidney transplantation. Liver transplantation is emerging. Moving on to Jharkhand. The diseased donor organ transplantation is emerging there. Transplant activity is mainly restricted to living donor kidney transplants. The SOTO is functional, but we were not able to gather much data from the SOTO. These news articles highlight that Jharkhand is taking its first step or is embarking on the journey for transplantation. So they are set to launch liver and kidney transplants soon. The kidney transplants have been approved. So Jharkhand has approved kidney and liver transplant programs. Maybe the data will be available once the volume scales up. So the key takeaway from this zonal overview is we have a good governance in Maharashtra. They have a mature ROTO, SOTO. They have 4 zonal transplant coordination centers. Madhya Pradesh SOTO is established. It is active. Chhattisgarh SOTO is maturing. Jharkhand SOTO has been established. The data is yet to come. We have had good volumes in Maharashtra, from which we should learn as a center which wants to proceed in this direction. The achievement of Maharashtra is that they have done complicated, complex procedures. They have had donation after circulatory death. We are having consistent year-on-year growth. And Chhattisgarh also has a liver program which has started up. So overall, I think that this is something where we need expert guidance from all the dignitaries present here, how we can improve, how the organizational structures can improve, what to do about the diseased organ donations, how we can get more organs, motivate more people to donate. So that is something which is open for questions. Thank you.
Thank you, Dr. Sunaina. As we all saw from this presentation, roughly for every 200 transplants that are needed, we are able to do only 30. It comes to almost 1/8 only. And as we can see that the 2 leading centers are Mumbai and Pune. So we can say that for not only the people who need transplant, they are being left because there are not many centers who are doing it. So there is a big gap between the centers who are providing the transplant, and there is a big gap, even the centers who are providing the transplant, whether they are receiving the donors or not. So it's a good eye opener, and I think the policy decisions will be taken as to most states get involved in it, and not just a couple of states with that 2 epic centers are doing that. Thank you, ma'am. Thank you again.
We will have the final concluding remarks from Kavita ma'am and then move on to the next session.
Thank you, Dr. Sunaina. And as I'm representing state as a Dean and CEO of Medical College of Capital, Bhopal, Gandhi Medical College, I would like to share with all the legends and dignitaries who have come across from the nation that we started and we are gradually picking up, especially Jabalpur, Indore, Bhopal Medical Colleges along with AIIMS. So there's a lot to go ahead as far as the burden is concerned. It is really worrisome. But at the same time, as a sitting on the policy side, I would request all the post holders and seniors to share with the policymakers that there should be swift moving of the movement of the files, because just I'll share one comment which I received on my WhatsApp 2 days ago, which is by one of the patients who has shared one news cutting, लीवर ट्रांसप्लांट की जटिल प्रक्रियाओं के बीच बुझी एक जिंदगी, व्यवस्था की संवेदनहीनता पर उठे सवाल. And this lady has sent me an SMS that due to delay in paper forwarding in Telangana, her husband, their relative couldn't get the transplant done. Madam, thank you so much for your response, because they wanted NOC from here, so which was very swift. But in spite of that, 1.5 months was just went off and they lost the patient. So there are so many issues to be discussed apart from transplant and organ donation, and how to make the things very easy, because there is a huge burden and there is a lot to be done. I'm so thankful to the organizers, Dr. Das, Dr. Mahapatra, Dr. Kar, and organizing team for inviting me. There are so many nominated experts from my college as well. So thank you so much for the invitation. Thank you. Questions will be taken later on. Our next
Organ transplantation, donation and transplantation.
Our next presentation is the keynote address on Task Force Recommendation, Organ Donation and Transplantation in India. Our keynote speaker is a true stalwart of Indian medicine, Professor Dr. Yogesh Chawla, a recipient of Dr. B.C. Rai Award in 1999 and Padma Shri 2015. Dr. Chawla is a world-renowned hepatologist and former director of PGI MER Chandigarh. As the chairman of the NAMS task force, he has been the primary architect of the policy we are discussing today. For the chairpersons, it is a rare privilege to have this session presided over by two of the most influential figures in Indian medical academia. We are honored to be joined by Professor Dr. Digambar Behera, a 2020 Padma Shri recipient whose leadership at NAMS continues to set the national standard for research integrity. Alongside, we also welcome Professor Dr. Madhanand Kar, the Executive Director and CEO of AIIMS Bhopal, a visionary surgical oncologist whose administrative and clinical acumen is transforming this institute into a global center of medical excellence. May I request our esteemed chairpersons, Professor Dr. Digambar Behera and Professor Dr. Madhanand Kar, to kindly take the dais, and also request our speaker, Professor Dr. Yogesh Chawla, sir, to please take the podium.
So thank you. I think it is as Professor Chawla has already been introduced. He was the chairman of our task force on organ donation, and he's a, as I told during my inaugural address, so he's a pioneer in the field of organ transplant movement in the PGI Chandigarh, and he himself is a renowned hepatologist. And with the team, I'm sure he's going to introduce his team of experts. So that is the, and I think the without any further delay, we request you to start your lecture, sir.
Thank you, Dr. Digambar. Thank you, Professor Kar. It's a pleasure to come to this state. My disclosure in the beginning would be that I belong to Jabalpur. I did my MBBS and MD from Jabalpur before I moved to All India Institute. Did my DM in gastroenterology there and then shifted to PGI Chandigarh. And when I took over as the director of the institute in 2011, I felt that the patients with liver disease, end-stage liver disease, we could do very little for them. Plus, I had information from other departments that we need to promote organ donation. And that became a motto for us and our team in PGI Chandigarh. And we could achieve very good results over the period. So I want All India Institute Bhopal and the other medical colleges that are attached in this region to be very passionate about organ donation, because you would be serving a lot of patients, and that is something very important. So the National Academy made a group of persons who were involved with organ donation in their different subjects. We had Dr. S.K. Mathur from Bombay, Balakrishnan, who's a cardiac surgeon, Anil Kumar from Noto, Nitin Agarwal, Vivek Kute for renal transplants, Harsha Johari, he's in Gangaram, again very active in organ donations, Anita Panda, a corneal transplant surgeon, Sunil Shroff, he runs an NGO known as Mohan Foundation. Rajneesh Sahai was the Director General of Health that time. And we have Vipin Kaushal and Vijay Tadia. Vipin Kaushal and his team, who were looking after the medical superintendent aspect, they made things very streamlined. And that is how we could have a good organ donation program at PGI. We also had a neurosurgeon. So I would request the institutes who are participating here that not only you could have an active medical superintendent office, which will help you in getting the organ donations done with all the breaks that come in between, but a neurosurgeon is absolutely important and a critical care person. So the National Academy wanted us to come out with a white paper, and we did come out with it in 2023. We know that organ transplantation saves lives, and we just heard and we are all familiar that patients with end-stage liver disease, we cannot do much except for doing a transplantation, and that is an unmet need. While live-related transplants are well established in the country, the cadaveric donations, they are picking up. And we've seen the graph which Madam just showed. Some states like Tamil Nadu, Telangana, and Karnataka, these states have been very, very active. And this is all through the authorities which have given the promotion for organ donation and the NGOs who work very hard. By doing a transplantation, you give a person a chance to live and contribute to the society. So the organs that are donated ultimately become a national asset, and that is what we should work for. India has made meaningful progress in organ transplantation, but there are a lot of systemic gaps. And as was said earlier, the program of organ donation, of organ retrieval, storage, and transplantation for therapeutic purposes was started after the passage of the Transplantation of Human Organs and Tissues Act in 1994. And it has since then been adopted by all states except for Andhra Pradesh and Karnataka, which have their own separate legislation, but they are doing extremely well. The National Organ Transplant Program, also started by the Government of India in 2011, which looks after the organizational and financial framework for promoting organ donation. And that is in 2023 where the National Academy came out with the task force message. One of the government reports says that about 1.75 lakh individuals require a kidney transplant, and 50,000 require a liver, heart, and lung transplant, and pancreas in about 2,500. In India, the organ donation rate is less than 1 per million population. And for us to give benefit to all these patients with end-stage disease, we would require about 124 donations per million. So there's a huge gap. What we are actually doing now and the requirement is huge. In India, mostly it's the living related donors which are the primary source for kidney and liver. But we need to realize that there is an element of potential exploitation, and there are health related complications that happen in living donors, which are now coming up in the open, but we all need to be aware. Hence, the importance of doing cadaveric donation is absolutely important. This can be done because we know that almost 2 lakh fatal road accidents happen every year. And mostly this is because of associated head injuries. We can have good donors from cerebrovascular accidents, and these occur in ranges of 44 to 150 per 1 lakh population, with a fatality rate of 18 to 48%. So as I mentioned previously, the organ donation rate in India is less than 1 per million. And if you compare it with Spain, it is 48 per million of the population. So there's a huge gap. And even in USA, it is 35 to 40 patients per million. Unfortunately, for patients who can afford, most of the transplants are happening in the private health setup. And this is cost prohibitive, but we need to reverse this trend and make the public sector hospitals attracted for doing different donations. When you look at the donation rate in 2021, 171 donations happened in a public setup and 521 donations happened in a private setup. So you can see the difference. If you look at the living donations, 827 happened in the public and more than 6,000 happened in the private. And when you actually look at the willingness to donate, this is a paper published some time back, almost 74% of the individuals who were surveyed were willing to donate. Noto, that came out in 2011 and 2012, you have the National Organ Transplant Tissue Organization, 5 rotos distributed in the country, and sotos which look after the states. There are 25 of them. And under them, they have a total of more than 1,000 hospitals, of which 707 transplant centers have been given the clearance. There are 146 centers for retrieval of organs. So we need and these organizations, they integrate the efforts of state institutions, healthcare professionals, NGOs with standard operating procedures and organ allocation policies. And this is what was just shown. You have 5 different rotos and the states that come under them. Again, this is what was earlier shown, that of the 707 organ transplant centers, private centers were much more as compared to the government centers for all the organs that were transplanted: kidney, liver, heart, lung, pancreas, and intestine. Even the organ retrieval centers, which are just 146 in number, it was the private center which was contributing more as compared to the public sector. There are some states where no disease donation is happening, and these are mainly the northeast states. J&K also has not picked up. Ladakh hasn't, except for a few cases. Uttarakhand, Jharkhand, and the other smaller places have yet to start, but you would realize that in the dark green, the map of the country, the donations are much more in the south and the west as compared to what we have in the north. And this is some statistics in 2024. You need not go through it, but just to say that living donors are much more than the cadaveric donors. And this is the graph indicating, which Madam showed, that it is increasing. The donations are increasing of cadavers, but we are still far behind our requirements. And this is with the states. Chandigarh at one time had about 50 donations as a single institute in the year, in 1 year. And this was comparable that time to the Tamil Nadu's contribution of the entire state. So Vipin has been getting the awards from the Government of India for one institute that still continues to have the highest number of cadaveric donations. And I want All India Institute Bhopal and the other medical colleges that are associated to tighten their boots and go in for organ donations. You have heart transplantation being mostly done in the south, very few in the north, and same is true for lung transplantation. But here again, I would say that PGI, because of the organ donation, has the highest number of kidney and pancreas transplantation in the country. And that was only because of the organ donations that we did. This is extremely helpful for patients with kidney disease and those who have diabetes. And if in the clinic, you would see a lot of number of patients coming to us. So India, if you look at the statistics, it's the third country after US and China in the total number of transplants. Certainly there has been an increase in transplants from almost 5,000 in 2013 to almost 19,000 in 2023. The infrastructure has improved, but the growth has been mainly in the private healthcare, and the extremely low disease donation rate has also compounded by the missed opportunities and solutions which we have not been able to sort out. And this again was highlighted in the last talk. So we have a lot of deficiencies, and all these need to be corrected. Firstly, there is reluctance from the relatives for giving a donor. They feel that body disfigurement is an important contribution, and some of these people back out when they are given a chance for organ donation. Something which we realized in the institute was that the definition of brainstem death way back in 2011 wasn't very clear to a lot of doctors within our own institute, and we took it upon us to have repeated workshops on the definition of brainstem death so that all the doctors are aware of it, all the nurses are aware of it, and they contribute to the organ donation. We also made it compulsory for brainstem death to be reported to the higher authorities, and we took personal interest. Every 2 weeks, we used to have a meeting after 5 o'clock for 2 hours, taking the accountability of the critical care people and neurosurgeons. How many deaths happened in your units, and how many could you declare as brain death? And did you get a chance to convert them into organ donation? For the first 3 months, we had difficulty, but after 3 months, there was no looking back. It was a success story for us. But one of the problems is that the declaration of BSD, brainstem death, should be made compulsory. The ICUs lack protocol and trained personnel, and the hospital staff in medical colleges, district hospitals with ICUs should be trained for end-of-life care and about brainstem death. There are, of course, regional disparities. South is much better than the north, and only a few hospitals participate in organ donation. There should be a hub and spoke pattern. One should register all trauma centers and medical colleges for donation. We should formulate SOPs for manpower and equipment which is required, which are now there. The monthly activities of Noto, Soto, and Roto should be notified on the websites, and information on workshops should be updated. Dr. Sonal Asthana, he repeatedly has cadaveric donation programs, and I think you've had a very good response from people who want to learn about it. And so also his team has been doing fellowship courses for people who want to learn transplant. Of course, MCH is a separate ballgame which would come up very soon at a few centers, but fellowships is another good way of training surgeons in their respective fields for organ transplantation. So monthly death audits should be done for brainstem death by Soto. I don't know whether the Soto of this region does that, but certainly it's our own responsibility that you have to push that they should do it for all the medical colleges in the region. Organ preservation facilities also need to be upgraded. You need to have a license every 5 years for retrieval as well as for organ transplantation. And if you want to get recognition, then this is one factor which will give you a lot of recognition. So organ donation should be, and transplant should be a quality metric for any hospital. And when you do a recertification for transplant, you should find out whether enough organ donations have been done by the institute or not. One thing that we are lacking, and which always becomes a success story, especially it happened in PGI, that a transplant coordinator is absolutely important. We have about 5 to 6 transplant coordinators in PGI who are totally devoted to this. Apollo has possibly just one of them, but certainly the government helps you in getting transplant coordinators with a monthly pay of 35,000 or slightly more. So the government helps you that, and I would suggest that all the medical colleges, if they want to do donations or transplant in the future, they should have transplant coordinators. There should be SOPs for organ donation pathways. And one of the most important friend that you should have when you want to do organ donation is involve the police, because most of the road accidents would be medical legal issues, and this always delays organ donation. So again, I would compliment Vipin Kaushal that he was instrumental in being very friendly to all the police people in the different states surrounding Chandigarh, and barring a few cases, we could manage to get the organ donation. And there should be awareness programs with the police, and the procedure for medical legal issues should be streamlined and SOPs made. All units, all India institutes should have an organ transplant unit, as you have one over here. And all medical colleges should have retrieval centers. This should be made compulsory. The state government should be very active to identify medical college for multi-organ transplantation. An advanced transplant center should happen in all INIs. These INIs should have individual organ subdivisions, like we saw the cardiac transplant here in CTVS, and the renal transplant in the urology department. So like this for lung, for liver, there should be respective individual subdivisions. There is a suggestion that there should be a common ICU for transplants. We always fight for individual transplant ICUs. That probably may not be very cost effective, but you would save a lot of money if you have a common ICU. Recruit only those people who have a passion for organ donation. And there should be organ transplant fellowships, which Dr. Sonal would talk about it, and there are enough of them. You should train consultants, improve the trauma centers, and build a pool of transplant surgeons for capacity building. I'm not very sure whether there is a curriculum for organ donation and transplantation in MBBS or in MD. Anyone aware, people? Is it there? 3 talks in MBBS. Certainly, this should be improved, and more information should be given to the MBBS students and MDMS. The Prime Minister, when he spoke in Man Ki Baat some time back, that boosted the organ donation program. But for it to be very successful, there should be public awareness, social media should be very active, walkathon, festival celebrations. There should be incentives for organ donation. At our own institute, the family members of people who were making public awareness, again, Vipin Kaushal, Rajesh Chabra, neurosurgeon, their entire family got involved in promoting public awareness. Their children got involved, speaking in different schools, speaking to different colleges. So that should be the spirit if you actually want to do organ donation and have more and more public awareness. The Times of India used to carry about organ donation some time back, but I haven't seen it for quite some time. But the Hindi newspapers, local, they should always every week come out with positive stories of transplant. I wonder if they have come out with the 3 cardiac transplants that have happened. But these positive news should be given by these press. There should be tree plantation ceremony, and we at PGI have been holding the transplant games and giving awards and getting celebrities associated with it. There are financial barriers. Ayushman needs to increase the number of the money given for doing transplants. We should actively involve the CSR. You have Infosys, Aziz Premji, and the Ambani Group. If you approach them, possibly they might help you in some amount of money for transplant things. Again, Dr. Sonal Asthana has worked on crowdfunding. Yesterday we were saying that we don't have enough funds. Possibly you can elaborate it on the open discussion session, how you have succeeded in doing crowdfunding and managed your poor patients. And the insurance needs to increase, if at all, for transplant. Recently, some changes have happened from the government side. They've made a one nation, one policy reform so that the condition of state domicile has been removed. The upper age limit for recipients has been removed. There is no fee for registration because earlier on, going to different states, you had to give a registration fee. Round the clock postmortem has been made compulsory for patients who are willing for organ donation. We should have a seamless transport of organs, green corridors, uniform national policy among states. There is no screening of organs at airport or metros. And again, Aadhaar-based digital portal and QR code for pledge has been started in the country. Tele-ICU can be another factor as well as AI in monitoring the cadaveric donation from the experts for the affected hospital. So friends, this is all what we had mentioned in the task force. You've been given the copies of the NAMS task force. I want you to go through them, and if you have any questions, we can have those questions put up in the open discussion later in the day. So thank you all, and thanks NAMS for giving us a chance to come up with this white paper.
Thank you, sir. It's a very comprehensive and like outlook for everyone. They will take it, and a lot of discussion can be done. But we will go simultaneously all presentations. Then we will have a discussion, sir. and your visionary steps, how all these things were taken. In the future, we also take, also in this institute also, how we'll streamline more things here. And now the college next sessions, we will discuss all these things as individual things. Thank you so much, sir. Thank you.
Thank you so much, sir, for such insightful session. And we are obliged by the presence of our esteemed chairpersons. Thank you so much. Now, as we move towards the pivotal segment of this CME, expanding organ transportation, expanding organ transplantation capacity in India, policy, infrastructure, and clinical advances. Under this, we'll be having 3 sessions. For chairing this series of session, I would like to invite Professor Dr. Rajesh Malik, Professor and Head, Radio Diagnosis and Imaging, AIIMS Bhopal, Professor Dr. Vikas Gupta, Medical Superintendent, AIIMS Bhopal, Professor Dr. Saurabh Jain, Associate Professor, Department of Urology, GMC Bhopal, Dr. Devashish Kaushal, Additional Professor, Department of Urology, AIIMS Bhopal. The first session under the segment.
Hello. This session was supposed to be given by Dr. Arvind, who is not with us. Dr. Pranjal Modi also is not available. So apologies for this, but we'll now be starting with the next session, and it's my privilege to introduce the next speaker. He's a legendary hemato-oncologist with over 36 years of dedicated service. None other than General Nair, who has served as the Director General Medical Services, where he steered the entire medical corps with visionary leadership. For his exceptional devotion to duty and distinguished service, he has been decorated by the President of India with the Param Vishisht Seva Medal, the Ati Vishisht Seva Medal, and the Vishisht Seva Medal. Beyond his military command, he's a pioneer who has been instrumental in establishing high-end bone marrow and stem cell transplant centers across the country. I also had the privilege of being with him last evening, and he's a fantastic gentleman. Looking forward to hearing from you, sir.
Hello. हेलो हेलो सर इससे हैमिंग आता है हेलो चेक हेलो
सर ये नहीं मैं इधर से करूंगा इधर से है ना वो कर्सर लगा दो बस कर्सर लेजर कर्सर राइट क्लिक हाँ बस 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 very good morning to one and all here. And thank you for those kind words, sir, the chairpersons. I'm delighted to be here in AIIMS Bhopal. I came here in 2013. I was that time serving in the army. And I remember Professor Sandeep was the director. And we had one of the first CMEs here. It's a pleasure to be back after a long time. We are the odd one out. We are talking of solid organ transplants, but I'm going to talk on bone marrow transplants. So it's a little, the odd one out. I would just say that this is the only transplant where you don't lose an organ, whether it's a live donor or otherwise, but you don't lose an organ because the stem cells are formed in days to weeks, whatever you harvest. Okay, and the nomenclatures have been traditionally called bone marrow transplant. But today, contemporary, it's called as HCT. which stands for hematopoietic cell transplantation. So bone marrow transplantation, to put it simply, a defective marrow because of leukemia or genetic disorder is replaced by a healthy marrow taken from another donor or self. And I'll tell you those two situations. So if you see on your left is the autologous transplant with the patient is the donor himself or herself. Lymphoma, failed chemotherapy, immunotherapy. So you want to give much higher doses, but you will ablate the bone marrow. So you take out the bone marrow, store it, try to ablate the lymphoma and reinfuse the stem cells. Likewise, in allogenic is from a healthy HLA matched donor. Okay, there's a big difference between solid organ transplantation and bone marrow transplantation. And the biggest difference is in solid organ transplantation, the immune system is intact. So whatever organ you put in, let's take the kidney, it's likely to be rejected. So the immune system has to be suppressed long term. So the long term, lifelong immunosuppression with its inherent problems. While in bone marrow transplantation, you change the immune system. The immune system comes from the donor graft. And in 6 months to 1 year, they develop the magical thing called tolerance. And once you have tolerance, you stop the immunosuppressions. So immunosuppression is finite. It's just for 3 months to actually about 9 months nowadays. What is the need for BMT? Today it's a day of war all over the world. So in Second World War, Hiroshima, Nagasaki occurred, and the biggest culprit to kill people was bone marrow ablation because of radiation. All tissues which multiply fast are knocked off first. So whether it's the gut, whether it's the skin, whether it's the hair, whether it's the bone marrow, okay? So there was a need for BMTs. And if you see the world today, the nuclear states, you just see this around us. There are about 9 nuclear states and most of them are in Asia. And we are surrounded and we ourselves are a nuclear state. So this is the real danger, by the way. And the nuclear reactors, especially in the developing world, was not safe. Chernobyl, everybody knows his history in the erstwhile USSR. A lot of people died because of a bad design of the nuclear reactor. There was a leak. In India, we have 22 reactors. So obviously, we have to be ready for any nuclear leak. And for that, the medical fraternity has to be ready. And Asia Pacific Bone Marrow Transplant Registry was alive to this when a Fukushima occurred in Japan in the tsunami. And when that occurred, there were a lot of deaths. So we have 23 countries in the Asia Pacific Bone Marrow Transplant Group, which works out of Tokyo. And I had the pleasure and this thing to chair the Nuclear Accident Management Committee because of the army background which I come from, where we had done a lot of work on this nuclear front. So we made the guidelines which have been adopted by 23 countries. It's a free download on their website. So the history after the Second World War, we dabbed with various combinations, but ultimately in the 70s, BMT took off. In India, in 83 in TMH, and after that, many more centers followed. What are the indications? Expanding all the time. Cancers, genetic disorders, immune deficiency, you name it and you got it. And you can actually do transplant when all conventional treatment forms have failed. Okay, so how many transplants are performed worldwide? If you see here, you will see that the allogenic transplant, the red curves, is in the US about 10,000 and the autologous is nearly 12. So more than 22,000 transplants in a year in the US, which is a reasonably big number. While in our country, if you see the number of centers, this is the ISBMT, is the Indian Society for Blood and Marrow Transplantation. We formed this just some years ago, and you'll see in the first, up to about 2000, we only had about 10 or 12 centers. But then there's been a linear increase and there's been a surge in the last decade and a half. And you can see we got about 167 centers, but a huge supply-demand imbalance even now. And this is the data from the registry. Without data, you can't analyze, you can't progress, you can't actually ask the government for anything. You must have data. So the data here shows that the autologous in red is, you can see, smaller in number. Per year, we are doing about 1,500, and allogenic, the blue, is over 2,000. And total transplants about 35,000, but from what period? 83 to now. And if you see here, one thing I want to drive home is we don't have a good registry, because unlike solid organs, you can be a voluntary donor and lose nothing. So the world over there, over 40 million donors, but in India we have 6 or 7 lakhs. So there's a huge gap. This is where we have to work. And you'll see, but in the last 12 years, we have found that there's a ready donor in the family all the time. That's called a haplo donor. You just need a 50% match. So we used to think you need a 100% match. No, 50% match. So every parent and every child is a donor to each other. So within the family, you may find 80% chance of finding a donor. So India has actually grabbed this opportunity and we are moving ahead. And you see the blue graph, how the haplo is taken off. India is one of the largest centers of haplo transplants. Nearly 1,000 is being done every year. While the registry one is the red one, less than 200 in a year, which is dismal actually. And the risk is also there for haplos because it's mismatched. You have a 15 to 25% chance of rejection. So this is the unmet need where we have to work on how to prevent this. While in a fully matched, it's less than 5% chance of rejection. If you see this registry data, pediatrics forms a part of it, but adult forms the chunk of it. Nearly 20,000 of these transplants are in adults. Okay, now what are the problems and challenges? Firstly, it's a complex capital and labor intensive procedure. One transplant per month per bed. So if you have 3 beds, max 3 transplants. Average, I'm saying. So obviously, in a year, you'll end up doing 36 or 40 transplants. And there's a huge supply-demand imbalance. The cost is a limitation, limits the accessibility for poor people, and donor availability is itself now improved with haplotransplant, otherwise was an issue. The donor registry in our country needs to be driven, and our trained manpower, we are on the job, but lots to be done here. And the last 3, I think, for example, I'm very happy that Dr. Gaurav here in this center, in a short time, has done 18 transplants and 3 haplos. Fantastic. So these are the type of young people driven by passion who need full support. That can be louder, I say. Yeah, it's not easy. It's not easy in a government hospital. I've served nearly 39, 40 years in the armed forces. It is not easy. And Dr. Avnish is here. It takes your lifetime work to drive it. So you bring your passion to the stage and do whatever you can, but drive it. And get the system to support you. Get the celebrities on the stage so that, they take notice of you. But well done, Dr. Gaurav, and that's the way to go. The problem challenge in our country is always infections. But peculiar to us is viruses and fungus are our biggest enemies. You name the virus and we've had it. So we are more of ID specialists to make our outcomes better. For that, we need a good antimicrobial stewardship program, which is, again, an unmet need, which NAMS has actually got a task force, and we are working with the ICMR, and we actually have to carry this forward. The other thing is, to have enough clinical trials, collaboration, and capacity building. And for this, you can't move forward without political and government involvement. Why do I say this? 75% of the transplants are done in the private sector out of the pocket expenses. But here, health is a state subject. So a Gujarat state gives 5 lakhs per transplant, but some states are giving 50,000. So it's heterogeneous. So the government has to step in, top-down approach to make this possible. And we must cut across the geographic barriers. The tier 2 and 3 cities must be empowered to do. We must get the facilities going here. And this is a typical transplant unit in Apollo, Ahmedabad, where I work. You have HEPA filtered rooms. It's like an ICU. You must have cryopreservation facilities. And you must have a irrigator. India makes it now. BARC was making it. Otherwise, it costs about 30 lakhs. It's available for much cheaper now. All blood products must be irradiated. It's very good practice because the passenger lymphocytes, even in solid organ transplants, can create a lot of problems. Transfusion associated GVHD is a killer. 80% aplasia of the bone marrow. So just irradiation will prevent it. So this is the one big take-home message today. And the family donations are the worst. In Bollywood, it is good, but actually it is the worst. A son, a cousin, a family, not the best. Without irradiation, it's a no, no, no. Supportive care takes a chunk of the money. Complications which have to be met with, I'm not going to the details, but we have our share of complications. And this cost is the biggest barrier. So a few words on the cost. I will tell you what is the average cost. This is what it costs in the private sector. In the good centers, it can go 30% more otherwise. Autologous 8 to 10 usually, allogenic 15 to 20, and a haplo can go up to 30 lakhs. This has to be brought down by nearly 50%, if not more. Insurance companies are not taking it up. So we need governmental political involvement to bridge this gap of cost, which I think is where the major work remains. And that's where people like our AIIMS, our chain, the leadership has to take this up. And the skilled workforce must be retained. In the private sector, there's poaching. In government sectors, they are retained. And you must create awareness and appropriate system, patient selection. Informed consent and fertility are neglected fields. They all become infertile after transplant. So fertility preservation is a big area today because many people are in the teenage and young age where they still need to have a family. And the donor availability has to be increased. HLA was done by antigen, methods before. Today we do it by alleles, and if you have a good registry, 70% chance of finding a donor. Within haplos, 80 to 90% chance of finding a donor. Okay, and today we do allele matching 10 out of 10 or 12 out of 10 to do a transplant. And this are the registries available in India. There are 4 or 5, but Datri is the premier one in Chennai, where also we only have about 6 lakh donors registered. Worldwide, bone marrow registry worldwide, 42 million donors. And you see the contribution of Asia and Africa is very poor. You see the West, they have much higher contributions and much smaller population, you see. So ISBMT is a society which we have created over the last a decade or so, and with this we have got a lot of data, collaboration and trials taking place. And I'm proud to say that we have now got the guidelines which we got it released by the ICMR. I had the pleasure to chair this. We had a lot of private and public participation in the formulation of this, and we also made the standards for accreditation, which we never had. So NABH and QA have brought this out, and the recent advances are what I told you. I'm not going to repeat this. So this is my last slide. India has come a long way. Long way, from 10 centers to nearly 170 centers. And we have a registry which is expanding. We have the guidelines, we have the accreditation standards. And I think what we need is to take our passion forward, get the government involved, get the political backing, get the CSRs going, but we need funding. And without that, we can't move forward. And I'm sure that message goes through. There are ways and means to do it. Professor Chawla told you also, the big business houses can come through, and various CSR activities also can be tapped, but we must get them going. So with that, I would say thank you for a patient listening. Jai Hind, thank you very much.
Thank you, sir, for such a meaningful session. Dr. Gaurav has the will and the wisdom to take things forward under your guidance. For sure, the cost needs to be, looked into, and the government and the political will has to be there. Thank you so much, sir.
Thank you, sir. Next in line, we have Dr. Colonel Avnish says. Sir is a veteran of the Armed Forces Medical Services. Colonel Seth is a distinguished honoree of the Visis Seva Medal conferred by the President of India in recognition of service of a high order. His clinical legacy is marked by a monumental milestone. That is, he established the first successful liver transplant program in an Indian government hospital at the Army Hospital, R&R, that is the Research and Referral Center. Beyond the operating theatre, he is widely recognized as a key architect of the Green Corridor system, a logistic marvel that has saved countless lives by ensuring the rapid transit of organs across our bustling cities. As a former director of the Fortis Organ Retrieval and Transplant Initiative, his leadership has been instrumental in bridging the gap between the clinical capability and the public awareness. Welcome, sir. Sir.
Thank you very much, and it's a privilege and a pleasure to be here. Dr. Velu would remember these are 6 soldiers who received a liver transplant 20 years ago in Army Hospital R&R after a disease donation. And as you can see, not just saving lives, look at the quality of life. They are back in uniform. And that is the beauty of transplantation. Just to show you that what the world does, 46,000 transplants disease donors. These are not transplants, these are disease donors. But out of that, 28% are donations after circulatory death. And look at India, we have 2 in a year. So we really need to make a move, not just strengthen our brain death process, but also I'll touch upon a little on circulatory death. So this is a study that we published in 2009 that patients who die on ventilator after a head injury or stroke, 30% die of brain death and 70% die of circulatory death. What it means is we have been focusing on 30% only. So once again, we need to think DCD. My topic is about public hospitals, but I can tell you that it's the same story, public or private. These are all critical care heads of 18 Fortis hospitals that we worked together for and published. 4 key things are very important. One, organ donation doesn't happen on its own. You have to have somebody in your organization who thinks about it and pushes it. We have a department of medicine, surgery, everything, but no department of organ donation. So unless you think about it, it will not happen. It has to be driven top down, like Dr. Chawla did in PGI Chandigarh. It is the leadership which has to talk about it, only then it happens. Early identification, I'll be focusing on this, and something about counseling I'll be talking about. So these are the conventional definitions when it is related to brain death. Possible donors, when we have some brainstem death signs, we call it potential donor, and then we do the formal testing. But what we actually get reported in the country from all hospitals is just a very small number. So I would like to show you what we want to talk about is quality. We talk about catheter associated UTIs in the ICU. We talk about ventilator associated pneumonia. Let's talk about organ donation. How do we bring quality into this? So this is what we propose, that our potential donors, we need to subdivide into multiple different categories. And we have to start very early, not when we have started doing the 4 people doing the brainstem death testing. So we should have an alert when a GCS goes below 5. Then potential donor identified when we have 3 brainstem reflexes gone. Then we must report this to a committee. And what we have recommended in my 55 Manipal hospitals is Chief of Critical Care, Medical Nursing and Chief of Nursing should know that 9 o'clock at night, bed number 7 in ICU, pupillary reflex is not there. Then suitability. After reporting, we don't do a brain death testing and then start talking whether it is contraindicated or not, organ donation. We should report and then start the process. So we want to subdivide potential donors in this way so that we can audit at the end of the month where we went wrong. And this is to show you that how a GCS alert goes across to the Chief of Medical Services, Chief of Critical Care, Chief of Nursing, and this is auto-generated from your hospital record systems. Something like this is very important. This should not go to the transplant coordinator because they should not get involved at this stage at all. If you have a grief counselor, it is fine. But then somebody has to go through all these GCS alerts to make sense of it. This is my hospital where when we analyze the GCS alerts to see how many patients were relevant to organ donation. So out of all these alerts, 52, 22 got discharged, which meant that there was a bit of over-reporting of GCS because some people are on sedation, etc. But we are not worried about that. We are not worried about picking up more patients. We are worried about not losing any on the brain death pathway. 7 went LAMA, 10 had cardiac death, 13 went along the brain death pathway. So you're actively tracking that out of these GCS 5, 13 went along the brain death pathway. And then this is the pyramid you build up, see from below upwards. Potential donors identified 13, 3 went LAMA, evaluated 10, tested 8, families approached 8, consented 4, donation 3. We want this figure from every hospital in the country. And why? Because then we do what the world does. We calculate key performance indicators. How good is your hospital in organ donation based on world standards? For example, look at this one, brain death tested to brain death identified ratio. Benchmark should be 90%. We got 60% in my hospital. Families approach should be 90%. We should approach all the families. We did well here. Consent rate, we got 50%. Benchmark, we want to put about 50 to 80, depending on where we are in the country. Conversion rate, benchmark 50 to 60%. So unless we calculate all this, we'll never know how good we are. And when we approach families, we don't want to talk about the transplant coordinator not doing her or his job. They need support. So we recommend, world over everyone has moved to group counseling. So when we have the first session with the family, we advise that you should have a neurosurgeon, neurophysician whose patient it is, a critical care specialist, and a transplant coordinator, where the transplant coordinator just listens. They are a part of that meeting. But in the next one, the transplant coordinator starts leading, and don't again leave her alone. She must be supported by somebody from medical admin and a nursing supervisor. Some people want waiver of bill, they want a medical legal clearance. So the medical administration should not be sleeping at 2 o'clock at night while the transplant coordinator is struggling. It doesn't work like that. So next stage, you can involve a family physician, religious leader, whoever you think who can help you in the process. So this monthly return form that you see, I get from all my Manipal hospitals, and we presented this in the Chintan Shivir, which was organized by the Ministry of Health, and this was approved by everyone. So if you want, I can share it with you here. This is the data which you should generate every month so that you are able to find the quality assessment. A few words on DCD. So it was 10 years ago that we held the first meeting, 2015, on DCD in India. When I was in Fortis, we got 3 international experts, and first thing that we solved was that DCD is legal. So the Transplantation of Human Organs Act 94 says that organ donation can be done in a brainstem death setting or in a cardiopulmonary. So if somebody talks about legality, that chapter is closed. DCD is legal. We have published with 9 societies the position paper on how to do DCD in India. This was in 2022. And these are the 5 types of DCD, out of which 3, 4, and 5 is what we should be looking at. 3 is like in a withdrawal of support situation. 4 is a brain death person, along the brain death pathway, the heart stops. And 5 is an unanticipated arrest in the ICU. So these are the 3 that we could look at. I would like you to focus on how DCD can be done in a brain death pathway. Because about 50 patients every year in our country, after brain death, the heart stops and we don't take any organs. So if we have done both the tests already for brain death, then obviously we can go for retrieval straight away. This is an important one. This is how PGI Chandigarh was doing kidney transplants. If a patient, one set of tests has been done, they get a cardiac arrest. We were doing a CPR for 30 minutes because that patient is not dead yet. We haven't done the second test. And then going on with the DCD pathway. But what happens when you do a CPR in a dead person like this is you lose all the organs. So this is how we have proposed in our guidelines. We should do in a brain death situation where the second test has not been done. Patient is unstable, we get the do not attempt resuscitation signed by the family, and please don't do CPR in this setting and ruin all the organs. So this is the important message that we wanted to convey, in a brain death situation when the heart stops. No CPR if you fill the DNR form. Then in 2023, the Supreme Court guidelines came on withdrawal of life support, and we had to rewrite our consensus document on, and this time we got 12 societies involved, and all this is freely available for you to read how to do it. One slide on how exactly this is done, because you'll be watching this more and more in the country. So when we withdraw life support therapy, you switch off the ventilator, for example, the BP will start coming down, 100, 80, 60. When the systolic reaches 50, that is the time ischemia to the organs has started. So the clock starts ticking from that time on. The heart stops. 5 minutes we don't touch, because if there is any auto resuscitation, we don't want to move in. We always follow the dead donor rule in organ donation. So after 5 minutes, that person will never come back to life. And then we move in quickly with protocols in place to try to take all the organs. That is the way DCD is done. 90% of the DCD in the world is DCD3. Now, when you take out the kidneys in this setting, they are quite hardy. Even if they don't work for a few days with dialysis support, after a few days they come back to. But other organs cannot be used. We wanted to use the liver to start with. Now, if you pull out the liver in a DCD and put it in a machine, it costs 5 crore rupees, that machine. And each session has consumable of 5 lakhs. So the recipient family can pay for that. But if you are going to throw that liver into the dustbin, then who is going to pay for that 5 lakhs? So this was not financially viable as of now. Of course, we are trying to build now machines in India. But this is how we did the first DCD liver transplant. I'll spend 2-3 slides on this. Very recently in Manipal Hospital in Delhi. So in a dead person, this is what we do. We take out blood from the femoral vein, goes into a reservoir, and is pumped through an oxygenator and put back into the femoral artery, into the aorta. And from the other femoral artery, that thing in yellow, that is a balloon that we inflate in the supradiaphragmatic aorta. So there is no blood flowing into the chest. So this is abdominal normothermic regional perfusion. So we have the flow going, and from the aorta into the celiac artery, into the renal arteries, and back into the... So the abdominal circulation is maintained for up to 4 hours maximum, and we can keep the organs alive. And you can see the X-ray of our patient where the balloon can be seen in the supradiaphragmatic. So we have a national consortium on normothermic regional perfusion, and we have 22 specialists from all fields. And what we did, we came out with a low-cost hybrid ECMO for India. So what we did in my hospital was, after 2 years of hard work, but we spent less than 1 lakh. And I'm very happy to say that yesterday I got a mail from NATO that they'll be reimbursing this 1 lakh that we spent on the NRP. So that's all that we spent. It's not a 5 crore machine and a 5 lakh disposables. So this lady was a 55 years old teacher with motor neuron disease, bedridden. She was brought to us with labored breathing, and look at the PCO2. So she was retaining carbon dioxide with pH of 7.1. And the family said, we want to let her go in peace, and please take the organs if possible. So no ventilator. So we were ready. We spoke to them about DCD, and we spoke about NRP, and we put lines into the femorals while she was still alive. We gave 50,000 units of heparin, and then we switched off the non-invasive ventilation. And of course, there are a lot of documentation which we can talk about later. But this is what happened. See, as we switch off the NIV, the BP keeps coming down, cardiac arrest, 843. After 5 minutes, we start moving with NRP. So we have maximum of 20 minutes in which to have the NRP up and running, otherwise the organs go bad. And this is the first time in Asia, actually, that we had a liver transplanted with an NRP. And as you can see here, It went very well. And this is the message I got from the surgeon in ILBS at 6 o'clock in the morning. He said, I've never seen a liver like this. It's like operating on a normal, a live person. In a brain death, when we retrieve the liver, it's never as good looking as this. To summarize, ladies and gentlemen, two important messages. One, we must increase donation after brain death. Have a system where you can use the last 20 years of experience that we have for quality assessment. Find out every month, like Professor Chawla said in PGI, have a monthly meeting. There is no finger pointing. It is just data that is looked at and spoken about. Use group counseling. Don't leave your transplant coordinator alone. But think DCD. It is legal, it is ethical, and DCD4 in a brain death pathway you should be able to do tomorrow if required. But DCD3, what we did was not withdrawal of support. We did withholding of support. For withdrawal of support, you need primary medical board, secondary medical board, etc. But for withholding, you don't need any. And if you start doing in motor neuron disease, interstitial lung disease, our donor pool will expand. And the normothermic regional perfusion is a low-cost way to take your organs in this situation. Thank you very much for your kind hearing.
Thank you very much, sir. It was absolutely a fantastic talk. You actually led us to an extensive thinking process as to when and how we initiate the process when the GCS goes to 5.0, and that is how you activate the whole team. This would definitely help us in, revolutionizing the technique of organ retrieval at our institute. Thank you so much, and congratulations for such a fantastic downfall in the price from 5 lakhs to 1.2 lakhs. Credits to and applause to you, sir. Thank you so very much.
Now I would like to invite Professor Vipin Kaushal, who is Medical Superintendent PGIMR Chandigarh. Sir is who has worked as a nodal officer for organ retrieval, regional organ and tissue transplant organization. Professor Kaushal has been the driving force behind the transforming PGIMR Chandigarh into a national benchmark for institutional organ procurement. His stewardship has not only streamlined the complex logistics of donation across North India, but has also fostered a culture of clinical excellence that serves as a model for the entire country. A visionary in hospital administration, his work sits at the critical intersection of policy, ethics, and life-saving surgery. We most respectfully invite you, sir, to the podium.
Thank you, chairpersons. Thanks, AIIMS Bhopal and NAMS, and distinguished participants and delegates. You are all dedicated participants sitting here from different institutions who would like to start the program of organ donation and transplantation. And especially we will be talking about the cadaveric organ donation. In PGI, I will be discussing the experience of PGI, where we always say it's not I, it's we. So it's a team which work behind all this program. So how we have done, because we became in PGI Roto North also, that is a different story. But we have how we have taken and what steps we can take. Yesterday we had a session with the AIIMS Bhopal teams who are doing very wonderful work here. They have done excellent gap study. So that is very important in your institutions, because these are all, old government medical colleges. I think all public sector institutions from different states are here. They have all the facilities, infrastructures with them. They need to have a very good team to take this forward. So how we have done, Dr. Seth has discussed, Dr. Chawla has already told so many things. There will be some repetition also. So how we did it in PGI, I will be just sharing the difficulties being faced in AIIMS Bhopal. Yesterday we discussed with them. I think will be the similar with all of you sitting here. So how we have translated the terrible loss, because it's a terrible loss, into the gift of life. So many lives are saved after organ donation through a well-structured and successful cadaver organ donation program. So this is the how we evolved. We started with renal transplant way back The THOTA came into being in 1974. Eyes were doing since 1963. So we are into liver transplantation, heart transplantation, lung transplantation, pancreas, of course, and tissue also. So with 337 cadaver organ donations, which we started from 1974, after 1994, after the THOTA Act. So we were not doing so many, but after 2011 or 15, we have done 266 for the last 10 years, and we have saved 656 lives. And we have cornea donation 7593, which were transplanted. Simultaneous pancreas and kidney transplants, we have done maximum in the country, I think 68. SLK is 4, and donations after cardiac death, what Dr. Seth was highlighting, that is very important. So it's easy to go with that, and the infrastructure they have developed. We have done 20 so far, but these were all kidneys. So we will be working for the liver, taking guidance from Lusa. And the youngest donor in our hospital was 68 hours, and the oldest was 75 years. So age is no barrier for taking the organs. We created 90, as Dr. Chawla said, the organs are the national treasure, so should not be wasted. So we created 98 green corridors and shared the organs with the different hospitals in the country. So, of course, it's not a pleasant journey. It's a very tough journey, all through challenges. I always say every case comes with a new challenge. It's not that the challenge you face in the last case will be the similar in this. So every time the new challenge will come in front of you, but as a team, you have to come out of it. So I will be discussing how we made the difference in the single institution, how we are doing with, we are taking care of around 30 lakh patients only in the OPDs, treating 2 lakh patients, doing 1 lakh surgeries. So it's a tertiary care hospital. Still, how we were taking this organ donation program ahead, I will be discussing those things. So it was, we were able to do with a seamless and robust system of organ donation and transplantation. As highlighted by everybody, it has to be, very, very seamless. There is no hiccups. The time is the essence. And very important, hospital systems have to be there. You need to have everything. You need to have an ICU, you need proper triage area, proper maintenance of the donor, the lab services, the diagnostic services, the teams to operate, preservatives, so many things. So you need to have all these, as AIIMS Bhopal has done 3 cardiac surgeries, transplants, and 1 kidney cadaver. So infrastructure is there. And of course, the committed leadership from the top, as Dr. Seth were talking, and the passionate team working without boundaries. So this is not my job, this is not my job. It's not like that. So everybody in the team has to be very, very passionate about this cause, and they have to work maybe round the clock and without any boundaries. And we need to have awareness is very important. In the morning, President of the Institute asked how many of sitting here have pledged our organs. I think very few hands were raised. So we need to have awareness in ourselves, in the public, so that with the impactful, multi-pronged and media-oriented IEC, it is very important. So we did that. That worked for us. So I think after this, we should all pledge our organs. So again, all how we rose to this situation. Professor Y.K. Chawla, who is the ex-director of PGI, now the NAMS task force member for the organ donation, he sowed the seed and he showed the ways. Okay, we have to work as a team. So he brought ROTO to PGIMER Chandigarh, in which we have 6 states in the North India, all have SOTOs created, and 3 UTs. Only Leh is left where we have to create the SOTO. And they have started functioning well. So Dr. Chawla planted this small plant, now which has grown into a full tree. So how bridging the gaps we were talking yesterday, there are a lot many gaps. So active and passive surveillance, the real-time information flow is very, very important. Dr. said how they are taking the data. So we have to take active and passive also, because sometimes everybody is forthcoming. In the act itself, it's mentioned you have to notify your potential donors. So report has to come to the hospital administrator. Flexibility in donor selection. So this is very important. Marginal donors are to be taken. Otherwise, in tertiary care hospitals, patient reaches after, has a critical injury. It takes 3 to 4 days time, and the organs are not that in good shape. So we are to be very, very flexible. Donors being maintained even in the triage area. So in the triage area, we have very good team of the critical department working and maintaining the potential donors there even before the ICU bed is created. Regular review meetings for stock taking and feedback, promoting immediate addressal of the issues. Many issues can come. So when the top leadership is meeting with the teams, so these issues can be addressed. This is the sequence we are still following. Dedicated room in the trauma center in the ICU for the impactful counseling is very important. As you said, the transplant coordinator, the role is very, very important. So who all will be in the team to counsel the next of the kin? It's very difficult to convince. And in the act, even if I have pledged my organ and the situation comes, it is the next of the kin who has to say yes. Consent is to be taken from the next of the kin. So when you have to break that news, how to tell, and the doctors are the teams who treating the patient. I think, as Dr. said, they should go and tell and break the news first. And then the role of the transplant coordinators come for coordinating so many things. Sensitization meetings with police officials making NOC, because most of these cases are medical legal cases. We need to have the police NOC, because they have to get the postmortem done and the cases are to be pursued. So, and consent process has to be made less hassle free. And monthly and daily duty roster of BDC, brain death certification, is very, very important. And it has to be done twice when there is a potential donor in 6 hours. And there is in the act, there is a constitution of the committee, how the committee should work, what tests has to be done. So, and mostly these cases come in the middle of the night, and it becomes difficult for the members to come, and they have certain questions also. So we have created the rosters for the team members who will be coming if the case comes. So all this has to be done. Otherwise, we were facing earlier problems to getting the members for the certification. In the states, what is happening? They are having one member from the government institution, and maybe the potential donor is in the A hospital in some other district, and the member in that team is from the some other place. So very difficult. Now what we have decided in the Roto North, that the institutional level committees will be there. So that makes the process very, very simple, and it is a very important step in the brain death certificate. In the cardiac death certification, CDC, DCD, you need not to have this step. All investigations being conducted in-house with quick response, because many tests are being performed, and your normal working is also going on. So these tests, investigations should be given preference. So what we did, we have a prompt stamping on these test investigation forms. No, digital also is a organ donor. So preference is given. Lighting with the traffic police, airport authorities and others for smooth conduct of the green corridors. You may have the concept of green corridor. So if the organ is not used in that institution, so we need to send it to share it to some other place. So creation, because time is very important. For liver, for the heart, it is 4 hours. After the retrieval, it has to be transplanted. So kidney 6 to 24 hours. So other issue is streamlining the post-mortem process in medical legal cases. Sometimes it's the odd hours we have to do it. So the role of forensic team is very important. They have to take into confidence beforehand. So we do it, show the file to the forensic experts beforehand. So, and that way police also get convinced that we will get the cause of death and it will not be a hassle for us later on. Transportation facility for donor as an expression of gratitude to the donor family. So we provide free transportation for this and recognition of the donor families for their noble gesture and media visibility. So that bring awareness in the public. So human resource, how we have created this passion and motivation. So we need to have a committed leadership. What is happening? I know why we are less in Central India and North India. What is happening in the South? The leadership at the top, political will is there. They have very good infrastructure developed, Transplant, ZCC, where their CM, finance minister, finance secretaries, health secretaries, all are part of it. And many incentives are given. So that is one part. The number may be the higher. Once we ask them questions, sir, is there that will you be able to, if the leadership is not that committed, then the difficulties are there. So in our single hospital institution, committed leadership made the difference. It could be a director, it could be a principal, director principal. So they need to know about this, the requirement, and should be passionate about this, leading the team as such. Then role of hospital administrators, medical superintendent and his team is very, very important. You need to have a nodal officer. Maybe a roto soto is not everywhere in the every institution, but wherever it is, we need to have a very smooth relationship with the sotos or rotos and noto, and need to have a very proactive nodal officer in the hospital itself. Policies should be laid down clearly. There should be proper SOPs and well-trained, well-communicative transplant coordinators in the hospital. They should be very, very dedicated transplant coordinators. And the role of Roto Soto, they are always there to help us. So ensuring smooth coordination. Everybody, see the big team. First is the identification, how we do the identification, where the patient comes. It is a treating doctor, and most of the time it is the neurosurgeon. So Dr. Chawla highlighted the role of the neurosurgeons. They have to be, because they are the ones who gives the cases. And what is happening, most of the cadaver transplants are being done in private sector. And most of the potential donors are coming from the government hospitals. No, sir. Mostly these are coming, cadaver donors are there in the government hospitals, and many, because number of registered hospitals in the government setup is very less. And more in the private sector, transplantation is being done in, there are more than 1,500 hospitals which are registered, private hospitals. So treating doctors, nursing staff, and transplant coordinators, their role is, and synergy between them is very important. Then intensivist nursing staff and lab investigation when the patient is shifted to the ICU. It is fast track work. Then convincing the next of the kins how to take the consent, how to handle the police, and very important is the brain death certification. So we have the roster for this. Then identifying the recipient and the transplantation, and donor retrieval and postmortem, and sending the body. That has to be taken care of. And this is all done by the transplant coordinator. Equipping and training. So we need to have transplant coordinators, which we increase the number to 4 to 6. CMEs for the doctors, orientation and training of the nurses, sensitization diagnostic staff, research studies on the subject. These are very important. So these workshops for the hospital healthcare workers, this is one step towards that only. So Department of Hepatology launched their own website, Lampa Live, then convinced Chandigarh Adam to have a OD status in driving, organ donation. I'm an organ donor. It is in the license in the Chandigarh when the license is given. Displayed IC material in all the departments. We took initiative to OD status in PGMIR ID cards. We have written this thing and release short films, documentaries to promote awareness and organ donation in the public. Renal transplant surgery hold the transplant games, engaging graffiti, signature campaigns, publishing leaflets, booklets. These are the awareness, how we create the IEC material. Then Roto, Soto, and all hospitals, various teams. You need to have the help of the nursing staff, the doctors, various department doctors, the neurosurgeon, neurologists. So we have to have the community connect camps, many camps where students are very important. They are the change ambassadors who bring awareness. Student activities are very important. We have a student relation, be a change, be an organ donor. We go to various schools, 40 schools, 35 colleges, and 14 universities. We are leading this program. Public forums, stakeholder meetings, advocacy. This is one of the advocacy session. Case studies and success stories, as Dr. Seth told you how he has done the liver transplant. Then various, you can go theater shows, street plays, video spot, documentaries, customized goods and merchandise association engagement, walkathons and rallies. These are very important to bring awareness in the public. Then media, integrating media strategy is very visibility. Any positive story brings very good result. One negative story, takes the whole program off. So we have done so many for the last 10 years, 7,000 media positive stories have been done by the print media as well as the electronic. We have made short films of the donors who wants recipients who got the organs. Then green corridors. We created 1908 green corridors and saved so many lives. Shared the organs till Chennai. We have sent organs to Mumbai, Pune, Chennai, R&R, ILBS in Delhi by to Delhi by road, traveling in 3 hours, creating connecting 8 districts, passing through 8 districts, talking to the 8 SPs of that area, superintendent of police. So it's a big exercise, but if we have to not waste the organ, we need to share them properly. Paying homage to the organ donor, this is also being done, shown by us, by AIIMS Bhopal team, that they also honor the, when we give God of honor while sending the body home, and then honoring the donor families. Only last Saturday, we honored 16 families who saved or impacted 85 lives. So, and it goes, very well in the media and bring lot of awareness in the public. So we got some awards also as a best hospital, public sector hospital, performing the large number of then best rotos. So this gives motivation to work more. A defining moment was then when our 3-month-old, our one of the donors, Abadat, was mentioned, and Honorable Prime Minister spoke to her parents. So it was in the 99 Mann Ki Baat. And again, after that, 2 times. So this is very close to Prime Minister also to promote organ donation in the country. So key takeaways is we need to have a quality infrastructure supplemented by proactive review and wrestle mechanism ensures good delivery. So all AIIMS, INIs and medical colleges in the state, they have infrastructure and quality is being maintained or done by B people. Visionary and top-driven initiatives executed by skilled and synergized teams result into unprecedented success, and creating positive conversations with focus awareness campaigns and 360-degree media engagement to build. We shy of talking. We don't talk about organ donation. We talk death. So we need to talk about organ donation. That is very important. With this, I conclude my talk. Thank you very much. आज हम उन्हें श्रद्धांजलि अर्पित करते हैं जो अंगदान का संकल्प लें. These are the young donors, next of kin have donated their organs and they have saved many lives. Thank you very much.
And we are in a process of developing cadaveric organ retrieval program and transplant program at State Medical College. And I think this talk will help us a lot in taking many points from your talk. Thank you so much, sir.
But Saurabh, do you agree that we have got maximum cadaveric donation government institutes?
No, not in Madhya Pradesh. Not in Madhya Pradesh, because there are Yes, sir. Because there are many reasons, and I think the main hurdle is in this program is lack of training, and recently Aishman scheme, which is one of the biggest hurdle in establishing this program. Ma'am, the main thing in developing a retrieval center is who will pay, because as I said, there is no incentive in Aishman scheme for retrieval and all other things. In our hospital, every case, because of Aishman scheme, we get equipments and we get consumables which are on case by case basis, on local purchase basis. So if there is something we have to retrieve, there is no package in Aishman scheme, so our superintendent can't order that. So that is the biggest hurdle. Yes, that's true.
I'm sure the institutions have their own some fund control, right? Why can the institution not take a decision that for this, the institution will spend non-Ayushman funds for retrieval of organs? Does the, I don't know which institution you belong to, let's say look at AIIMS here. Can it not be said that we are willing to spend this much money on supplies that are needed for retrieval? I'm sure you spend so much. There are many things that can be cut within this institute. We can, right?
You rightly said, sir.
That's a decision of people within this institute administration.
You rightly said, sir, but that is something to be answered by the institute administration.
See, look, we all faculty are administration. I somehow feel that faculty is not administration is wrong. Faculty is a part of administration. Right? Heads of the department surely are a part of administration. To me, every faculty member is a part of administration. We just need to say this, that we need this, and this has to come out of the institution fund. Raise it to your finance committee. I'm sure the finance committee would approve.
So, if I may add something that what we've been doing in South India, because we do about 200 donations every year right now. So there is a good mechanism of actually fund arbitrage that is actually in place. It's conducted by our SOTO, which is our Jiva Sarthakate, which is our allocation authority. So essentially every institution that actually benefits from a potential organ like a liver or a kidney will pay to the central authority. Like for liver, we'll pay 75,000 rupees. For kidney, we'll pay 50,000 rupees. For a heart, we'll pay 50,000 rupees. And that money then goes towards the retrieval center towards payment. That is number one. At a central level, there is a provision for payment of up to 1 lakh rupees for maintenance of a donor and retrieval that is available from NOTO. So there is actually a fair amount of funding available. It's about question of how you structure the funding. And every state will have a slightly different, way of doing it actually.
And the NOTO gives you money for making a retrieval center. Yeah. So you have to explore that. Go to the website and you will find that.
Sir, we have already applied for that 1 crore funding, and we are still to receive the answer from
थोड़ा
NOTO.
सा
Yes, it will
pursue
take
करना
some time.
पड़ेगा
Yes, sir.
आपको.
We have already applied.
Just pursue that.
Now, may I call the next speaker? May I now invite our next speaker, Professor Vijay Gurwar, sir, Professor and Head of CTVS at RML Hospital, New Delhi. Professor Gurwar is a renowned expert in expanding surgical infrastructure, especially in the government sector. His work has been instrumental in ensuring that high-end transplant services are both scalable and accessible through institutional preparedness. Sir, we are deeply privileged to have you over here, and we look forward to your address with utmost esteem and anticipation. Thank you.
Good afternoon. After listening to the success stories of PGI, Chandigarh, RNR Hospital, we get influenced that transplant is a possible entity, and we will be able to deliver good results. But there's so much of work that has been done at these institutes for decades to produce such results, and it is far more difficult even today in the government sector to envisage a program which can be not only to start a program but to run another program to a definite numbers, to scale the amount of numbers. I because most of the slides that I have made may be a repetition, but I'll go through them very fast, and I'll reflect on the problems that we face, because that's a system that's, I think, more important at this kind of uh, program, where the people have to solve problems and make a way out of to make the transplant process successful. So this is my institute in Delhi. This is an ABVIMS with the RML hospital attached to it. We have a undergraduate program, postgraduate program, and a postdoctoral program. We have had a department of CTVS since 2001, and I've been there since then. And we have managed to do all kinds of cardiac surgery in that hospital. And after a period of 10 years or so, we decided that we should be able to do a transplant in our setup. But after 10 years, when we made the proposal and we started working on it, it took us 7 years, I think about 6 to 7 years to do the first transplant. So it's not an easy game. It looks quite simple, but it's not an easy game. It took us 7 years to do the transplant. And look at this. We did the first transplant. The picture on the left reflects the story that was published in the Times of India. We received a lot of accolades from the government, from the press, from the institution, from the DGHS. Everybody praised us, as we were the first central government hospital in Delhi to do a transplant. But accolades are also followed by brickbats. Within a span of 4 days or 5 days, this second that thing was published in the Hindustan in the Hindi edition of Hindustan Times, where they mentioned the fact that we had stopped cardiac surgeries for 10 days, looking after the transplant patient. So you have to be prepared for the brickbats as well. So that really highlighted that we could do it, but at what cost? We could do it, but where is the infrastructure? We could do it, but at what rate? And is it feasible to sustain ourselves to do that? Doing a transplant was one part that took us 7 years. The 10 days that we were there, we had to run around pillar to post to arrange an ICU bed, to arrange a nursing home bed. We could isolate the patient, to arrange medicines for immunosuppressants, to be able to convince the authorities that we had a poor patient who could hardly sustain themselves, to be able to give them money for the medications. As you said, Noto has brought out a proposal for 1 lakh rupees for medications as well as help. That was the fund that was started when we pushed it forward. And again, these were you realize that you have a medical staff in place, but having that is not enough. You have to scale the physical infrastructure to do any good work. A most important part was what was demonstrated in the article in the Hindustan Times was that we were cannibalizing on the routine surgeries. So that took us really, made us look backwards to understand how we could proceed further without affecting routine work. And that is the most important part in any infrastructure development. If you want to take transplant in a big way, a department of transplant medicine has to come into the medical college. A separate space has to be made for the patients, and separate ICUs, Dr. Yogesh has already pointed out in great detail. As we all have been talking about this. There's a 1.5 lakh patients die annually from road traffic accidents, which should not happen in the country like ours. We should have money less deaths. But having said that, these out of the 1.5 lakh deaths, most of them die at the stage, at the site of the accident. Very few reach the trauma centers, or very few reach the district hospitals, and where they are not even managed properly. Unless we manage to preserve those patients well, there comes the role of the police as well as the hospital that is catering to these dead patients, or potentially donors. They have to be sustained. Even that kind of diligence is not there in most of our, sadly speaking, most of our smaller hospitals, either in district, even in medical colleges. We fail to preserve life. The trauma centers and the ICU care is not up to the mark. Unless we achieve that at a level of the whole country, we will not be going too far with cadaveric transplants. Out of which, if you realize, we only do around 1,200 transplants. And of course, there's a big waiting list, as already pointed out. Of course, we have an over-reliance on the living donors. That is the easier subset to manage. That's easier to manage as from the administrator's point of view, from the infrastructure point of view, from every point of view. But if we have to make a way, we have to shift forward to a deceased organ transplant. Requires a lot of investment, both from technological part, both from investment, both from money, both from finance, both from administration willingness, as well as society at large. Of course, if you look at this has been pointed out a number of times. If you are located in Tamil Nadu, you are very likely to receive a organ in time. So your PIN code of residence does matter. So if you live in Tamil Nadu with a PIN code of 4 ... you would be more likely to get a transplant if you live in North India or the Northeast. This has to change. This has to change. This has to change by all our government efforts, especially with now that we are looking at PMSSY, we are establishing apex centers of AIIMS all around the country. We should change this definite geographical skew. So all of these medical colleges, at least the colleges that have been there for a long time, like KGMC Lucknow, like Banaras Hindu University, RML Hospital Delhi, Safdarjung Hospital Delhi, and all of those AIIMS institutes that are being established in the country. So if we are able to manage them, provide them infrastructure as well as financial support, I'm sure we'll be able to do a better job. Ultimately, we have to develop a three-tier national ecosystem where the grassroots, we have to make sure that we have non-transplant organ retrieval centers to be able to capture and harvest organs locally. That is the mainstay. All the road accidents do not occur in the main cities. They do not occur close to the retrieval center. So you have to bring retrieval center close to the place of injury. So if you are able to establish retrieval centers in the district hospitals, I know it's a very tough job. Even district hospitals do not have proper medications available. What to say of ICU care for the patient who is potentially dying. But that's the way forward. Unless we establish our system from district level hospital to regional hubs in state medical colleges, which can manage high volume common transplants like kidney and cornea, and apex institutes like AIIMS and INIs, which can be equipped for largest, more complex multi-organ transplants. Again, there could be a hub transplant center, a hub and spoke model, where we could have one district, one non-transplant organ retrieval center, followed by ICU upgrades and protocol mandates. Now, this is the most important step. Unless you have good ICU protocols across the country, where you will not be able to manage these, even the number will increase only if we are able to make the road accident patients or the stroke patients survive the first few hours of injury or the event. So that will only be possible by good private and public hospitals requiring good ICU hardware, good mandatory reporting of all brain deaths, as has already been pointed out, and immediate brain death certification. It looks very easy. It's not very easy. I am sure you. If you look at success stories with Chandigarh, they are very few amongst the whole country. Transplant coordinators play a big role. The government of India has incentivized transplant coordinators, but we are still a large way off to make it a uniform phenomenon all over the country. These are the foot soldiers of any kind of transplant program. Unless we recruit them, unless we give them enough incentives, we are not going to be there. It cannot be a medical personnel run program in its entirety. Of course, physical infrastructure has to be, we have come a long way. Now the modular OTs have become the norm in most big centers that are coming up, especially in the private sector. In the government sector also, at least in the apex institutes, more or less it is the norm to have a dedicated modular OTs. HEPA filtration has become the talk of the town. It is more or less now acknowledged by every administrator that they are need of the hour. So I don't think this is going to be a big challenge, but we have to invest in more of these OTs and dedicated space for transplant program to run. Otherwise, if you're starting cannibalizing on the routine services, you'll always face resistance because they're all you're cannibalizing on the aspirational people in all departments, apart from the transplant team. High dependency units are already coming up. They have to come in a much bigger way, and the ability to be able to sustain a patient, a potential donor in an ICU, that requires a lot of commitment from the top down, as Dr. Chawla has and PGI team has demonstrated. The top down approach has worked for them. I'm sure it will work everywhere else, given the sufficient impetus by the people in charge. To maintain, especially for heart lung programs, we require infrastructure like ventricular assist devices, ECMO, and IBP to maintain the heart, so that both the donor as well as the recipient to be able to manage a good program. On-site diagnostic and pathology services are definitely a mandate. You cannot run pillar to post to get various lab investigations done. Histopathology has now revolutionized care. We are able to detect by rapid biopsy services available to be able to detect rejection at an early age. So this basically is a basic model of a physical infrastructure of a apex center. So again, the mandate is, even if Dr. Devguru will be, I think, highlighting more on this, of the mandate of personnel that is employed in these particular ICUs, apart from immunologists, social workers, physicians, dietitian, anesthesiologist, critical care facilities, nursing plays an important role to be able to maintain a good program. So next is the most important part. This country, especially the government sector, we get a notification every day. I get a call at 12 o'clock at night on a WhatsApp message saying a heart is available in Jodhpur, middle of the night. Now, how do I go to Jodhpur? I have to go by a commercial flight. The family says we want the body at 9 o'clock in the morning. So retrieval time is fixed at 6 o'clock. I cannot go to Jodhpur at night. It is not possible. Ultimately, end up refusing the organ. And so many times that we see at the middle of the night that a lot of organs are being rejected because of these logistic issues. And this is something which is close to my heart. It is something which we have green corridors. In Chandigarh has a very good system. We got a 2-hour donors from PGI Chandigarh. Because Chandigarh is easy for us to go to from Delhi. It's a 3 hours drive. We could make a green corridor. We reached Chandigarh middle of the night. Our team went at 3 o'clock at night, reached there, retrieved the organ, and the early morning flight could come back. But that's not possible for Jodhpur. That's not possible for Udaipur. Leave alone Pune. Leave alone Nagpur. Leave alone. We cannot go everywhere. So this is something which, I don't know. So a lot of thinking has to go in as to how to be able to transport organs. It's commercial, depending on the commercial system of aircraft, is something which will be halfway gesture towards program. Of course, it is financially a big challenge to the government of India. State green corridors, well, as far as the states are concerned, they are there. Interstate boundaries, where sometimes there's a difficulty. Preservation of the organ, we have managed to procure good cold chain management, but still lot more to be done to be able to make them sure that there's no way that we lose organs in the system. System enablers in the form of technology and financing, I think a lot has been said about it earlier. A unified digital registry, Noto is doing an excellent job till now, but there's still scope for a lot of improvement to be able to have a complete waste list visibility, donor matching, and a transparent system, which could be AI driven in the long run. Advanced preservation techniques like an ex vivo perfusion could play a role in especially in heart transplant, where we have a barrier of 4 to 5 hours before warm ischemic time. Maybe if we can have a system in place, we may be possible to transport organs and with more time in hand. Financial equity protection, a lot has been said. AIIMS inclusion, I think it's a mandate of all of us that to be able to persuade the people at large, the administrators at large, and the political will has to be there. Ayushman has been a success story of this government for the last 10 years or so now, and I'm sure now that the Prime Minister is talking about organ transplantation in Man Ki Baat. In fact, he mentioned our patient, the first patient that we did completed 4 years of transplant and went from not being able to do any housework. Patient went to Kedarnath on a 40-kilometer walk on her own. So Prime Minister mentioned that patient in this March episode of Man Ki Baat. So there, the political will is there. It has to be convinced to be able to have an integration of transplant procedures, ECMO adjuncts, post-op immunosuppression, and they have to be adopted in national health schemes. District level care has to improve dramatically. That is the place where most accidents will occur, and we have to find a place where we can salvage the organs from there. Funding, as has also been mentioned, CSR has become a very unique way of funding for this country. CSR funds should be more deviated towards the health sector because the health sector gets very minimal access to government funds. So if you're able to ask these corporates to direct more funds to the health sector than to other activities, it would be a boon for this program. I end by saying a robust infrastructure upgradation is needed to address challenges in tissue and organ transplant program. Government agencies need to be strengthened because to make it a large program, it is a lot to be done there. Public partnership, CSR funding can play a vital role. Transport has to be made more affordable to a lesser privileged. The source of funding has to be generated from scheme like Ayushman. Transport and logistic infrastructure to be upgraded for effective organ utilization. I end by saying what I say to my team every day: together we can. Thank you.
Thank you, Dr. Grover. We'll have to interrupt this session here because our chief guest, Dr. Vinod Paul, is online with us for his session. So I would be requesting Dr. V. Devguru and Sonal Asthana to continue with this session after we have the address by the chief guest.
Thank you. I request Professor Digambar Behra and Professor Madhavananda Kar sir to please chair the session and introduce the chief guest to the audience.
A very good afternoon, sir. So, ladies and gentlemen, I think we are waiting for the inaugural address by Professor Vinod Paul. Is a very well-known personality as a distinguished member of the Niti Aayog, that is a member health. Dr. Paul leads the health and family welfare vertical, where he has been the visionary force behind the India's most transformative healthcare reforms. The world's largest public health science, that is, the Ayushman Bharat scheme, it is his brainchild. Before his pivotal role in the national policy, Dr. Paul served as the head of the Department of Pediatrics at All India Institute of Medical Sciences, New Delhi, for over a decade. A world-renowned researcher and a recipient of the prestigious, Yusan Dogmesi Family Health Foundation Prize from the WHO. His commitment to clinical excellence is matched only by his dedication to public services. During the most challenging times of the pandemic, the COVID pandemic, Dr. Paul stood as a pillar of guidance for the nation as the chairman of the National Expert Group on Vaccine Administration. Today, his presence with us underscores the national priority and the strategic importance of organ donation and the transplantation of India. In fact, Dr. Paul is a guiding force and a inspiring force for the National Academy of Medical Sciences. So anytime, anywhere we call him, he is always there to guide us. And this is one of his, the organ transplantation. He is always worried about the organ transplantation system in the country, wherein he is mostly worried that, most of the organ transplantation is occurring in the private sector, but that should come into the public sector also. He always tells us that. And again, he is trying to course the National Academy to become the part of the healthcare delivery system, so that we try to inculcate the spirit of organ transplantation, spirit into the medical colleges and institutions. So I am Dr. Paul sir, we are really grateful and thankful to you for your kind presence, and obviously we are waiting for your inspirational inaugural address. Professor Paul, please, sir.
Thank you very much. Good afternoon, respected Dr. Digambar Behra ji, respected Dr. Madhvananda Karji, dignitaries, distinguished delegates to this meeting. Thank you very much for inviting me to be a part of the deliberations of this very important workshop and CME conducted by AIIMS Bhopal, but organized under the aegis of the National Academy of Medical Sciences. I'm so grateful, and as Digambar sir has said, I admire the work that's been done by National Academy of Medical Sciences, and even more so when we look at the legacy of NAMS. It is an organization, it's a professional body, it is a think tank created by the most important stalwarts of our profession in the post-independence phase of our great nation. So you have a huge, important legacy, but also equally importantly, you have a huge responsibility to continue to serve the cause of health for people of India. Let me start by saying
are some network issues. We are just trying to reconnect, sir.
That's from technical issue from that side, from Professor Binod Niti Aayog side. They are taking care and will do best soon.
but I continue with your permission. I was referring to the health-related overarching goal for the Viksit Bharat at 2047. The target is to achieve a life expectancy of 85 years or more from the current level of 71. Since independence of life expectancy under 30, we have come a long way to 71. The developed nations have a life expectancy of around 85 or more, typically above 80, but among the most, the European nations, it is about 85. But the important point is the other target, namely health-adjusted life expectancy, healthy life expectancy. The current level is 60 years, and the target is to move to 75 years. So one nuance that all of us need to now align to is the emphasis on healthy life expectancy. So far, largely our emphasis has been on reducing mortality, improving outcomes in different ways, addressing communicable disease, maternal child health, and other disorders as well. But moving forward, the next immediate thought that should be is how healthy are the people when they are having a longer lives. That's very important. Now, since non-communicable diseases are the major reason for mortality, especially among adults, clearly, then non-communicable diseases have to be addressed, and then non-communicable diseases lead to organ failure. Some of those organs are amenable to transplant. So this is one convoluted way to bring the importance of transplant to the fore. And obviously, when a choice comes between a transplant or living with medication, very often it is a very difficult choice, but we know medically the quality of life, and that's why I'm linking it to healthy life expectancy. The quality of life with transplant is so much better than the other choices that we may have, which are truly not as good. Having said that, now I bring the point, Dr. Behra, that you made, which is where this conclave can play an important role. The number of transplants have risen from about 12,259, that's the under 13,000 in 21, to about 18,400, okay, under 19, from 13 to under 19, that's it. So there is an increase, which is good. But my, very important concerns are twofold. One, how to increase the coverage of transplants to meet the needs. I'll come to that in a minute. How do we do that on a big scale? And there is a huge unmet need. I'm sure this has been spoken since morning more than once. But if you, just for the sake of me to make a case, for renal transplants, the need perhaps is between 1.75 lakh to 2 lakhs, and we conducting overall about 14,000 transplants. 14,000 versus 2 lakhs. Liver, about 50,000 possible need. We are doing about 5,000. Heart, potentially 50,000 need, very difficult area. We are doing about 250. So that huge unmet need is one issue that concerns us all. And that's one area of work, a huge work. In the recent 4 or 5 years, 3 to 4 years, several actions have been taken to improve the transportation of organs. Got the SOPs done for airlines and trains and metros and so on and so forth, ships as well, and other ease of enrolling for as a transplant candidate has happened. The jurisdiction of states, etc., has been changed. So taken other policy steps which are conducive toward increased transplant coverage, but the fundamental issue is where is our optimum expertise in conducting transplants? And there, the government sector in particular is even, particularly I would say, weak in this area. Out of the 18,000 transplants that I referred to in 2023-24, in 24 to be specific, only 16%, only 3,700 out of the 18,000 were conducted in the public sector hospital. 16%. And overall, in the tertiary care space, we have a much more presence. And that's one part of the story that must be spoken here. And I'm looking forward to NAMS and tertiary institutions, our INIs, to be the leaders in improving the pipeline of care in our country. So छोटा point ये है कि हम under 4,000 कर पा रहे हैं. 16% of transplants happen in the public sector. इसको कैसे ठीक किया जाए? Because it brings in affordability, and also it brings in the other issue that our public sector hospital should be able to conduct these sophisticated surgeries today. And very few medical colleges qualify for it, even in the city of Delhi. INI community is at different stages of its evolution, and there also there is a need to accelerate this commitment, to accelerate creating the infrastructure and human resources in that regard. And clearly, patients have a advantage to be receiving it from the government sector. A liver transplant in government sector is around 14 lakh or so. Typically in a private sector is double, if not much more than double, triple, and 3 times, and so on and so forth. So the real message from me is, can we work together, helping each other? Those who have the ability to train, to guide, to handhold, come forward to those who are willing to now establish transplant systems. Those who are keen, and if the net of those who are keen is less today, can we motivate our institution to take the plunge, take the hard work that must be done? Nation has done very many things that are easy and quite a few things that are difficult. But the real challenge going forward is to be able to do more difficult things. This is a time to do more difficult things. It's not easy to establish a system. It does need commitment, needs resources, networking. And I heard the preceding speaker, the respected speaker was before me, talking about a few very important challenges. A lot of people have a responsibility. But the core that we can help with as a community of professional bodies like NAMS and institutions that are represented here is to be able to create a network for training. क्या हम ट्रेनिंग कर सकते हैं? क्या हम हैंड होल्डिंग कर सकते हैं? अपने आप शुरुआत करते हैं. Why are we waiting for somebody to tell us? How can we help institutions that are at the threshold of moving into a transplant program? उनका हैंड होल्ड करके हम कैसे दूसरे के साथ जुड़ के इसको आगे बढ़ा सकते हैं? And not only transplant, the important other part is that organ retrieval centers should be energized. Practically all medical colleges should be able to be organ retrieval centers. And why not? It is not a very difficult thing to do. To connect to transplant centers, there are steps to be taken. Some are being taken. There are challenges. But why we in a city, and extended regions, we do not have enough number of organ retrieval centers. So the uptake of transplant programs can be augmented manifold if there are more organ retrieval centers, if more organs are available that can be mobilized. So both aspects are very important. Enhancing the capacity for organ retrieval centers. What is it that we can do? And this is not, so complex that it cannot be done in well-established medical colleges and even good district hospitals. And then concomitantly, how we can enhance the organ transplant expertise as teams in our institutions. We have an aspiration of having at least 50 more kidney transplant centers in the next 5 years, 10 new liver transplant centers in the next 5 years, both in the public sector in particular. I would say not in particular, in public sector, because private sector moves on its own dynamics. We appreciate that, we adore that, we admire that. And 200 new organ retrieval centers in the next 5 years. Here, I have inputs from the private sector that if you create a network of training of nurses, the medical specialists, and the surgeons, the private sector is also willing to come forward. And we can connect you to some of those institutions in the private sector who are willing to be able to impart treatment. So, sir, the issue, Dr. Behra sir and Dr. Kar sir, is to debate how, in practical sense, we create our own capacities, those who are here, if the institutions themselves, and then importantly, how those who are conducting these operations and surgeries and activities, both as organ retrieval centers as well as transplant centers, can handhold each other. Can we create that network? Can we create that glue? And the glue can be the NAMS itself. That can be done. And I think this is the spirit with which Dr. Behra, you have taken up this mission. I appreciate your initiative and the initiative of the NAMS. And I'm happy to be making this very simple case to all of you कि आप खुद इसका नेटवर्क क्रिएट करते हैं, एक दूसरे की मदद करते हैं, हैंड होल्डिंग करते हैं, ऑन साइट सपोर्ट भी चाहिए होगी. And then of course there are other pathways how teams can go to another location to conduct the surgery, but also to handhold. That would be another pathway that we need to develop. Happy to be of help, any help in this regard. But can we work on that mission of 50 new kidney transplant centers? And we train, and then we garner the other resources that are need to be done from the government and other places. At least 10 new liver transplant centers in the public sector in the next 5 years, and 200 new organ retrieval centers. With these words, I thank you for the opportunity and apologize for the glitch that happened. Thank you very much. Good day. Namaste.
Sir.
Thank you, Jay.
Thank you so much, sir. This is a very inspiring speech and some task given to us like that. This is one thing, sir, we can assure like this. This workshop comes CME as having the agenda keeping all the like INI. This is giving the 4 states INIs, private setups, those who are doing, and the visionaries with state medical colleges like senior faculties and policyholders we are having here. That's already each state having one INI like AIIMS has given, and most of the AIIMS already started like Jodhpur. This Bhopal is doing like a cardiac transplant, kidney transplant, bone marrow transplant, the Jodhpur, Nagpur, Bhubaneswar. Few things are that is, and this is a very encouraging steps from the ministry that is there, allowing like to collaborate with the private setups also, and that is a good thing that so we can enrich our training system. Few things are from our side that is like a request and something that we can also part of this mission. What you are telling, this is the 50 kidney transplant centers, more for liver, like cardiac, that gap system. Few importance should be given to the INA. They should focus on the transplant. Few more guidelines we needed that how we will take more faculties for dedicated for that purpose. And like in AIIMS Bhopal, we have to increase our faculty strength in that line. And more flexible that we can take the faculties from the private sectors, those who have already established in this things, like we are doing MOU and other things. And we are progressing on that way, sir. We are with you, but a few things that support you need from your side to the Ministry of Health and Family Welfare. We can give more focus on that side. Will be the thing. Thank you so much, sir. And this much
Thank you.
We can expect from you. And we are assuring that we are doing things like after Delhi, this AIIMS Bhopal is doing cardiac transplant. And very soon, because of the faculty, we will start. That progress already started, like taking the lung cancer already approved. We're studying for the liver transplant very recently. Bone marrow transplant is going on. Cornea transplant is going on. Kidney transplant is regularly doing here. The all INS should have given these things. Few things should be facilitated from the ministry side to regarding faculty and other things. bottlenecks will come that time. Thank you so much for your inspiring speech, and that will give a mileage and some responsibility to us who will go ahead. And NAMS has taken the right steps coming to us, and we are giving all the stakeholders from the states, from the institutes, and this is a good awareness among all, how everyone is responsible to how this facilities facilitate the among the community and all the hospitals to be part of this mission. Thank you, sir. Thank you.
So there are 2 points, Dr. Kar.
Sir.
One is हम खुद कर रहे हैं तो हम किसको ट्रेन करें?
Yes, sir. Yes.
अब आप कर रहे हो, नागपुर कर रहा है, भुवनेश्वर कर रहे हैं, तो हम मदद करने के लिए प्लान बनाए ना कि अगले 3 साल में हम कितने लोगों को लेके आएंगे.
सर
ठीक है,
सर
ऑर्गन रिट्रीवल के लिए एक नेटवर्क क्रिएट कर दीजिए आसपास.
सर.
ठीक है, तो वो something that we can do. Then what NAMS can do is look at the same way in other regions and other areas and say, okay, ऐसे नेटवर्क हम कितने क्रिएट कर सकते हैं और कैसे ट्रेनिंग पे हम उनको भेज सकते हैं. So if you the suggestion for the academy would be कि आप विजुअलाइज करो कि ये 50, 60, 70, 40 बनाने हैं अगर तुम specifically now this is ready. Let's say X medical college is ready, Lady Harding is ready. उनकी कैसे मदद करें? कितना चाहिए? क्या कर सकते हो? ट्रेनिंग सबसे बड़ी एक बात होती है, उसका टाइम भी लगता है, लोग जाते हैं, रिलीव करना पड़ता है वगैरह वगैरह. तो क्या ऐसा पाथवे क्रिएट हो सकता है? तो उसके लिए एक ऐसा चाहिए कि एडहॉक नहीं छोड़ते, इकट्ठे सोचते हैं कि वी विल ट्राई टू डू इट. So you serve your part and perhaps you will take 10% of that load or 15% of the load. Another institution becomes a nodal hub, spoke. But the NAMS can look at how it can be visualized nationally and how to get this thing around. So I think that is the process, suo moto, by an academic system network led by NAMS, I think is the way forward. नहीं तो वेट कर रहे हैं कि कोई कहेगा तो करेंगे, अपने तरीके से हम अपना कर रहे हैं. लेकिन सबको जोड़ने का जो काम है, अगर आप सब मिलके करेंगे तो आई थिंक स्पीड बढ़ेगी. यही मेरा सुझाव है. बहुत बहुत धन्यवाद. जय हिंद. थैंक यू.
Thank you, sir. Thank you, sir.
बाय.
Thank you, sir.
नमस्ते.
Thanks, sir. Let's continue other programs.
Hello. Thank you so much, sir, and our esteemed chairpersons for the session. Now, we continue with our previous session. For this, I would like to invite Professor Dr. V. Deva Gauru. With a monumental career spanning over 7,000 surgical procedures, Dr. Deva Gauru is an elite surgeon who has been at the forefront of the most complex heart and lung transplant cases in India. His dedication to training the next generation of transplant surgeons at a nation's premier institute is unparalleled. For chairing the session, I would like to invite from the State Organ and Tissue Transplant Organization Bhopal, Professor Dr. Kavita Kumar and Dr. Naveen Kumar. I would like to invite Dr. Rakesh Bhargav from Kiran Foundation Bhopal and Dr. Navneet Saxena from Jabalpur. Thank you so much.
Good morning, respected chairpersons, dignitaries, dear colleagues and residents and paramedical staff. I thank the director and the team of AIIMS and NAMS for inviting me to give a talk on training the workforce in organ retrieval and transplantation. This is my center, Cardiothoracic Center, where history was made in 1994 when we did the first heart transplant by our mentor, Professor Venugopal. We started the lung transplants a couple of years back. Then we had a lull because of the morbidity mortality, and then we are starting to restart the program again. I have no disclosures to make except that I have experience only in the heart transplant and yet to venture into lung transplant. I'll be giving an overview on how we go about in procuring an organ, and it's mostly as a cardiac surgeon. My perspective will be as a cardiac surgeon, and most of it will be true for the other organs too. As for the history of transplant, the first heart transplant was done in 1967 by Christian Bernard at Gruchur Hospital in Cape Town. There was a lull after that because of the immunosuppression and its morbidity which happened, and still the protocol was established by Dr. Norman Chauvet, which again there is a secondary interest, it started happening. And we did our first heart transplant in 1994 after the THO Act was passed. That was in August 3rd, 1994, which is even today is regarded as the transplant day of India. To start, we should have a team. Cardiac surgery itself is a teamwork, but more so with a transplant, either heart or lung or any transplant. We should have a coordinated team, which includes, for the cardiac transplant, we include the cardiologists, cardiac surgeons. Then we have the intensivist, transplant anesthetists. In addition, we have the perfusionist who will manage. In addition, we have other associated people who are most often involved, the nephrologists, psychiatrists, the infection control people, microbiologists, all are very part of the main team, which is going to be part of the team. It's also relevant to inform that we should have physician assistants in teams, which we have physician assistant. We have programs for physician assistants specifically for transplant in some centers. And also we have to train our own nurses, nursing staff, both in recipient team and the retrieval team. That is very important. When you have your core team, again, we have to subdivide them into people specializing, especially it comes to for liver transplant, we have a retrieval team and a recipient team, which so that the things are very protocolized and we have the best outcomes when we do transplant. As I said again, within the team, you will have to have your own team, and we have to train your own nursing staff and delegate the work. And most important, the entire team will be the transplant coordinator, which has been touched upon in the previous talks. To go about, you should have protocols in places, processes. Either you have it or you take it from a center which is doing very well. We don't have to reinvent the wheel. We look at a place which is doing successful work. We take their protocols, processes, and then try implementing in your place. As you grow, get experience, you can have your shortcomings, you can keep changing things, but it's very important to have protocol in place because, as we said, organ is very rare to get, and that to have the best outcome of it, you should have a protocol in place so that the efficiency is maximum, the errors are minimum, the outcomes are best. There are some paperworks required to get you have to get your licensing done for that, and you should have some of the team members having a certification or at least having some attended some places where they can claim that they can do transplant. That is very important. That is the beginning work to do. Once otherwise you'll have to attend conferences, we have to workshop. There are several workshops being conducted for heart transplant, lung transplant, liver transplant. They have cadaveric workshops being done in several places. So you have to attend some places or invite people to give didactic lectures, show some videos, and also have a full core team which also used to, the other team members also should participate in the workshops and get training and experience from outside or within India. As I said, transplant is a teamwork, and each member should be able to have gain experience either by attending conferences like this or have a simple cadaveric workshops they attend, they gain experience. And of course you can go abroad in particular center of area of interest, or within India we can go. For example, there are very good centers for cardiac surgery and lung transplant. We have very good centers in South Hyderabad and Chennai. So if we want to get trained, it's an ideal place to go for a couple of weeks. As part of the Indian Association of Cardiac Thoracic, we had fellowship programs in transplant a couple of years back. That's not being done, continuing now. But we do encourage, as part of the INHLT, we encourage people to go for a short-term fellowship for 15 years. Anybody who's a member of the Indian Association of Heart Transplant, Heart and Lung Transplant, can apply for it and go to centers. Some centers like Dr. Bala's place in Chennai, they offer a observership program of 15 days. Networking is very important, especially in cardiac surgery. We have to have the cardiologists in place who's treating heart failure and listing your heart failure patients for transplant. And of course, the neurosurgeons are the most important when it comes to donor pool. And if we are retrieving organs from outside, then we'll have to have a good network with the airport, traffic police, and other things in place, and with the ICU of that place. And you should be able to retrieve the organ in such a way that we know the time from which you land, come back, the warm ischemia time, and when they'll start the recipient side according to your flight status or the road transport available. Once you have this protocol, you should have mock drills, because these are, as they said, the organ is a gift to the nation. So you have to make best use of it. For that, you'll have to have mock drills, so there's no delays there, because ischemia time is very important when it comes to transplant in any organ. Heart transplant requires a few other extra things like sternotomy saw and certain small things like retrieval centers where you're going, you may not have a sternal saw if they are not doing thoracic work. So it is a must to have your own instrument. When you go with a team, you have your handheld straw, and have as simple as ice crush may not be available for transporting the organ back. So these small steps you'll have to take care, and you'll have to have the custodial solution as HTK solution for organ preservation. And if you're doing for lung transplant for DEX, all this have to be part of your system, because the retrieving hospital may not have any of this, or they may not be able to provide you at late hours. So it is important to have your own system, take your own machine and equipment. The most important thing is to evaluate the donor, optimize, because the outcomes directly depend on how well you optimize the donor. For some people, kidney people want more fluid to be given to have the organ functioning. For lung fellow, we don't want too much of fluid to be there. So all this, you'll have to take a balanced approach when you're optimizing the patient. That's important, because each organ is different, and a lung person will like the lung to be dry. The kidney persons will have the CVP as maximum as possible. The heart will not require too much of inotropes, but the liver people may want a good systemic map pressures to be very good. So all this you'll have to take in consideration when you're going in for a retrieval. As I said, donor management outcome will depend on how well you manage the donor and how well you can coordinate with the recipient center, time the surgery properly, bring it at the right time back to the recipient area. When you go, you'll have to make sure these are the basic fundamental things. You'll have to make sure that no error happens. Donor consent is important. Donor management is important. You communicate with the other team about the matching, ABO matching, size matching, and which person can have the recipient, and mobilize your recipient accordingly. You have a set of people with the same group, mobilize them. If they are in and around, it'll be much easier, but you have to time it, because they may not be in and around. They may take a couple of hours to reach, so you have to bring them back. We have to make them, it's important to have NPO status. All this you plan according to the retrieval. Team briefing is important, because each member of the team should know what they are doing and when they are supposed to start. And also important timing is everything in organ transplant. This is about the technicalities. I don't want to go. You will have to, within the transplant team, you'll have to know what the abdominal surgeon wants, how much you want. If you have a heart only retrieval, it'll be a little different. If you want the other person is taking the lung, how much of the left atrium you'll have to take. All this you'll have to coordinate. Similar with the liver surgeon, how much of the IVC you'll require. All this has to be coordinated And when you go, it should be clockwork. You should work in a clockwork position. And if you're taking the heart, you'll have to make sure the other people are ready for the heart to be stopped. And if you're taking the lung, accordingly, you'll have to have your staplers. You'll have to have your solution for heart and lung separately. Once you start the solution, then you'll have to make sure the heart doesn't distend. And when you're taking the harvesting heart, you have to make sure if you're a lung, then you are making an incision, the left atrial appendage, you'll have to make a note of it so that the receiving team knows there is a hole in the left atrium. All these things are important because when you start the solution to stop the heart should not distend. Same way, you make sure the left atrium doesn't distend, that will affect the left ventricular function. These are some steps I don't think will be required to know. Of course, organ preservation is very important because I said the most important thing to take crushed ice and pack it properly. Like donor optimization, retrieval and transport is as important as for the outcomes. Ischemic time is very important, so you'll have to plan, as I said before. You have to document when you clamp, what time you have started the cardioplegia, what time you have prevented the distension. All this you make small. You can make stay sutures to make which is anterior, which is posterior, which is the left atrial side, or if I made the incision. Some people make only in the pulmonary vein for prevent distension. Sometimes they amputate the left atrium appendage, so that has to be made a mention so that the recipient team knows what they are doing. This I've already discussed. The outcome depends on the donor optimization and the transport, how well you transport it. Then local protocol is important because you know what exactly you're doing, how to go about it, and as I said, you don't have to reinvent it. You go to a center which does maximum work, which does successful work, and just copy it, and as you proceed you'll know how much to change over time. Successful art or any organ donor starts from the time of harvest, before the organ reaches your hospital. As always said, the organ is a gift to the nation. You have to make sure that you account for it and make sure consistently we honor the donor. We have the best outcome in the recipient to have the best available organs, not only heart, any organ. Thank you.
Hello. Thank you, Dr. Deva Venu, sir. Actually, I'm Dr. Navneet Saxena, Dean, Medical College, Jabalpur. Recently, I mean, last year, we had harvest of the 3 times. So we made the corridor for 3 times. And the first time, the heart was sent to the AIIMS Bhopal and they did very successfully. And I was talking to Dr. Vikram, so he said the patient is doing very well. What problem I faced, in fact, what I agree with you, and of course, all the things, but the mock drill, as you said, it should be done on regular basis. So each member of the team should know what work is to be done, when it is to be done, and how it's to be done. Because it's a teamwork, definitely. It's a teamwork. No one can do alone, in fact. So first time when we made, it was really very hectic. Whole night I was in communication with the collector, communication with the SP to make it, and corridor, and when the flight is coming and the night landing and this, and it was a really hectic one. But the second time it was cool, and the third time everybody was knowing lot of paperwork to be done, lot of technician maintenance of the vitals, and the time of the retrieval, and the time of the travel time, ischemic time. So in fact, it is, I personally feel, because we have still our team of transplant here in the super specialty hospital. So separate infrastructure, number one, a full dedicated team, number two, including from technician to everyone, should be there. The best or the first role of the TC, that is the transplant coordinator. So In fact, you
they
have.
want us to take these questions in the open house next
Okay,
session.
okay. Thank you. Thank you.
Thank you.
Anyway, thank you very much, sir. Thank you.
Thank you so much, sir, for highlighting the technical and human resource necessary to sustain a world-class transplant program. I would request our chairpersons to continue with the next session also. Our final talk of this under this segment of the session explores technological advances in organ transplantation, surgical and medical innovations. To enlighten us with this session, may I now request and invite Dr. Sonal Asthana, Chief Liver Transplant Surgeon at Aster Hospital, Bangalore. Trained in the UK and Canada, Dr. Asthana is a pioneer in multi-organ transplantation and clinical islet cell research. Sir, we look forward for your insights. Thank you.
Good afternoon. So the final talk of the first session comes to me, and so thank you so much for being here, and thank you so much to the National Academy for this invitation, Professor Kaur, Professor Chavala, for giving me this opportunity. So I've had the opportunity to listen to various stalwarts. It's always a pleasure to listen to Dr. Seth and Dr. Chavala as well about how the ecosystem is built up and how we have evolved over the last 10 or 12 years. So two things probably come out to mind. Firstly, that we should look at innovation from a larger lens than just looking at bolts and nuts that we talk about. In the Indian scenario, we have to innovate when it comes to service delivery, when it comes to performance of transplant, when it comes to technology, when it also comes to many other things so that transplant becomes accessible and affordable. So we need a wider lens to look at transplant. And the second thing is that we must learn from each other. What we have discussed in great detail today is a clear example of siloed thinking. We have there's a very common saying, right? The future is already here. It is just not evenly distributed. So we know that there are parts of our country that are already doing transplant to a great degree. Tamil Nadu has donation rates of 4 to 5 part per million, and the rest of India does not. So why do we not learn from Tamil Nadu? Why do we have to learn to the US or the UK? So silos are probably what's actually limiting us a little bit more. With that rant, I'll just make a start. These are my appointments. I don't have any conflicts of interest for this particular talk. So we'll talk a little bit about our journey so far. This will be fast because a lot of the discussion has occurred. We'll talk about the dominance of liver donor transplant, especially in the kidney and the liver setting. I've been asked to talk a little bit about the building up of a liver transplant program, which because Dr. Modi is not here. And then we talk about innovation as well as building capacity beyond, tier one cities, so to speak. So liver transplant in India in generally has been a fairly unqualified success story. From the time when our Athota was declared in 1994, you can see that although it started slowly, it built up over a period of time, and the last 6 or 7 years have actually been, the exponential part of the curve, so to speak. But this has been driven in a large part by uh, an increase in the living donor transplant alone. When we look at the gap, the demand and the supply gap, a lot has been talked about this already. For every 50,000 patients who require a transplant, we perhaps transplant 1 in 10. And you must also remember the transplants done in India, almost 20% of them go for non-Indian transplants as well. So out of 5,000 transplants that are done for livers every year, only 4,000 actually benefit Indians directly. So there is a very big demand and supply gap. Just by sheer dint of numbers, we are among the top 3 countries in the world that performs transplant. But look at the split of the transplants. Most of the transplants that are performed in India are coming from living donors as coming from deceased donors. So the total number of transplants I'll discuss is close to 20,000. Most of these are living donor transplants. The number of deceased donors are actually, unfortunately, almost flat. In our country of about 1.4 billion, we have about 1,200 donors. But what's more interesting is the split of these donations. A vast majority of the donations of India occur in the south and the west of this country. And this has been historically true. And if anything, this gap has been growing over the last decade or so. In fact, my state, Karnataka, is probably the only state in India where there have been more deceased donor transplants than living donor transplants, actually. When we look at the living donor transplant split, about 1 in 5 transplants across India come from living donors. But look at the difference between the south, the north, and the west. In the south, almost 40% of the transplants done come from deceased donors. In the north, only 5% of the transplants done come from deceased donors. In fact, if you drew a line between India at about just above the level of the Vindhyas, 95% of Indian donations would come from below that line. So clearly, there is already a very good use case in front of us. We can learn from each other. We need to perhaps learn from each other and factor in the differences of different states and provinces that already occur in our country so that we can increase our understanding. So we already know how our system is divided, NATO, SOTO, and ROTO. There are also a lot of NGOs that are involved, which play human service in actually promoting public awareness about organ donation, as well as setting up SOPs. And large parts of our country are covered. Some countries, some states are active, some not so much, but mostly most of the country is actually covered right now. And more importantly than before, these are obviously very good things. We have very clear guidelines of what each NATO, ROTO, and SOTO should do. So this makes it very easy for us to launch a new SOTO, for example, or set out SOPs for a new ROTO so that they can understand how to work with each other. So what does it take to set up a liver transplant program? So AIIMS Bhopal wanting to set up liver transplant program after doing kidney, after doing heart transplants. What would it take to actually set this up? So if we break this up, if we break it up into infrastructure, personnel, equipment, and service delivery, we have to look at different components of how this would be working. Infrastructure is probably the smallest part of this right now. Any hospital that does cardiac surgeries, cardiac bypass surgery, and renal transplant can do liver transplant. Okay. Infrastructure is probably a solved problem in India right now, especially when it comes to INIs. I understand that district hospitals are different and there are places which do not have the capex, etc. But especially in a place such as AIIMS Bhopal, if the answer question is, can transplant happen here? It can definitely happen here. So when we talk about certain equipment, thrombolastograph, QSA, etc., those can be managed. Surgical equipment are widely available. ICUs are usually well established already. It's important to have ICUs with built-in isolation and a positive pressure flow with specific laminar flow that is important for isolation perspectives. We also need to look at the ancillary things that are required in terms of transplant wards, dedicated teams, dedicated administrative support for running a transplant. As well as, of course, as Dr. Grover had mentioned in his talk, we also need to make sure that the hospital runs. The labs are available, the ABGs are available, and the medicines are available around the clock. Now, that's a transplant team when it comes to liver. Remember, I've put the hepatologists first, not the transplant surgeons, because it's extremely important to remember that the coordination of this entire process is actually predominantly a medical endeavor. Okay, it's important to realize where we fit into the system. These are basically broad requirements that were set up by the Liver Transplant Society of India when we talked about how transplant centers should be set up. So now, of course, when we talk about teams, there should be a core team that is trained in transplantation. And of course, there are ancillary teams that could learn while the transplants are being performed in the unit. So, of course, you need surgeons, hepatologists, anesthetists, intensive care people, as well as support staff. When we talk about training, it's good for people to be exposed to high volumes of transplant. It's not necessary or not enough to just go and spend some time observing a transplant in a setup, because it's actually important to understand how the process works, how the SOPs work, how people handle difficult situations, etc. So these are some illustrative numbers that we had put together as a white paper when it came to transplant training approximately 8 or 9 years ago. And I think these are largely still true. So in our country, the problem is transplant surgeons are actually an anomaly. It's usually an extension of the anatomical process that we normally follow. A GI surgeon will do liver, a urologist will do kidney transplant, and a cardiac surgeon will do heart transplant. But it does not necessarily follow. One is surgical competency, but also the other thing is understanding and having the aptitude of understanding of managing transplantation. So what are the core attributes? Of course, we know that you have to be a good vascular surgeon, you have to good surgical skills, you should be a good doctor, but most importantly, you should be humble. You need to know that this is a team spirit and its team sport in its entirety. And if you do not play as a team, then you're not going to win here. Then, of course, these are the knowledge components. When we come to surgical trainees right now, perhaps the training component in our current curriculum is not well established. We need to work more on that. That's something that NAMS can work on, and that can be helped a little bit by targeted surgical courses. How can courses or how can centers benefit? So the Liver Transplant Society of India, which is a professional body, has a center mentoring program where a center is picked up as a mentee center by a mentoring center. Then all the knowledge and skills can be transferred directly from a mentor center to a mentee center, and then there can be evaluations as well as a period before autonomy occurs. The key bit here is to understand, like I said, it is not about the equipment we have anymore. It's actually about the people. The human resources are the core resources when it comes to developing a transplant program. Everything else is fungible. You can actually get OTs, you can get ICUs, you can get kit, but you cannot get a team that works well together. So this is what I just mentioned, the LTSS Center Mentoring Program. I'd like to talk to you a little bit about a targeted training program. Professor Chawla had mentioned it very kindly in his talk as well. So as we have discussed, retrievals can happen anywhere across the country, and it may happen in centers where hospitals have not been exposed to retrieving organs at all. So there is a need for surgeons who are able to safely retrieve organs, who may not necessarily be transplant surgeons. But this is not part of any surgical curricula. To specifically address this need, we had designed a course along with the UK NHSBT, which we currently administer in Bangalore, where we train surgeons in the art and science of organ retrieval. So this is a 2-day course. This is done at MS Ramaya Medical College, where we use frozen cadavers, which gives a very, very life experience. This teaches us all the surgeons, that includes liver surgeons, renal surgeons, heart and lung surgeons, in the steps of organ recovery, and more importantly, of how to work together when it comes to recovering organs. So this course has been running for the last 10 years, and this course actually is very well sort of. We have trained more than 300 surgeons right now. I just want to play a little video. This is a simulation that we have done, again, when it comes to innovation, of how to train people on how to suture organs for liver transplant. So see, this is a very simple innovation. It's all 3D printed. It's a silicone model. This is a Perspex glass box. And just to get to the angle of suturing the liver, you can see as the trainee is doing very well, we have to create a simulation of difficulty so that vascular surgery can be performed in a way. And of course, this can be very well observed by any mentor that exists. So this is a very simple simulation model that we have developed to train people in how to suture organs for organ transplantation. So this is some of the resources. We've trained about 193 people on organ transplantation, organ retrieval, and many of them have gone on to actually start successful programs as well. So now coming back to point number 1, innovation is a very, very broad umbrella. So when we talk about innovation, there can be frugal innovation, bloodless transplantation, or not using hepatitis B immunoglobulin, for example. These were first pioneered in India. Surgical advancements like Professor Rela's unit does, Dr. Pamecha does RCTs in surgery, which is very, very difficult. And, so all of us have actually played some part in some degree of this innovation. So one example is, of course, mapping out the liver. We know that the liver has got 8 parts. That's why we can do right and left lobe transplants. We can select lobes carefully, but we have to be very careful about making sure that the vasculature and the volume of the liver that we are taking from the living donor is safe. This is normally done right now by CT volumetry. We can actually measure the size of the liver that we take out. We can also do a virtual hepatectomy before laying a knife on anybody. This was a 9-year-old child who needed a transplant for Wilson's disease. So you can see that we have done a simulated left hepatectomy. So we know how much liver the child is getting, how much liver will be left behind with the mom. So this is currently existing. Now, if we take this one step further, using the CT scan images, we can actually print a 3D model of the liver completely. So we have done this for the first time in India to use for a pediatric transplant planning. So you can see that the blood vessels are printed in a colored plastic. The rest of it is in silicone. So this is an excellent training tool for trainees who need to learn how to actually divide a liver or to decide on the line of transaction. This helps us very, very well. And then when we go forward, you can actually do a virtual reality planning as well. This is very easy to do. This took me less than half an hour to do, and you can tell that the quality is not very good. But the reality is that with the current imaging techniques that we have, it is really possible to use these tools and incorporate it into surgical planning already. This is possible in India today. And when we talk about the rise of the machines right now, of course, there's a lot of machines we'll be talking about, mostly robotic hepatectomies, living donor robotic hepatectomy. India is actually among the top countries in the world that does robotic living donor hepatectomy. It really reduces, the recovery time for the donors. The other important part that we talked about is organ preservation. So we saw this machine before. This is called a normothermic organ preservation. So what this basically does is preserves the organ outside the body. It circulates blood which is oxygenated and gives it some nutrients in the organ outside the body. So with this, the organs can stay viable outside the body for longer. So this machine was developed in Oxford. We were the first center to use it in Asia in 2017. But as Dr. Seth mentioned, this costs 5 crores. It costs 7 lakhs to deploy, not 5. It costs 7 lakhs to deploy. So it was obviously a very, very big problem. And it is getting to be a bigger problem right now because most of the organs we see today are actually marginal organs. So when you go to say IT centers like Bangalore and Hyderabad, they're hubs for fatty liver disease. 84% of our IT community has got fatty liver disease. So unfortunately, most of the organs that we get right now look something like this. They look very, very yellow. So when we actually have to try to use marginal organs, we have to increase the utilization of these. So basically what normothermic machine perfusion does, as you can see here, this organ is connected outside the body. You can see that the blood is flowing in, started to flow into the liver. It is animating. Now it's becoming pink. From a yellowish color, it becomes pink. And immediately you can see the liver function start. You can see that the bile starts to come here inside the T-tube that's put inside the bile duct. So it's a very, very good way of not just animating the liver, but also making sure that the liver is viable. So Dr. Mathur, who was part of the task force that Dr. Chawla mentioned, had initially started some work in Bombay using normothermic liver perfusion for dogs. And this is something I'd like to share with you. This is from IIT Chennai. This will probably interest Dr. Grover and Dr. Dev Guru a little bit more. This is actually a sheep heart that has been animated after slaughter after 8 minutes, and it has been revived, and this has been kept alive outside the body for 8 hours. So ex vivo organ perfusion can really change the game for heart transplants and lung transplants. Where hearts that are shocked because of injury, etc., can be revived very, very carefully and managed outside the body. So this work is currently going on in IIT Madras. We have also done some work on the liver. What we have done differently from what has been reported in the literature is using a new technique called spectroscopy to assess the viability of these organs, so that we can actually do the spectroscopy photography, and we can actually ensure that the organs are well perfused and viable before we transplant them. So what can we do with this machine? We can do a lot with this machine. Currently, we've heard about xenotransplant, right? So we can take an organ from a pig, put it in the machine, and keep it outside the body, so that if patients have acute liver failure, they can actually be managed outside as what is called a bridge to recovery or bridge to transplant therapy. So this has been already done in China, and this is also something very interesting. You can actually perfuse the organ outside the body, remove the carbohydrate moieties of blood groups, and you can convert an A blood group or an B blood group kidney into a universal blood group kidney. So this means that if we have the right technology, we can not just expand what we are doing, we can actually change the game. AI I shall not talk about because we have a lot of discussions. I just want to tell you that there is something called the Indian Liver Transplant Registry, which has been running for the last 6 years. We have data on almost 12,000 transplants done in India across the last 6 years. We have a very good amount of follow-up, especially in the recent years. And this is perhaps the largest single repository of data on transplantation in the world of its kind. So we talked about building capacity during beyond metro cities. This picture is from Dr. Pamecha's team. They recently came to AIIMS Bhubaneswar to help mentor the program there to start doing transplantation. So this is perhaps one way in which centers that are established can actually mentor other centers in starting a program. So it's not all roses, of course, we know. There are a lot of institutional challenges. These are all individual-led efforts. These are they are non-transplant affiliated donation champions don't exist. Donor costs are not covered. We talked about it. And of course, there is a problem with regulation as well. There is probably the biggest part, the third part of the public-private divide. We talked about silos before. And I would really encourage NAMS and the society here to start thinking outside those silos. Because currently the largest expertise, at least in liver transplant and perhaps lung transplant as well, in the world exists in India right now. Okay. So there is no need to look outside. There's probably just a way of tweaking our mechanism so that we can utilize people like Dr. Soin, Dr. Gupta, Professor Ela if you're able to benefit from them and train people, what's wrong with that? We perhaps need to look a little bit differently, I think, outside the box about how we can utilize our luminaries better, be they be in the private sector, because they're not the enemy. And of course, fair and equitable access. So the last part of what I'll talk about, I'll take 2 minutes on. This is probably the most important part of innovation for me. Where does the rubber hit the road? How can we make sure that all we talked about will benefit the man on the street? As Gandhi said, right? When you actually are thinking about something, think about the poorest man you see. How would it benefit them? So we are very good at actually cutting costs down. We know that people make move without moon missions, and we are able to launch moon missions at prices less than it costs movies to make about them. So India is actually very good at transplant at cost cutting. So when you look at the number of costs for India, when you talk about liver transplantation, when we compare the cost of a transplant in India versus the US, the costs are almost 20 to 30 times less. The problem is the ability to pay. Most of our people are paying out of pocket, they're not covered by insurance, and most people are not able to pay for this. So how do we actually make transplant affordable? So the last part of what I'm going to talk about is how to convert a 25 lakh transplant into a 2.5 lakh transplant. How can we make sure that the service delivery happens at a cost that is affordable to people? So this happened primarily because of this child, Ashwini, whose father works in Bangalore in a factory. He earned 7,000 rupees per month. She got liver failure. Mother was a donor. We transplanted because that's what we know how to do. Then we realized that there was a lot of money to be paid. And then we had to actually find a mechanism of paying for her. She did well because of, like Dr. Saxena just mentioned, we had to learn on the fly. We had to learn how to raise money on the fly, and we were able to help her. But thanks to Ashwini's case, we were able to put together a funding model that involved the patient, crowdfunding, and CSR in order to pay for a very, very expensive treatment. This is basically how the flywheel works. The family pays some amount comes through crowdfunding. It is subsidized through the hospital and industry, and there is, of course, corporate sponsorship that comes in for a child on an individual basis. So how does this primarily work? It works through social media. When we talk about crowdfunding is nothing but a targeted appeal to people who are likely to contribute to the payment of an individual using social media. So if Facebook was a country, we know that it would be a very big country, and it would probably have a lot of Indians, because Indians are very, 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 very popular on Facebook. So now I'd like to give you one experiment. When we take the total number of Indians on Facebook, and we look at the total experience of AIIMS Bharat, this is a few years old, you can realize that if every Indian on Facebook paid 200 rupees per year, you could fund India's health budget. We talk about Boond Boond Se Sagar. This is the impact of what social media can do for crowdfunding. For children like Tanmay, whose father drives an Uber car in Bangalore, he had hepatoblastoma. We were able to raise 18 lakhs for him in 4 days' time to pay for a transplant. So this is Tanmay's dad and Tanmay's mom. We transplanted him. It's actually 10 years since his transplant now. So like this, we've actually gone through many, many children. We've put the system together, and we have also refined this. I'm just giving you a very, very high overview. It's not as simple. It's crowdfunding as well as CSR and using some impact funding to ensure that people's complications are paid for as well. So we've done about 256 transplants so far. We've raised close to 12 crores of money, and we've got about 88% survival over the last 10 or 11 years since we've been running this program. And what's more interesting to us is that IIM has actually written this up as a case study on how to raise money using philanthropy. And I never thought that a boy from Dehradun would be in the Harvard Business Review, but there I am. So this is basically when you actually try to solve your own problems, you end up solving a lot of other people's problems as well. So when we talk about innovation, it's important to move away just from thinking that it's about machines. It's also about service delivery at the very end, about what impact we're actually able to make for children such as this. So is it fulfilling? I would say it is, because right now we are in a situation which has a lot of promise and potential. It's never perfect, never is actually, but we have to start where we are and do what we can. Thank you. Thank you.
Thank you so much, sir, for your insightful session on the innovations reshaping our surgical landscapes. Thank you so much for all the chairpersons. Now, as we reach to the culmination of our first scientific session, we invite you to a preeminent panel of academic deliberations. I now announce the commencement of the panel discussion and open house focusing on the ethical, legal, and strategic challenges in organ transplantations in India. For this, the session will be moderated by Professor Dr. Yogesh Chawla, former director of PGI-MER and chairperson of NAMS. For this session, I would like to request the panelists to be seated at their places since this is an open discussion, open house discussion. For our external resource faculties, we have Professor Dr. Sonal Asthana, Chief Liver Transplant Surgeon, Aster Hospital, Bangalore. We have Professor Dr. Vipin Kaushal, Medical Superintendent PGI Chandigarh, and Professor Dr. V. Deva Gauru, Professor and Head CTVS AIIMS New Delhi. We have Dr. Colonel Avneesh Seth, VSM, Country Head, Manipal Organ Sharing and Transplant, Delhi. Professor Dr. Vijay Grover, Professor and Head CTVS, RML Hospital, New Delhi. For representing the multidisciplinary expertise of AIIMS Bhopal, we have Professor Dr. Debashish Biswas, Professor and Head Microbiology. We have Professor Dr. Amit Agrawal, Professor and Head Neurosurgery. Professor Dr. Saurabh Sehgal, Professor Critical Care. Professor Dr. Vikas Gupta, Medical Superintendent. Professor Dr. Vaishali Walke, Professor and Head Pathology. We have Dr. Ajay Shukla, Additional Professor Pharmacology. Dr. Roshan Sutar, Associate Professor Psychiatry, and Professor Puri Vittal Prakash, Associate Professor Physical Medicine and Rehabilitation. We have Mr. Dinesh Meena, a transplant coordinator. From the state and regional representatives, we have from Soto Bhopal, Professor Dr. Kavita Kumar and Dr. Naveen Kumar. From Soto Madhya Pradesh, we have Dr. Padmini Sirkanongo. And from AIIMS Nagpur, we have Dr. Chandrakant Munjewar and Dr. Ronak Dubey. And representing our regional centers, we have Dr. Rakesh Bhargava and Dr. Navneet Saxena from Jalpur. Thank you so much.
We've had some excellent talks by the experts, and I'm sure you must have gained a lot for a institute which is likely to do more of multi-organ transplants. I would like the audience to ask questions to whosoever has spoken, but just to set the ball rolling, I would I would ask Sonal Asthana, as we were just discussing, that a lot of innovations have happened from the Indian context. And one thing which impressed me most was the use of wearables for assessing the immunosuppressive levels. You don't have to give a prick to the patient after you've done a transplant. So any experience on that, or any new ideas?
There are 2 or 3 new interesting things happening in the immunosuppressive space, because as you know, immunosuppressions have to be taken on a regular basis twice a day, and there is always a peak and a trough of immunosuppression. So peaks will actually add to the toxicity, but the effect is actually determined by the trough of the medication. So sustained release immunosuppression is something that is coming out in a big way right now. We know that there's a once daily pill that is available right now, but there is some work going on hydrogels that are incorporated with tacrolimus, for example, which can be put inside the cheek, from which they can leach out slowly, as well as these will not be responsible or just be limited by people being able to swallow them. Now, sensor-based assessment of immunosuppressive levels is something that is currently going on. It can be used, sensors can be used using the levels of tacrolimus in the sweat, for example. This can also be worn as a patch on the body. which can then be read by Bluetooth. So these are the two things that are currently in development.
So I think this is very important because earlier on it used to be said that you treat a patient for liver transplant and you give him another disease. So most of these immunosuppressive drugs tend to produce diabetes, obesity, hypertension. So that affects the kidneys. So with wearables being available to us, maybe in the new future, there is always a talk on reducing the immunosuppression, but to what extent this reduction is, we are not very sure of the levels. Yeah.
Some new technology may help us actually refine our immunosuppression better. Donor-derived cell-free DNA, because that's a test that we can do in the blood that will tell us whether there is any injury to the organ. So this is actually much more sensitive than our current biochemical test that we use. And we know that certain groups have already started to use it to minimize the immunosuppression as well.
Okay, right. The question to you, Avnish. You get a patient with metabolic disorders. How would you assess that this patient is suitable for organ donation? He has diabetes for 25 years, hypertension. This is a question which would occur in everybody's mind.
Yeah. So, see, age is no criteria when it comes to organ donation. You could be a not very good 50 or a good 70. So, talking about metabolic disorder, what we are worried about is fatty liver. That is our main concern. And we have a good way to judge with the CT scan. A non-contrast CT scan gives us a very good idea. We don't want more than about 10% fat in the liver in a living donor liver transplant. And there are times where we have actually brought down the fat content by good diet control, exercise program in 3 months. Sometimes a gastric balloon has been put to reduce the fat and make it okay. Liver biopsy we normally don't resort to, but non-invasive tests are pretty okay. So.
Yeah, but this is you're talking on the terms of a living related donation. But if you have a cadaver who's had diabetes for 25 years,
we would go by the liver function test, and if need in a cadaver situation, liver biopsy can be done. So.
Okay. And the kidneys also, a kidney biopsy also may be required. So we come to the point of marginal donors. So Sonal, you did mention about that. So can you also tell us about the expanded criteria, more from the liver angle? Kidneys, we don't have a specialist here. Pranjal Modi would have been the right person to have answered that. But if you can, it's wonderful.
Sure.
From the liver point of view.
Now, I'll start from the liver perspective. So the liver is a very, as you well know, it's a very magical organ in that it can regenerate at any age. Very recently, there was an article where a 100-year World War II veteran actually went ahead and donated their organs. So there was a in the US, a 100-year-old veteran came forward as a donor, and they donated their organs. These organs were actually pumped by a machine very similar to what Dr. Seth has developed and actually utilized for organ transplant. So for liver, age is not a criteria. That's probably the first one. Dr. Seth has already said that very clearly. But what we are seeing nowadays is that a lot of livers do have some sort of metabolic liver disease, most commonly fat in the liver. So what causes the liver to become marginal as opposed to a standard liver? So age is probably a lesser criteria. But what's more important is how the donor has been managed. We've not talked about that so far in our deliberations. But what typically happens is that if you have a trauma patient who had hypovolemic shock, they may be managed in a district hospital where the BP is running at 40, 50 for several hours. And they may not have any urine output, acid builds up, for example. So these patients are not very well managed when it comes to the trauma perspective. This impacts all the organs. So the commonest cause of a marginal donor in our setting is actually a poorly managed donor. A donor who's not been well managed in the periphery when the donor was alive and before the potential donor became brain dead. So that is one. Donors who've been in the ICU for a long period of time, because they can develop sepsis, anyone in ICU for more than 4 or 5 days can get sepsis, for example. So age, poor donor measures, sepsis, fat in the donor, and of course trauma, direct trauma to the liver. These are things that can actually make an impact and make an organ become marginal. When it comes to the kidney, age is a distinct requirement. Older kidneys are not as good as younger kidneys. Older kidneys do not do as well as younger kidneys. And clearly, even our matching algorithms will allocate older kidneys to older recipients. Okay. If the presence of diabetes, the presence of hypertension, the presence of poor donor management are things that can actually make a normal kidney marginal.
Thank you. Physiotherapists and psychiatrists play an important part. So we had invited from AIIMS Bhopal the psychiatrist and physiotherapist. How well are they prepared for it? And that's an important component if you're banking on a transplant program. Yeah. And a microbiologist.
Actually, sir, I am not the physiotherapist, but I am from physical medicine and rehabilitation department. Physiotherapist is one of the team member of our team. Actually, not in in kidney donor, kidney transplant or other organ transplant, but in particular heart transplant, heart lung transplant, the PMR specialist role is very vital. That is, there are two steps. That is pre-rehabilitation. Actually, when we think about the transplant, the recipient should assess if that is lung expansion and thoracic expansion, exercise, breathing patterns should be evaluated. Then all muscle power, that is a clinical evaluation done. And to improve the endurance of whole body, that is posture, strength, we give some rehab protocol to that patient.
So basically, sarcopenia is a major problem in these patients, and you would like to correct that if possible before surgery and maybe after surgery as well.
Yes, sir.
Fine. What about the psychiatrist?
I think psychiatrist's role is important as we are talking about the organ transplant. So the institutional preparedness, as we are doing kidney transplant and bone marrow transplant, we have been routinely observing patients, including donor as well as recipients. We are thoroughly assessing them for preparedness, knowing the process of transplantation and substance use, personality issues, pre-existing depression, anxiety disorder, and whether they had any psychiatric history in the past. For example, alcohol use disorder, like sir mentioned, it's high probability that relapse can lead to a lot of complication in the transplant, liver transplant patient. So we have to preempt and you have to anticipate the
You're
risk.
actively involved in you're aware of, you're helping these patients
Yes.
with BMT and kidney and of course the cardiac people. Sir.
Just want to add a point. As far as the liver and lung transplant or a kidney transplant, probably the role of physiotherapy and psychiatry is little less important as compared to the hand and face transplant, which is now happening world over. Even in India, we are using. Right. I think psychiatry plays a very, very important role in face transplant. There are several reports. One of the comment which was made that by a patient that I don't look like what I was before as a recipient, and I don't look fit into the image of the donor also. Mm-hmm. So it is very, very important to accept the transplant, and it's very vital in face transplant.
Absolutely, we totally agree with that. So any questions from the audience? We haven't heard them interacting. Yogesh, you have any point to...
My question is with Dr. Avnish Seth. Sir, what organs can we harvest from a DCD donor?
From?
DCD.
Deceased donor, okay.
DCD, yes, sir.
So a DCD donor can give you all the organs that a brain dead donor can. Just one exception, small bowel has not been done so far with DCD. So that doesn't work very well. But interesting part is that if a person is dead, the heart has stopped beating, you pull out that heart and put it in a machine and start perfusing blood through it. So what percentage you think the heart will start beating again? A dead heart? 100%. So initially DCD was called donation after cardiac death. But once we started taking the heart and transplanting, then C became donation after circulatory death. So this was in Sydney. There's the Dr. Kumud Hittal, who is now working with us in India. He was in Sydney at that time, who did the first DCD heart transplantation. So he was telling us how he pulled out a heart, put it in a machine, and he was watching it for 12 hours, whether I should put it in someone, may kill that person. And then it actually worked. So DCD lung transplantation results are much better than a DBD lung transplant. That's also a good thing to remember. Because when we have a brain death situation, we normally end up putting so much fluid in the patient to save the kidneys that the lung drown. But the DCD lung outcome is much better than DBD. And as far as liver and kidney are concerned, if you use NRP like we shown you, if you just pull out a liver and transplant, there's a lot of ischemic injury to the bile ducts. So the results are not very good. So liver in DCD, you have to put through some kind of organ preservation. Either we put it in an organ care system, like Dr. Sonal said, which is very expensive, or what we did for less than 1 lakh rupees. Once you started a circulation, then you pull out the liver, you almost convert a DCD into a DBD because you're flowing, the blood is flowing. So except for small bowel, we have done the first DCD pancreas of the country in PGI Chandigarh. So all organs except small bowel.
Thank you, sir.
Any other questions? Yes.
Good afternoon, sir. I am Dr. Krishna, endocrinology resident. I have a doubt ki even if we have taken the pledge to donate my organ, why haven't we inculcated that the same information is conveyed to family members? Because after the inevitable, it is the family members who has to take this decision. Is there any reason behind not so much talk about this thing in the pledge, or is this a miss out?
I think there is no particular reason for that. It's just for public awareness which should go up. The media should play an important role, and the social media. But there's no other reason for that.
Thank you, sir.
Any other question? Yeah.
So when I was in R&R hospital, just to highlight what you said, somebody said that someone has come to meet you. So in walked into my office on the 5th floor, a 70-year-old gentleman who came all the way from Calcutta to Delhi. He had a thela, chappals, umbrella. He told me, I have 2 sons. One is in Australia, one in US. They don't look after me. My wife has died. I have pledged my organs. I have come to your office. Now I'm going to jump from your window and you will take all my organs. You promised me. So I moved between him and the window, got him some water, and I told him, sir, we cannot take organs like that. So unless your family is there to sign, there is no legal value in that paper. So it's very important. Written at the back of the card is, please keep your family informed about your wishes. So unless you have actually told your family, they won't know that you have signed.
Thank you, sir.
Okay. I don't think we'll take any more questions. It's time. Yeah. Because we want to know, we have the principal from Jabalpur Medical College. And sir, thank you very much. You gave a heart to the Bhopal AIIMS. So what is the preparation going on in Jabalpur? I would like to know from you. And how is the SOTO active in MP? Are they taking some accountability from the medical colleges ki kitne brainstem death kiye? And what better can be done? Just let him answer and then I'll.
Yes, we had given the heart to the AIIMS Bhopal. Actually, it, as I said earlier, that it is a teamwork. So in my super specialty hospital, there is a dedicated team and very, I mean, they know their responsibilities and they were always trying to do something new. So in the history of Medical College of Madhya Pradesh, because since you belongs to Jabalpur Medical College, so we are the first college who has gone for the harvesting of the organ and not for the once time, 3 times. So in fact, in our setup, we have not a dedicated transplant coordinator. We have to have it, which is the main role to play. But somehow we could manage, somehow we could convince the families, because our patient inward is the rural areas. I mean, they don't know about what is this organ is all about. So they don't know it. Exactly, they don't know. Then we have to be very, very gentle, and doctor should not counsel. In fact, if he is counseling, he will say something is some interest in this doctor. So that is the our main
I
issue.
think,
Our TC is there. So
yeah,
always, all the time.
I think you have to recruit a couple of transplant coordinators and have an authorization committee, brainstem death committee. I'm sure you would
Yeah,
be
yeah,
having.
we have everything.
But we would like to learn more from Jabalpur Medical College and Bhopal Medical College.
Yeah, because we
कैसे
have
करेंगे?
applied for the transplant coordinator to the SOTO, and SOTO is doing a wonderful job. And they said that, okay, we'll give you a dedicated TC, because in the Indore Medical College they have it, or Indore city they have it. Because,
एक नहीं मांगना, तीन
दो
चार मांगना.
दो मांगे मैंने
ठीक
दो
है.
मांगे.
Okay. And सोटो से कौन है? हाँ, सर कैसे चल रहा है सोटो आपका यहाँ? I hope you take accountability from the medical colleges कि कितने brainstem death हुए एक महीने में, कितने convert किए हैं. I think that is the
Manish
ultimate
Purohit.
aim.
Manish Purohit, sir.
I'm Dr. Padmini, nephrologist from MGM Medical College, Indore. And as far as the SOTO activities are concerned, it is true.
Mic closer to your mouth.
Yeah, we do have a transplant coordinator at Indore, and we have instructed the transplant coordinator to daily take rounds of neurology, as well as we have a dedicated doctor for that who is taking this is proactive case searching for a brainstem death patient. Unfortunately, we were very close to doing a brainstem retrieval, but we at the last minute the family backed off. So these are, I think, the initial problems that probably every institute since you
So,
sir.
so I think the SOTO should take accountability every month of all the medical colleges under their care कि भाई कितने brainstem death हुए और कितने आपने organ donation किए.
There was a wonderful slide that was shown that showed that these were the number of patients who were screened for brainstem death, and these could be converted into potential donors. So I think we
Very good.
we have to follow that.
Good, good,
Sir,
good.
I wanted to make one point, or I don't know whether this is the right forum, but one of the problems that we are facing in transplantation process is that the basic test, the HLA test, the cross match test, and the DSA test, these are not covered under the Ayushman scheme. And
This is not the right forum to ask. So Ayushman में नहीं जाएंगे.
Sir, if I may ask a
And
question.
you had a question.
Yes, sir. Good afternoon, everyone. I have a question for you, sir. Do you screen for virus these days in liver transplant as well? Because a lot of work is going on in kidney transplant for immunomodulating the virus, sir. Because liver is the most immunotolerant organ, I guess. In solid organ, we see it is the liver where we can even withdraw the immunosuppression after few years of transplant. So to modify that immunosuppression, nowadays in kidney transplant, many centers, even in India, are doing work on virus. Virus just is a ubiquitous enzyme present in almost each and every individual. And as the level of immunosuppression varies, it level goes up or goes down. So you can predict rejection, or you can even modify immunosuppression based on those levels. So you can even predict the immunological event in future. So is there anything going on in liver transplant as well?
So firstly, you can't withdraw immunosuppression in all liver transplantation. You can withdraw it in 20%, but we don't know which 20%. So that's a big problem. So tolerance, I mean, one of my teachers said that tolerance is like jumping off a 20-story building. For the first 19 stories, you think you're flying. It's only when the last story hits, actually, you realize that it wasn't tolerance after all. So the the tricky part is always going to be in how much immunosuppression you need to give, to what degree. As you correctly said, Toctino is used as a mechanism of the degree of immunosuppression. So nowadays, the most of the things that we are looking at is a more dynamic assessment of the degree of immunosuppression, not just the drug levels actually. And now how we look at a lot of the opportunistic viruses, for example, CMV, EBV, is also along these lines. CMV is not an invasive virus all the time. CMV levels are actually a marker of the degree of immunity of the body, immunosuppression of the body. So most of the time when you have a high CMV level, for example, in a liver transplant recipient, you do not need to treat it. All you need to do is to decrease your immunosuppression. So one of the other ways we look at this is also something called ddcfDNA, that is donor-derived cell-free DNA. We look at the amount of the DNA of the donor that is circulating in the body. So if there is a lot of circulating DNA in the body of a recipient, that means that there is organ damage. And that is usually because of rejection. So now there are more sensitive ways of telling how organs may be responding to rejection, which organs may be rejecting early. Toctino is one of them. We aren't checking for it now. Thank you, sir.
Having said that, for liver transplant, rejection is not a major issue. In fact, data shows that people who had a mild or moderate rejection do better in long term than people who don't have a rejection. Unlike other organs, it's not a very major concern.
I think we need to wind up. But before we close, we have a lot of youngsters still sitting. Can you name some movie which has promoted organ donation? And if you don't know, then please go and see that movie. Maybe put it in your OPDs for the patients while they are waiting for you. Is anyone aware of the movie? Air Zindagi, and the other one, Sonal, is Traffic. Two movies worth seeing, and keep it in your OPDs on the television for patients to watch, and that again will give them an idea of organ donation. So thank you very much.
मैंने कहा सर उसको हम लिफ्ट करके भोपाल इंदौर लेके जाएंगे। दूसरी चीज, जैसे गवर्नमेंट प्रमोट कर रही है, भारत सरकार या मध्य प्रदेश सरकार भी गार्ड ऑफ ऑनर कर रहे हैं, लेकिन अगर जो गवर्नमेंट के बड़े बड़े प्रोग्राम्स जो भी होते हैं, जैसे आज हमारे पास ये फ्लैक्स है और हमारे बैनर्स लगे हैं, इसी तरह गवर्नमेंट के कोई भी प्रोग्राम हो उसमें अगर एक स्लोगन हो ऑर्गन डोनेशन का, लाइक दैट, हम कहीं भी फोन करते हैं इलेक्ट्रिसिटी बोर्ड है कहीं भी, तो उनका एक टिपिकल रिंगटोन होती है, तो वैसे एक रिंगटोन में ऑर्गन डोनेशन को प्रमोट क्यों नहीं करते? हमारे हिंदुस्तान में हर जगह पूरे हर सरकार, स्टेट गवर्नमेंट लाडली लक्ष्मी योजना है, कुछ ना कुछ मुफ्त बांटने, तो उसमें एक ऐसा क्लॉज डाल सकते हैं कि भाई जो प्लेज करेगा उसको 20% एक्स्ट्रा मिलेगा, या जो नहीं करेगा उसको 20% कम मिलेगा। एक गांव-गांव में अवेयरनेस तो जाए। हम जैसे अभी वैक्सीनेशन हुआ है, ये गार्डासिल एचपीवी वैक्सीनेशन, उसमें एक जो भी उनका बैनर पोस्टर फ्लैक्स जाता है, जो भी मैसेज जाता है, उसमें एक लाइन ऑर्गेनाइजेशन पे क्यों नहीं होती? उससे एक मैसेज जाएगा गांव-गांव में, आंगनवाड़ी हर 1 किलोमीटर में आंगनवाड़ी है, छोटे-छोटे गांव में आंगनवाड़ी है, वहां पे जो पल्स पोलियो या हर चीज के लिए इतनी अवेयरनेस गवर्नमेंट करती है, तो उसमें एक छोटा सा पोस्टर क्यों नहीं होता ऑर्गन डोनेशन के लिए?
I totally agree on that. So there are complex answers to this, but it is all doable. And thanks for that suggestion. So we close this session. Thank you all for your suggestions and being participative in this program.
Thank you very much, sir, and to all our panelists. We will now break for lunch. The next session on artificial intelligence in healthcare will begin at 2:30 p.m. May I invite all the panelists for a group picture? May I invite all the panelists for a group photograph?
Hello, 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 hello. Hello, hello, hello.
अब भी लगाया 1 सेकंड का बोलो हेलो बोलिए सर हेलो
हेलो हेलो हेलो हेलो
क्या नहीं आ रहा लाइन नहीं आ रही क्या किया रहा लगा ना बड़ी वाली
हेलो
ये खराब अब देखना
चेक हेलो 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 हेलो
Hello. 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 Hello.
Distinguished guests, respected faculty, dear colleagues, and participants, good afternoon to all of you. It's my honor and privilege to welcome you to the second session of today's dissemination workshop and the first regional CME of National Academy of Medical Sciences India, being hosted by All India Institute of Medical Sciences, Bhopal. May I please invite uh, Professor Dr. Ashok Gupta, NAMS Council Member, Maharashtra State Convener, and to chair the session, Professor Dr. Manisha Srivastav, Ma'am, Director BMHRC, Professor Dr. Sangeeta Desai, Ma'am, former Professor and Head Pathology, TMH Mumbai, and Dr. Raju Khan, Chief Scientist, Energy and Environmental Solution Division, CSIR, EMPRI, to please chair this session.
Thank you. Which one have you opened? Which presentation you opened? No, because I just modified it, so I want to make sure that. Can you change the presentation? इसको modify. कौन सा वाला open किया? नहीं, कौन सा वाला open किया? पुराना है, नया वाला? हाँ, इसमें रिवाइज करके लो। आपकी पेन ड्राइव से? हाँ, इसी में है, मेरी पेन ड्राइव रिवाइज वाला है इसमें। रिवाइज? हाँ, यही वाला, हाँ, यही वाला ओपन करो। ठीक है, थैंक यू। Can I start? Honorable chairpersons, shall I start away? Thank you. Thank you. It's a big honor for me to be here amongst all of you and share my thought on the organ transplant. I, being a plastic surgeon and primarily a microvascular reconstructive surgeon, my talk is more on the non-vital, non-life-saving transplant which involve hand and face transplant, which is now coming to the age. You have heard the previous speaker about the kidney transplant, liver transplant, lung transplant. They are monofunction transfer, they are composite solid tissue organ transplant, and they are life-saving. Versus that, what we are dealing with is a hand transplant and a face transplant, which are non-vital and which has got a lot of ethical issues. To begin with, I would like to pay my prayer to Lord Shushruta and Lord Dhanvantri, and just to take back to the historical review. I'm turning 75 and half a century of surgery filled with love, passion, blessing, and unforgettable moments. Amazing voyage filled with wisdom, grace, and abundance of exciting and emotive moments. The tapestry of experience woven over the years emerging as a collection of different challenges, pains, gratitude, and enduring wisdom, particularly with the microvascular surgery and reconstructive surgery. Use of magnification to perform surgical procedures require tremendous skill on the part of surgeon, decreased complications and mortality rate. And I'm proud to have trained over 300 surgeons across the country for microvascular and vascular techniques. And what I'm sharing is more of a passion than a science. I'm thankful to AIIMS Bhopal and NAMS for allowing me to share my experience. And if you look at the history, this is what is even described in Sushruta Samhita. The Dhanvantri has narrated that during the great war of gods, Rudra severed the head of Yajna, and the gods then approached the famous celestial twin surgeons Ashwin Kumara, and they successfully united Yajna's head to trunk, restoring him to life. So this was a head transplant or head replant. Now, if we look back again, there's a mention in Roman Catholic account report in 3rd century saints Damian and Cosmos replacing the gangrenous leg of Roman deacon with a leg of recently deceased Ethiopian. The saints performing the transplant in 4th century, decades after their death. And some of these accounts have been mentioned and surgeons were performing. So transplant, limb transplant, hand transplant is something not of the future. It has already been described centuries ago. But all the credit we must give to Dr. Alexis Carrel, who did the pioneering work way back in 1900, and his vascular technique, 3 triangular technique, which is very well known all over the world, and all these specialties are using that is a triangulation technique, which has laid the solid foundation of vascular anastomosis. He was awarded Nobel Prize in 1912. And along with that vascular technique, he did a lot of limb transplant and organ transplant during his tenure. Then came which I always feel that the wars provided impetus to genesis of modern plastic surgery. Teams of dentists and surgeons successfully treated thousands of patients with complex facial problems. And Blair and Brown, these were the 2 people in the United States which laid the foundation for facial injuries and multiple procedures. And Blair set up the largest multidisciplinary team for the care of post-war maxillofacial injuries. And it is at this unit of Mr. Blair that Dr. Joseph Murray, the plastic surgeon who first did the kidney transplant in the world, was working. And before doing kidney transplant, he did the skin graft transplant between the 2 twins. So first kidney transplant was performed on December 23rd, 1954 by Joseph Murray. The Ronald Herrick became the first healthy human being to subject himself for surgical procedure for a benefit of someone else. And live donor of a kidney to identical twin brother, Richard, dying of an disease of renal disease. So his brother donated kidney, allowed Richard to survive for another 8 years. But the precursor of this kidney transplant was the skin graft between the 2 identical twins, which was also performed by Joseph Murray. So this is how the science has progressed, and they realize
that if the skin grafts are done in two identical twins, there is no immunorejection and there is no need for immunosuppressions. So these few facts have laid foundation. Then the biggest contribution in surgery or microsurgery came from Professor Nyland in 1921. He used the operating microscope. At that time, the microscope was so rudimentary that there was no illumination, there was no auto zoom, there was no facility of control, voice control, etc. And we are very fortunate in 100 years from 1921 to 2021. Now we are equipped with most of the most sophisticated operating microscope, which has triploscope with cold light source, 360 rotation, autofocus, foot control, voice control, and full accessibility. So this is microsurgery has changed from basic to it has become a need of the hour. Practically all the institutions across the world, leading institution, and I feel proud and privileged to, I've been recorded in the history of microsurgery as a third generation microsurgeon. And being the pioneer in India, this was my first free flap in 1980, which I did. First time we realized that a tissue from one part of the body can be transferred alive to other part of the body by joining the microvessel vessels. So this was in 1981 in JJ. First half of the face was reconstructed using free tissue transfer. So this is how the technology has changed. This is the first replant of the hand, amputation of the to the elbow. This was done in 1983, which has laid the foundation for a hand transplant now. So this is the process of replantation, process of free flap transfer in face has laid the foundation for the face transplant, hand transplant. Now, talking about the hand transplant, this is very ironical that the first hand transplant in the world was done on a New Zealander patient, done by a team of surgeons drawn from France, Australia, and United Kingdom, and was performed in France because at that time the ethical committee, and there were a lot of issues, so this New Zealand, Australia, UK, they were not allowing a transplant to be done. So first hand transplant was done in 1998. Of course, because of these several reasons, including immunosuppression, that was re-amputated after some years. So it is a very complex and complicated procedure, and I'm sure all of you would agree that the difference between a solid organ transplant like liver, kidney, and lung are little different than the composite tissue allotransplant, which is hand transplant and face transplant. And it requires a lot of practice, a lot of dissection. So now the first double hand transplant was also done in 1999 in United Kingdom. It was done by Warren Breidenbach in Louisville, Kentucky, and I'm very fortunate. I was his colleague fellow, and I've been trained by the same teachers which was trained by he was trained by Dr. Kleinert and Julia Terzis. Now, India is also not lagging behind like any other specialty. About 190 hand transplants have been performed around the world, including India since 1998. And Amrita Hospital, Kochi became the first center in the country to do the double hand transplant. And after that, they have completed almost 330 CTAs. There are several patients which require face transplant. One of them I would like to share, severe acid burn, which young girl thrown acid and completely has lost all the components of face. These are extremely difficult and challenging situation. And I'm very happy that we tried, we are almost ready for a transplant, but this is what we could achieve with a conventional microvascular techniques by doing restoration of practically 90% of the face. And finally, she got married and she embraced motherhood. Also, this was the first case in the world. Isabella from France was the first person to have partial face transplant. And since partial face transplant, we have now grown into composite full face transplant. Now, there are some situations where there's nothing short of face transplant will work. Like this is one of the girl where acid was thrown. She lost everything on the face, and we are waiting. Emerging field of microsurgery has led to dogmatic shift in treatment of severe facial disfigurement
involving transplanting composite tissue to patient with uh, irreversible facial defect. What we call as a FVCA transplants are transfer of different tissue types such as skin, muscle, bone, nerves, vessels, everything above periosteum, including periosteum, is lifted from the face and they are transplanted like mimetic muscles, nerves, skin, and becomes a complex tissue transplant. The composite tissue allotransplant, which is a CT, has become a clinical reality and a major breakthrough in reconstructive surgery. The long-term medical implications of face transplantations are yet to be yet unknown, but there are little doubt that while the immense psychological burden of disfigurement may at least partially be alleviated, there are other significant risks to someone who is in every respect perfectly healthy. And this raises a million-dollar question of ethics, whether we can allow these patients. So I'll just briefly show the process. Partial transplant, face transplant, which was done. The donor, we identify the area, we dissect that, and it is transferred to a person with a partial face transplant is not so difficult. It is relatively successful. Facial transplants have advantages over traditional method of facial reconstruction by providing patients with a regional functional integrity of the face, including ability to express facial emotions, speak, and swallow, as well as dramatic psychological benefit that are brought about by the facial disfigurement. Introduction of robotic surgery in facial transplantation has transformed potential where great precision, reduced operating trauma, and improved function aesthetic value are awaited. So this is how we are doing, talking about the composite full face transplant, where everything is removed, everything is above the periosteum is dissected, separated out, including periosteum, muscle attachment, nerve attachment. And this is how is the procedure. I mean, looks little ghastly, but this is how everything is dissected out above the periosteum. The donor face looks like this. And this is what one of the specimen of the face which has been ready for transplant. So this is how everything is dissected out. Some of the cases in the world, they are about one of the patient before transplant, and this is after transplant. This is before transplant, and I would agree that nothing short of a full face transplant is the solution for such situation. Now, what are the role of AI? The AI is definitely going to be very useful in a complex situation like this. I don't have to go through all this detail because this is all more of a theoretical, but capacity to analyze extensive and intricate data sets permits a comprehensive assessment of diverse variables, facilitating a comprehension complex medical situation, and incorporation of AI in complex field of solid organ transplant and CTA is a revolutionary component in contemporary medical practice. Basically, it helps us taking a better decision in matching donors and recipients instead of us mentally juggling multiple factors. AI can put everything together and guide forward a better match and outcome. In face transplant, we are working in a window of 6 hours because retrieval and anastomosis has to be completed in a short time. So 6 hours is the maximum time we have for retrieval, another 6 hours maximum time we have for anastomosis and restoration of circulation. So it's extremely challenging issue. Innovation through artificial intelligence, again, so overall it's like an extra layer of support, I would say. Nothing replacing us, just helping us think better and sharper. So skill of a surgeon, infrastructure of the transplant center, and the other support services are essential. I would say, again, AI is revolutionizing the organ transplant by improving donor recipient matching, predicting transplant outcome, and optimizing post-operative care. Ethical concerns are very, very important as far as the hand and face transplants are concerned. And I would say, are the patient expectation realistic, particularly face transplant? Hand, again, whether patient is going to get back the 100% function, whether it will have a sensation, whether it will have a motion. A patient psych prepared for rejection, repeated control of infection episode, daily required immunosuppression, concern of unknown related to ultimate function and potential chronic rejection. How good is this quality of life? With a new limb, daily medication are vital to maintain its viability. Can a limb be easily removed or re-amputated? If both surgeons and patient recognize that chronic rejection is occurring with so much personal time and effort invested by both surgeon and patient, is it worth? And modern medical advances permit one human being to make gift of life to another, must restore organ transplantation to where it really belongs to. No other field of medicine has raised ethical, moral, legal, and social issues as has the organ transplantation. I'm speaking about my specialty of hand and face. Doctors are not obliged to do everything which is technologically possible, and more areas of ethical debates are likely to emerge. Isabella was the first face transplant patient. Note that she looks neither like the woman she was prior to face transplant, nor a dead woman whose face has she inherited. So this is a question posted on each and every patient of face transplant. Face transplantation is not a life-saving need, but has become transformed into an aesthetic procedure. The immense psychological burden of mutilation may be partially alleviated, but other significant risk to someone other than respect healthy. In essence, doctors are doing very strange thing. They are taking fit bodies and making them ill for a lifelong immunosuppression. Are we doing that? So ethical concern, this is again a very big challenge. This is one of the patients, this is the donor face. You can see the donor face mutilation. This is the face transplant ready. And this next picture is of a lady which is ready for a second face transplant because the first is being rejected. So are we justifying this sort of expenses? Face transplant is failing in this patient. So ethical concern, face transplantation offers a reconstructive option for patients with severe facial disfigurement by restoring both function and appearance. Aesthetic outcomes are crucial to psychological well-being, and social integration have historically been evaluated subjectively. Role of robotic, we discussed, increases surgical precision and minimize invasiveness. So what the future lies? I would say the reshaping transplantation with AI, emerging technologies and xenotransplantation. Ultimately, we are going to head for a xenotransplantation. It has got a vast field of promising future. Soon will accomplish face or hand transplantation from other species has been shown in Indian mythology before. And as we all know, Lord Ganesha's head, baby elephant's head being transplanted successfully. So we are hoping that someday we'll be able to achieve xenotransplantation on the face. In conclusion, I would say to people sitting here and people listening, you have the power to save lives. Tell your loved one of the decision which is also in a donor card when you make. Don't take your organs to heaven. God knows they are needed here in earth. Must restore organ transplantation to point it really belongs to. Not an unethical and commercial venture it should be. Modern medical advances permitting human being to make the gift of life. And I'm indeed proud that the development of microsurgery led me to award of the honorary fellowship of the Royal College of Surgeons, and I was also named for the Hunterian lecture, which is a prestigious, and I was also awarded Padma Shri by and the Sheikh Hamdan Award, International Award for Humanitarian Work by the ruler of Dubai. With this, I want to thank AIIMS Bhopal and NAMS for allowing me to share my experience. This is more of a hypothetical situation now, the face transplant. We are ready anytime we may be doing the first face transplant in India. Thank you.
Thank you very much, Professor Gupta. You have nicely presented the basic transportation and what is the role of the AI in the transportation. So thank you very much for a wonderful talk.
Thank you to the chairperson. We will now move on to a keynote address. To chair this session, may I please invite Lieutenant General Dr. Velu Nair, sir, with nation's 3 highest service honor, PVSM, AVSM, and VSM, also President-elect National Academy of Medical Sciences, India, to please chair this session. Also, Professor Dr. Yogesh Chawla, sir, ex-director, PGI-MER, Chairman Task Force on Organ Transplant, NAMS, and Dr. Bhaskar, sir, Director, CSIR, AMPRI, to chair the session. It's my great honor to introduce our keynote speaker, Professor Dr. Y.K. Gupta, sir, Principal Advisor, Indian Strategy Development, Global Antibiotics Research and Development Partnership, President of AIIMS Kalyani, and former President, AIIMS Bhopal and AIIMS Jammu. Sir, please.
नहीं हमारे नहीं है ये हमारी स्लाइड ढूंढ रहे थे मैंने कहा नहीं है फॉर द कंफर्ट फॉर द ऑडियंस एम्स के यहाँ पे बैठे हुए सभी फैकल्टी मेंबर्स डीन एंड माय dear students, some of them, and faculty members, and respected Dr. Chawla sahab, Dr. Velu Nair, Dr. Bhaskar, and Dr. Gupta, and many others. मैं यहाँ पे जब हम यहाँ पे आए तो मुझे याद आ गया कि एम्स भोपाल में मैंने कई बार पहले भी फैकल्टी को एड्रेस किया एंड इट वाज सच ए नॉस्टैल्जिक टू टॉक टू faculty and students of AIIMS Bhopal. And I have traveled across almost all AIIMS. And I must tell you that AIIMS Bhopal, leave other than AIIMS Delhi, is the best. And I'm not telling this because to flatter the AIIMS faculty members, but it is the reality. When you see that AIIMS Bhopal has done heart transplant, renal transplant, bone transplant, corneal transplant, and that's why the NAMS has selected that why not to take AIIMS Bhopal as one of the site for our regional meetings. And similarly, when we talk of artificial intelligence, I think the way the artificial intelligence is being adopted, the way the CSIR and ICMR has funded the projects on artificial intelligence in AIIMS Bhopal, none of other AIIMS has taken that much of lead. So I think we must clap for AIIMS Bhopal again, because you have taken a lead in both these, the contemporary issues. And अभी एक प्रेस कॉन्फ्रेंस में वो प्रेस वाला पूछ रहा था क्या आर्टिफिशियल इंटेलिजेंस सब डॉक्टरों को रिप्लेस कर देगी? कर देगी? नहीं. क्यों? अब आर्टिफिशियल इंटेलिजेंस अगर आप एक फेक वीडियो देखें जो चाइना का है, जिसको लोगों ने कहा वाह वाह क्या आर्टिफिशियल इंटेलिजेंस है, पेशेंट घुसा और पेशेंट डिस्चार्ज हो गया खुशी खुशी, और एक भी डॉक्टर ने उसको टच नहीं किया. बट अल्टीमेटली इट केम आउट टू बी फेक. बट दैट फेक आर्टिफिशियल इंटेलिजेंस का जो फेक वीडियो था, दैट इज अ थॉट प्रोवोकिंग कि ऐसा भी हो सकता है. दैट्स व्हाट आई थिंक, दैट्स द मैसेज इट गेव. द पेशेंट केम, आई थिंक उस वीडियो को देखना चाहिए सबको. फेक है बिल्कुल, लेकिन ए थॉट प्रोवोकिंग है, इंपॉर्टेंट है. तो हमारे पत्रकार जी ने पूछा कि क्या डॉक्टर चले जाएंगे सारे? डॉक्टर चले नहीं जाएंगे. अगर आपको याद हो या जो आप लोगों ने सिखाया, जो हमको जो सिखाया टीचर ने, जब मरीज आता है पेट में दर्द के लिए तो हम उसको लिटा देते हैं, लिटाने के बाद धीरे धीरे उसके पेट पे हाथ फेरो, और धीरे धीरे पेट पे हाथ फेर के उससे फायदा क्या? अरे उससे फायदा डायग्नोसिस नहीं, उससे फायदा यह है कि हमारा पेशेंट के साथ जो एक आत्मीयता का कनेक्शन बना, आधा मरीज तो उससे ठीक हो गया. तभी कहते हैं लोग, वो डॉक्टर को देख के ठीक हो जाता है आधा मरीज। एम्स की बिल्डिंग देखे, हथोर्न इफेक्ट जिसे कहते हैं साइंस में, हथोर्न इफेक्ट। डॉक्टर को देखा, पर्सनालिटी देखी। पर्सनालिटी में जरूरी नहीं है कि 6 फुट लंबा बहुत खूबसूरत हो, या डॉक्टर गुप्ता से फेशियल सर्जरी करा के आया हो। पर्सनल टच कितना है उसमें, वो एक जो पेट में आया पर्सनल टच बना, उसके बाद में पेट की जो गार्डिंग है जिसे कहते हैं टफनेस, स्टिफनेस, वो कम हो गई। उसके बाद में पैल्पिटेशन जब किया, पैल्पेशन किया तो किडनी भी साफ दिखाई दे रही है, रीनल भी साफ दिखाई दे रहा है, पैल्पेट करके उसको पता लग गया। वो आर्टिफिशियल इंटेलिजेंस नहीं कर सकता। कर सकता है? नहीं कर सकता। आर्टिफिशियल इंटेलिजेंस जो आपकी फीस ली, कितनी फीस आएगी मेरी, और कितनी 4 साल के बाद मेरे पास कितना इकट्ठा हो जाएगा, तो मैं कौन सी गाड़ी सही लूंगा, वो आर्टिफिशियल इंटेलिजेंस कर देगा। लेकिन आर्टिफिशियल इंटेलिजेंस अगर आज के डॉक्टर ने, आपने नहीं सीखी, चाहे आप 17 साल के फर्स्ट ईयर स्टूडेंट हो, चाहे 70 साल प्लस के हमारे जैसे इधर बोलने वाले हो, नहीं सीखी तो आपका अस्तित्व खतरे में है। ये पक्की बात है, सीखनी पड़ेगी। आर्टिफिशियल इंटेलिजेंस इज नॉट ओनली बज वर्ड, आर्टिफिशियल इंटेलिजेंस इज दी इन थिंग, बिकॉज it has role from diagnosis. And again, one important thing is artificial intelligence is not replacing the competence of a doctor, but it is a facilitating, it is enhancing your competence, your decision making process. You have to just understand that. And that is the role of when you take an algorithm. All artificial intelligence ultimately boils down to algorithm. And when you have an algorithm, there are two important things which you must understand. That what is the input for that algorithm, and what is the process of developing that algorithm, and is this algorithm best fit for your place or your country or your continent. That is what very important for all of you to understand. I'm not going into the large nitty-gritty of AI because that I think the entire session is devoted to that. हमने इसीलिए NAMS ने ये कहा कि ये जो एल्गोरिदम बनता है, ये एल्गोरिदम डेटाबेस होता है, और जितना ज्यादा वेरिएंट डेटा, जितना नंबर ऑफ n इसमें ज्यादा होगा, उतना ज्यादा हमारा एक्यूरेसी एल्गोरिदम में बनेगी। एक सिक्का उछाला तो उसका एल्गोरिदम क्या बनाना है, उसको बता देगा 50% टेल, 50% हेड, 50% लड़का हो सकता है, 50% लड़की हो सकती है। अगर आपने ऑनेस्टली विदाउट आपने एक्सरे या अल्ट्रासाउंड के प्रेडिक्शन किया, वो पहले भी आर्टिफिशियल इंटेलिजेंस होता था ना। राजा के पास गया तो बताओ मेरी रानी के क्या होगा, उसने कहा पुत्र न पुत्री। उसने कहा हाँ चलो, 100 सही निकलेगा तो तुमको इनाम, नहीं से निकलेगा तो तुम्हें मौत। यही होता था ना पहले राजा की कहानी में। उसने कहा खोलो क्या है, उसने खोला, उसने कहा पुत्र न पुत्री। जब उसने कहा जब हो जाए तब बताना, तब खोलना इसको पर्चे को। कॉमा नहीं लगाया था उसने, फिर उस समय कॉमा लगा दिया, पुत्र न पुत्री, पुत्र हुआ। उसने कहा अच्छा अगर ये मान लो उल्टा हो जाता तो क्या कहता है, मैं कॉमा इधर कर देता, पुत्र न पुत्री। तो अल्टीमेटली when you put an algorithm, the most important thing, the accuracy which you predict. And if the algorithm is 50% correctness, I think it is useless. Correctness has to be more than 85% to 90% precision and accuracy. Then it can be considered algorithm. Now, algorithm which has been developed in UK or US, which is based on the data from their country, may not be valid in India. And therefore, you have to develop data from India, which is, अगर हमने उसमें सिर्फ एम्स भोपाल के 10,000 एक्सरेज निकाल के लगा दिए और हमने कहा कि ये ट्यूबरकुलोसिस में पॉजिटिव है, ये ट्यूबरकुलोसिस में नेगेटिव है, and I have developed a fast screening process for tuberculosis by using this AI. But if you have a data which is from AIIMS Kalyani, which is a data which is from a district hospital in Meerut, which is a data from a poor nutritional status, which is a data for patient which are more COPD patient, which is the data where in addition to tuberculosis are cancer patient, then your algorithm will become a more variant, and then algorithm which will be representing the entire species of this country or it will be more accurate. And इसीलिए नेशनल एकेडमी ने भी ये भी सोचा कि why not we develop a platform where more than one institution can combine together and work on one algorithm development. अभी प्रधानमंत्री जी ने भी कहा कि हम अभी तक जितने AI एल्गोरिदम हैं मोस्टली बाहर के हैं, हम क्यों ना अपना एल्गोरिदम बनाएं, इंडिया सेंट्रिक एल्गोरिदम बाय आइदर स्टार्टअप और बाय पब्लिक सेक्टर एंड देन यूज दोस एल्गोरिदम फॉर इंडियन पेशेंट. इज इम्पॉर्टेंट कि एल्गोरिदम बनाना इम्पॉर्टेंट नहीं है, एल्गोरिदम के बाद में उसको वैलिडेट करने के लिए जरूरत है कि इसको वैलिडेट कैसे करें. Being a pharmacologist, I will tell you how AI has been useful in developing new drugs. हम अपनी स्लाइड में पहले पढ़ाते थे कि एक ड्रग डेवलप करने में ये $1.5 बिलियन खर्च होते हैं और मिनिमम 10 साल लगते हैं और 1000 मॉलिक्यूल को बनाओ तब जाके 10 मॉलिक्यूल बनते हैं जो कि क्लिनिकल ट्रायल में ले जाएं और अल्टीमेटली एक ड्रग बनती है और जो कि 5 साल के बाद इसका एट्रिशन हो जाता है. अब मुझे लगता है कि स्लाइड जो है ना आउटडेटेड हो गई. कोविड ने बता दिया कि स्लाइड आउटडेटेड है. नाउ इफ यू आर यूजिंग एल्गोरिदम, if you are using the data science, if you are using the artificial intelligence, then you have structure based, you have a docking system, and then you can predict from 1000 structure on the computer that these 10 will be most likely useful for this efficacy because you identify the docking से कि ये receptor इसमें attach कर रहा है और ये receptor attach करने से उसको भूख कम लगती है, भूख कम लगने से उसकी मोटापा कम हो जाता है, डायबिटीज कम हो जाती है. And then you have semaglutide, liraglutide and GLP-1 agonist antagonist. Now when you are talking of GLP-1 agonist antagonist, which has been developed in much shorter time, now at least 20 molecules of similar type in the market, maybe those who are aware of this, which may be flooded in the Indian, not international market, GLP-1 agonist का controversy चल रही है. Because AI based data ने इतना short कर दिया, now you have a specific receptor and also you can predict कि इसका side effect क्या होगा, कितने लोगों में होगा by artificial intelligence. और अभी आपको मालूम होना चाहिए गवर्नमेंट ऑफ इंडिया ने इतनी हाई पावर कमेटी बनाई, हम भी थे उसमें, कि कैसे इसको गवर्न करें बिकॉज एवरीबडी इज गोइंग टू यूज दिस GLP-1 agonist and then what would be the possible effect after 5 years of use of these GLP agonists. That is what we are trying to predict. So now with artificial intelligence, not only you can predict efficacy, but you can predict the side effect. You can predict after 10 years what will happen. And this will also be useful not only to patients, this will also be used to those who are investing in it. Because उनको मालूम है कि दवाई 5 साल के बाद तो खत्म हो जाएगी, तो अभी से कमा लो जितना कमाना है. But that is also process of decision making, intelligence based. It's not Israel और अमेरिका में artificial intelligence करके bombing कर रहे हैं. This is also bombing of drugs in a well-informed public, and therefore understanding of this is very important. इसमें बड़े सारे issues आते हैं when you talk of artificial intelligence, some of which Dr. Gupta mentioned. Is ethical issues. हम यहाँ से ICMR में, when we look for the different committees in ICMR में, CSIR में, we are funding liberally AI-based projects. Unfortunately, many projects are such, यहाँ से हम डेटा इकट्ठा करके इंटरनेशनल एजेंसी को डेटा दे रहे हैं. And now the government of India is becoming very rigid. HMSC committee is very strong कि ऐसे डेटा को जो हम एनालाइज कर सकते हैं वो हम बाहर भेज रहे हैं. तो हमको वेरी केयरफुल होना चाहिए कि ये डेटा का कपास हमने जो हमारे आज़ादी के पहले कि हम रुई भेजते थे, कपास भेजते थे और उन्हीं से 10 times वापस महंगा हम कपड़ा लेते थे, उसी का बना हुआ. And that should not happen here today. That you are sending the data to abroad, they are making algorithm, sending it to you and charging heavy fee or the license fee or the loan license. So what is important thing that we must collaborate on these things. It is also important that when you are looking for AI, And I understand that after 10 days on 30th and 31st, you have a conference on personalized medicine, personalized precision medicine. Now, in cancer patient, in diabetes patient, in hypertension patient, in rheumatoid arthritis, in psoriasis patient, I think much depends on the what you call in Hindi or in Ayurveda Prakriti, or what you call as a immunogenic response, or what you call as a generic phenomena in that particular patient. And that's why each patient may respond differently. Cancer patient, each patient may respond of psoriasis differently to a particular biologics, biosimilars, and therefore it is important that you apply these integrated knowledge of immunogenicity, of, of genomics, knowledge of genomics, and also understand the entire thing, put this into algorithm and have a predictive model that this drug, this biologics, this biosimilars will be effective in 80% or 85% prediction this patient. That is what you precision medicine. You know that if I give INH and is cheapest and most effective anti-tubercular drug, which causes in 6 to 7% very severe Steven Johnson syndrome. But if I have his blood and I know the gene HLA28, which is responsible for severe Steven Johnson syndrome, I can predict that this patient should not be given INH because there is a probability by more than 90% he may develop Steven Johnson syndrome and develop alternative strategy. That is what the role of इस समय जो मैक्सिमम यूज हो रहा है आर्टिफिशियल इंटेलिजेंस का इन इंडिया, द प्रोजेक्ट्स आर ऑन द रेस्पिरेटरी, identifying lakhs of patients of X-ray. Then you identify this is doable, this is not doable, and if there is a this, and then you can find it tuberculosis positive hai, tuberculosis nahi positive hai. The funds have been released, the projects have been released, the reports have come, but the product is not popular in the market. The reason is that you have to have a high degree of validation, which is important thing. We talk of इसमें हाई कोर्ट ने डायरेक्शन दिया सरकार को कि रेयर डिजीज पे हमारे पास कोई दवाई नहीं है और इसके लिए फंडिंग में नहीं है. रेयर डिजीज को हम ऑर्फन डिजीज ड्रग्स भी बोलते थे, ऑर्फन डिजीज, क्योंकि उसमें कोई माँ बाप नहीं है, माई बाप नहीं है, मतलब उसको कि रिसर्च करने वाला रिसर्च नहीं करता क्योंकि उसको कोई फायदा नहीं है, पब्लिकेशन बड़ी मुश्किल से निकलता है, इंडस्ट्री उसमें काम नहीं करती क्योंकि मरीज ही बहुत कम है. लेकिन इसको भी छोड़ के 2-3 इंटरनेशनल कंपनी जो रिचेस्ट डिविडेंड पे कर रही हैं ओनली ऑन रेयर डिजीज, बिकॉज कॉस्ट इतना है, हमारे देश में कॉस्ट दे नहीं सकते. तो भारत सरकार ने कहा हम फंड करेंगे एनीबडी हु इज इंटरेस्टेड इन वर्किंग ऑन रेयर डिजीज. So I am just giving you this information. Easy funding. Also, in rare disease, the most important role is of artificial intelligence, because the patient, 1000 patient में हम ट्रायल नहीं कर सकते, 200 पेशेंट में ट्रायल नहीं कर सकते. हमको एक पेशेंट भी अगर मिल जाए वो भी हमारे ट्रायल के लिए अप्रूवल मिल सकता है. दिस इज कॉल्ड एज एन ऑफ वन ट्रायल, एन ऑफ वन, एक पेशेंट में. एंड देन you apply artificial intelligence on this, and the drug controller may give permission on the basis of this, saying that this is effective in one patient with reasonable certainty of 70%, and therefore this drug is tentatively approved with condition or with caveats. So artificial intelligence based decision दो तरह के होते हैं. One is you know the certainty, predictability. Other, you know what are the caveats. And therefore it is given, approval is given with the caveats कि इसके साथ में आप इसकी 10 ट्रायल, जब भी ट्रायल एक्सेसिव आपके नंबर होते जाएं तब आप करते रहिए, और जब आपको ये रीजनेबल. सो व्हाट इज दिस आर्टिफिशियल इंटेलिजेंस इज टॉट अस दैट कन्वेंशनल थिंकिंग से, रेगुलेटरी प्रोसेस कन्वेंशनल थिंकिंग से आप कोई भी ड्रग अब नहीं ला सकते, पर्टिकुलरली इस तरह के प्रोसेस में. सो यू हैव टू थिंक डिफरेंटली. You have to think out of box. You have to change the regulatory process based on the certain evidence, based on artificial intelligence data, कि कितने minimum patient चाहिए, कितना duration चाहिए, and कितनी risk इसमें रेजिडुअल रिस्क है. That is now the regulatory science is also being changed, and particularly when you talk of biologics, biosimilars, आज के ज़माने में हम कहते हैं स्मॉलर मॉलिक्यूल की दुनिया है, लार्जर ये. अब हम बात करते हैं कि इसके बाद में 10 साल के बाद में मेजॉरिटी ऑफ द डिजीज विल बी ट्रीटेड बाय बायोलॉजिक्स, चाहे वो कैंसर हो, चाहे सोराइसिस हो, चाहे हाइपरटेंशन हो, चाहे एनी डिजीज, मोस्ट ऑफ द डिजीज विल बी ट्रीटेड. अब हम बात कर रहे हैं कैंसर की, कहाँ हम बात कर रहे हैं? नाउ सी डाइकोटमी इन द कंट्री. We are talking of developing CAR T therapy in India, making several. There are more than 18 startups are working on CAR T. There are 4 companies which are developing CAR T. They are marketing CAR T, and CAR T was also in IIT and industry. They have developed the CAR T therapy first. Now there are more than 4 CAR T which is available in the market. Now there are 18 CAR T projects which have been approved and which are in the pipeline for the drug controller. एक तरफ तो हम कार्टी कर रहे हैं, उसमें भी artificial intelligence is most playing major role, that this person based on this data is more likely to be useful in CAR-T, because CAR-T में तो आपको 20-25 लाख reduce price पे लेना है, यहाँ बाहर तो करोड़ रुपए लगता है, 20 लाख भी महंगा है. तो हमको पता लग सकता है आर्टिफिशियल इंटेलिजेंस से कि इस पेशेंट में with 80% possibility this CAR T therapy will work. और हो क्या रहा है? Without using that information, people are misusing the CAR T therapy also in patient who will not likely to be benefited. And then we say CAR T therapy तो effective ही नहीं हो रही आधे लोगों में, because आपने गलत CAR T therapy उसमें दी. And that is why developing CAR T therapy, artificial intelligence in CAR T therapy is important. Validation is important. एक तो हम वहाँ पे उसकी बात कर रहे हैं, इतनी हाई साइंस. दूसरी तरफ अगर आप यहाँ पे एम्स भोपाल में ही देखो, या एम्स ग्वालियर या हॉस्पिटल ग्वालियर में देखो, या आप डिस्पेंसरी में चले जाओ, वो डॉक्टर प्रिस्क्रिप्शन लिखता है, उसकी बीवी गर्लफ्रेंड नहीं पढ़ पाती. होता है ना ऐसे? क्या लिखा? क्योंकि डॉक्टर की हैंडराइटिंग गुचर पुचर से अच्छी नहीं है. काश अगर उसने हैंडराइटिंग अपनी गर्लफ्रेंड को अच्छी हैंडराइटिंग में दी होती तो पढ़ गई होती, लेकिन उसको पता ही नहीं लगा कि हैंडराइटिंग उसकी समझ में ही नहीं आई. सो वो बेचारा मरीज ढूंढता रहता है, इधर से उधर. वो पूछता है आपसे कि अंकल बता दो, डॉक्टर साहब बता दो, ये प्रिस्क्रिप्शन में जो लिखा है वही दवाई हमको मिली है? ये दूध से पहले पानी से पी लें, या हम कितने दिन खाएं? यू नो, ट्यूबरकुलोसिस, मेजर रीजन फॉर डेवलपिंग मल्टी ड्रग रेजिस्टेंस ट्यूबरकुलोसिस वाज नॉट टेलिंग बाय द डॉक्टर कि इसको हम कितने दिन तक कैसे खाएं. और उसने 3 महीने के बाद में ट्यूबरकुलोसिस दवाई बंद कर दी, उसका खून निकलना बंद हो गया. उसने कहा कौन जाए डॉक्टर को फीस देने, and that became the resistant tuberculosis. That was the beginning of the major contribution, and that started the DOTS therapy. So what can be done is simple thing, AI based कि इसको आप digitalize करो prescription को. This has been done by a startup in Delhi, engineers ने, कि इसको digitalize करो. digitalize करने के बाद में इसको आप एक एल्गोरिदम बनाओ, उससे पता लग जाएगा कि ये ड्रग की स्पेलिंग डाइफेनाइल हाइड्रोटोन की लिखी है, डाइजिन लिखी है, डिजॉक्सिन लिखी है, वो पता सकता है AI बेस. क्योंकि पेशेंट तो हार्ट का है तो डिजॉक्सिन डाइजीन होगी, डिजॉक्सिन होगी. पेशेंट को तो डाइजीन पे से पेट में एसिडिटी, और अगर डाइजीन की जगह डिजॉक्सिन दे दिया तो मरेगा, और डिजॉक्सिन की जगह डाइजीन दे दिया तब भी मरेगा. There was a high power committee which I chaired. Foltraxate, methotrexate का brand name, Foltraxate was given for 6 months when the prescription drug was for vitamin B, and the patient came with a complete renal failure. और देखना क्या कि उसको तो white किया है, और उसने डॉक्टर ने F लिख दिया, क्योंकि उसको स्पेलिंग शायद खुद ही नहीं आती थी पता, या उसको टाइम नहीं था. और उसके बाद में दिस पेशेंट डिड नॉट गो टू कोर्ट. अगर हिंदुस्तान के बाहर होता तो कोर्ट में चला गया था, और वो तो जाके अपनी रैपर लेके जाता था, रिफिल दोबारा दे दो, तो केमिस्ट ने दोबारा दे दी. केमिस्ट तो यहाँ पूछता नहीं है, क्योंकि उसकी रिस्पॉन्सिबिलिटी तो भगवान ने बनाई नहीं है, लॉ में बनाई है. कभी उसने पूछा नहीं, तो 6 महीने तक वही चलता रहा. सो द इशू हियर इज देयर इज ऑल्सो मेथड बाय आर्टिफिशियल इंटेलिजेंस, देन यू कैन फाइंड द करेक्टनेस ऑफ द प्रिस्क्रिप्शन. You can reduce the prescription error you can reduce the drug interaction and you can increase the patient compliance and patient drug adherence by simple application of digitalization and AI. So AI is not only limited to developing robotic. Just recently I had visited to Merrill technology, which is in Vapi, जो बनाते हैं robotic surgery के लिए instrument, valve के और knee surgery के. उन्होंने आर्टिफिशियल इंटेलिजेंस यूज करके ट्रेनिंग करके बुलाया. मे बी सम ऑफ यू कैन गो एंड सी दैट कि अगर हमको नी सर्जरी करानी है, रिप्लेस करानी है, हिप रिप्लेस करना है, वॉल्व करना है, देन एवरी 3 or 4 coordinates of your will be taken and accurately it will be fed to the instrument. Then robot will go to the site where it is. इतना ही इंसिजन लगेगा, इतना ही प्रिसिशन लगेगा, इतना ही वहाँ पे डिस्प्लेसमेंट होगा. तो not only the artificial surgery, artificial intelligence has effective in the decision making process, but artificial intelligence based data has improved the correctness, accuracy of the devices which are being used, are likely to be used on the human being. So इसलिए this is something which is cross disciplinary. इसमें इंजीनियर भी होना चाहिए, इसमें डॉक्टर भी होना चाहिए, इसमें पॉलिसी मेकर भी होना चाहिए, इसमें वैलिडेशन भी होना चाहिए, इसमें क्रॉस इंस्टीट्यूशनल वो भी होना चाहिए. So what is finally we say? The objective of this workshop is not to create you an expert in artificial intelligence, is to make you aware, make you understand the importance of artificial intelligence, and you have to learn this basic thing and then evaluate. You must evaluate. Don't take blindly any artificial intelligence based algorithm or data product. Evaluate them and then also know how to apply this. इतना अगर हमको समझ में आ जाए, I think that is very important. The major issues भी आपको पता होना चाहिए. Lack of standardization नहीं है हमारे पास. वर्कशॉप करिए उसमें कि डेटा जनरेट करें तो उसके लिए हमारा डेटा और आपका डेटा आप कर रहे हैं मारुति में बैठ के कर रहे हैं, दूसरा कर रहा है मर्सिडीज में बैठ के डेटा. So there has to be standardization and then uniformity so that this data generation becomes, and ethical issues are very important. I said कि अगर आपने किसी का private data या privacy data नहीं किया तो that will be another problem. ये सब, these are the just few examples which I thought why NAMS, why Dr. Behra and all of us have decided that these are the one important area where each institution, whether it is a medical institution or, and you will believe, जो NAMS ने 3 महीने का आर्टिफिशियल इंटेलिजेंस एंड हेल्थ केयर का एक कोर्स चलाया, आपको पता होना चाहिए. यू मस्ट रजिस्टर इट. द फीस इज वेरी नॉमिनल एज कंपेयर टू अदर्स. who is conducting it? IIIT हैदराबाद. हमको उसमें फिर बाद में हमने उसमें बहुत सारे डॉक्टर्स भी जोड़े जो कि एप्लीकेशन करें. सो दिस इज नॉट ओनली डोमेन ऑफ IT expert, this is not only domain of engineers, this is a domain of cross sectional where the medical profession, biologist, statistician and policymakers, industry, because they are ultimately give you the product, will be working on it. So thank you very much. I think we have a lot of sessions on that, so we can have question answers and any of this. Thank you. Thank you, sir.
Thank you very much, sir, for a wonderful talk and a good beginning to a very interesting program onwards. Thanks a lot, sir.
Very thought-provoking, excellent. You walked us through it. So it was a narrative which was, we were with you. You know, you can get lost in a lot of slides. But there's 1, 2, 3 very simple things. You know, I like this slogan which says, he talked about more the data, more the big data, better the algorithm, which is so true. So garbage in, garbage out. So if your data is unilateral, you will get no algorithm. You will be misled. So this big data which we're talking about is a reality, definitely. And there's 2 other very important things I feel. I'm a teacher. My passion is teaching. So whatever you ask, पहले तो Google Mama में ढूंढते थे कि गूगल कर लिया, आंसर मिल गया, तो गूगल मामा से फट से मेडस्केप. So now it is AI. So don't kill your creativity. So you first say what is your solution to your problem which you are confronted with, then source these things to see how far you are from it. नहीं तो you will become dormant here. So I think creativity को नहीं kill करना, especially of students, that's so important. And when you know all the good, you must know the bad also. When something goes wrong, whom do you blame? The AI, or do you blame the doctor, or do you blame the institute? So accountability and regulation is so paramount, which is the Achilles heel. We don't have enough of it. So we are a long way from it. So we must actually work on that to get that going. And like he said, this is sensitization. And from here, you will take it forward. And I'm sure there are lots of lectures to come by. Thank you.
Thank you very much for the opportunity. And it is excellent, informative about the importance of AI. I think the AI means not artificial intelligence. AI means apni intelligence. Nobody can replace apni intelligence. Whatever may be the artificial, they are artificial. So in any sector, if we use artificial, अपनी इंटेलिजेंस के ऊपर नहीं हो सकती है, because we only created the artificial intelligence. It is only giving the data back to you. So अपनी intelligence is always better. So better we use अपनी intelligence, just take the support of artificial intelligence. Thank you.
Said आपकी intelligence, अपनी intelligence and artificial intelligence, to get the most appropriate answer by artificial intelligence, maybe whether you are using even now today ChatGPT, Perplexity, or any other, is how you give the prompts. So the highest paying engineers in AI are those who can give the best prompt. तो ये याद रखिए, अगर आपने prompt सही नहीं दिया तो आपका response वैसे ही आएगा. तो prompt देना ही एक science हो गया. Now there are people who are getting 1 lakh rupees, people who are getting 10 lakh rupees, and those persons who are getting better prompt, who will get better AI generated response. And then, so इसलिए आप सब लोगों को आप जो chat GPT में भी prompt देते हो ना, उसमें भी intelligence लगाना शुरू करो. Maybe you can ask the chat GPT what prompt I should give you to get this answer.
Thank you. Thank you. Thank you very much.
And we are very grateful to Professor Y.K. Gupta, who has been the chairperson of the task force, and also our distinguished chairpersons, Professor Thallada Bhaskar, who has agreed to attend this session in spite of all his busy schedule. Thank you, sir. So now, the main aim of this workshop come CME has been to disseminate the task force report, and the President NAMS had desired that we distribute the same. So I would now, sir is here. Achha. After this, okay. Okay. So we'll distribute this after this.
Thank you, sir. We will now move to our next session, which will explore two important frontiers of AI in healthcare, digital pathology and genomics. To chair this session, may I please request Dr. Madhavan Kar, Executive Director and CEO, AIIMS Bhopal, Dr. Debashish Biswasa, Professor, Department of Microbiology, AIIMS Bhopal, and Dr. Urmila Sinha, ma'am, Additional Professor, Department of Anatomy, AIIMS Deoghar, to please come. Our first speaker in this segment is Dr. Sangeeta Desai, former professor and head Department of Pathology, Tata Memorial Hospital, Mumbai. Ma'am would be speaking on digital pathology and artificial intelligence in the precision era.
Good afternoon. May I start?
Yeah, madam, you can start. Already they have destined.
So, wish you all very good afternoon. And my topic is digital pathology and AI in precision era. So, we are aware of four industrial revolutions in 18th century, 19th century, 20th century, and today. And today's is cyber physical systems, Internet of Things, and networks. And so these four industrial revolutions mankind experienced, and the world of pathology was also not far behind. So we have grown much beyond H&E or plain simple histopathology, and the first revolution in surgical pathology was immunohistochemistry, followed by molecular pathology, and then digital pathology and AI. And my talk is about digital pathology and AI. Now, these revolutions, whether industrial revolutions or revolutions in pathology, basically have resulted in transformative technological advancements that actually fundamentally changed workflows, increased efficiency and output, and expanded human capabilities. So for non-pathologists in the audience, this is a slide just to explain what a surgical pathologist or histopathologist does. So when patient goes to the clinician with a problem, I belong to cancer institutions, so my references are oncology. So if there is a tumor, then either a biopsy is a tumor is sampled, also a biopsy is submitted, or tumor is resected. So the entire material comes to histopathology laboratory, where it is processed further, and the end product is the paraffin block and a glass slide that is viewed under the microscope by the pathologist, and pathologist offers the diagnosis to the oncologist, but also gives additional information that how this tumor is going to behave, or how this particular tumor is going to respond to the treatment. So the same process is depicted here. So you come to the last, that is the final product, that is the glass slide. And when this particular microscope is replaced by whole slide imaging device, we practice, instead of surgical pathology, digital pathology. So what digital pathology is use of computer technology to convert analog images into digital images. It is also called virtual slide. So the very first step of converting glass slide into a virtual slide or digital image itself poses significant, considerable logistic, fiscal, and organizational challenges. And what we get is a virtual image which is actually has millions of pixels or picture elements or unit measurement of image. So millions of such pixels make an image. And when you go deeper into the layers of histopathology slide with the help of computational pathology, when you go much beyond and deeper, that is because when you go beyond and deeper, there is a wealth of information which is already hidden there. Then there is spatial context provided by digital pathology, and we in this era have ability to perform precise analysis of large data sets. And with all this, we are having fresh insights into pathophysiology, and this is called computational pathology. And this is possible because of whole slide imaging or digital pathology, which has enabled practice of computational pathology. Now, so coming to pixel pathway, we have replaced now microscope with whole slide imaging device. There is storage and server, and there is network, and this is viewed, analyzed, and there are myriad of applications of digital pathology. But most important is, more than, of course, getting whole slide imaging device is important, but what is important is IT parts, so that right information is available at the right moment all the time. And needless to say, High quality images need high quality slides, and as is your pathology, so is your digital pathology. So the applications of digital pathology are myriad, right from clinical research, education, and within the research I have written here AI and deep learning, but it has already reached clinical space. So AI is about making computers and machines able to perform tasks that typically require human intelligence, like learning, reasoning, problem solving, such as understanding natural language, identifying patterns, making predictions, and most algorithms in medicine are designed to estimate the risk, that is prediction, of a patient having an event presently, so that's diagnosis, or developing one in the future, so that is prognosis. And precision oncology is a personalized cancer care approach that uses patients' unique genetic, molecular, and cellular tumor characteristics to guide diagnosis, prevention, and targeted treatment. So, precision oncology, the interesting uh, association between digital path, AI, and precision medicine has really transformed oncology practice, and I will allude to that in subsequent slides. Coming to journey of AI, if you AI was the term was coined way back in 1956. Later on in 1959, machine learning was introduced, and 1986 deep learning. But we are talking about AI in pathology in the last few years, and that is because whole slide imaging devices, they entered the market very late. So again, machine learning is a subset of AI that is basically searching for patterns in data to build logic, and deep learning is using use of multi-layered neural networks, and generative AI is powered by large models that are pre-trained on vast corpora of data. So the day-to-day example of machine learning is the iPhone presents to you your own music list, or deep learning example is facial recognition, again to unlock the phone. Generative AI is ChatGPT, which we have been using, that is um, generative pre-trained transformer. And although we may think that we have made a lot of progress in AI, we are still in the phase of narrow AI, and super AI is hypothetical situations where AI is used for eradication of poverty or climate change or something like that. So basically in pathology, we are trying to unlock prognostic biology hidden in routine histopathology, and traditional histopathology is already clinically validated. There is standardized reporting patterns. There is TNM staging, has inter-observer variability, and it offers very limited insights into tumor microenvironment, immune contexture, molecular heterogeneity, and spatial architecture. So all these are pros and cons of traditional histopathology. And below the surface, there are there is wealth of information. And this is called pathomics, that is extracting subvisual details and quantifying them, and then correlating with clinical outcomes. And this is possible because using machine learning algorithms, it is possible now to segment, detect, and classify various structures such as stroma, epithelium, cancer cells, stromal cells, tumor infiltrating lymphocytes. And these are the applications of AI in pathology. This is being used in routine diagnostics or workflow enhancement. First is screening lymph nodes for metastasis, quantifying biomarkers. We routinely use immunohistochemistry for reporting various biomarkers, which actually they are used for clinical practice in oncology. So estimating these biomarkers, segmenting, counting mitosis, other quantification tasks. Pathologists are busy doing many repetitive mundane tasks, and so AI finds its place in coming to our rescue there. Grading assist tools and predicting genomic proteomic outcome information from H&E images and histological quality control. Now, these are some practical examples of quantification of biomarkers. And this is a breast cancer case where HER2/neu is a very strong prognostic and predictive marker. And we, of course, we have been doing manually, but now we can take help of AI. Similarly, Ki-67, which is a very cumbersome test to interpret, and this is the point which I would like to stress on. Any algorithm which is presented to you, you just can't buy it and you start using it in your laboratory. We have to first validate it and compare it with what we are already doing. So this is a breast cancer case where ER, PR, and HER2 and Ki-67, all these biomarkers were interpreted using AI. And similarly, there are these higher molecular tests, that is in situ hybridization. This is yet another example where this particular algorithm actually gives the pathologist heat map, so it is very much easy to interpret these tests. And again, the oncologists in the audience may know about revolution in HER2, a biomarker. That is, now we are concentrating more on non-overexpressed levels of HER2 in breast cancer. And it's very difficult to interpret these cases because it's very faint, incomplete staining, brown staining, and there is huge amount of inter-observer variability where AI can help us. This is about interpretation of lymph node metastasis. And we had done a study where we found that there was very high level of concordance and kappa value was very high among different observers. And most interesting part is whole slide image itself acting as a predictive biomarker. In breast cancer, there is yet another clinical situation in strong AR/PR positive breast cancer, which is non-metastatic. There is often a question whether this particular patient should be given chemotherapy or not. And for that, a very expensive multi-gene profiling test is done, which is called Oncotype DX. Now, instead of this, the image of breast cancer can be utilized to derive image-based risk score. And what we have shown is that image-based risk score could provide additional and more granular risk stratification compared to that offered by Oncotype DX or histologic grade alone. So computational pathology improves risk stratification of a multi-gene assay for early stage ER-positive breast cancer. This was published in Nature Portfolio Journal Breast Cancer. And there are many such algorithms already in commercial space. And in breast cancer, there are a variety of algorithms available. And of course, they come at a cost. But right from grading to lymph node metastasis to quantification of immunohistochemistry, so all these areas are covered by many commercial algorithms. Coming to prostate, it's yet another AI success story in urologic pathology, where the first FDA authorization for AI in pathology in 2021 was given to Page AI algorithm, and that is for clinical grade or grading of prostate cancer. But most interesting part is Artera AI prostate test report, which is a multimodal AI test. So what it does is, it's not only whole slide image, but it also combines it with PSA level clinical stage, and it is AI powered, FDA cleared, NCCN guideline included prognostic predictive test for localized prostate cancer. What it tells us, it tells us whether intermediate risk patient of prostate cancer will benefit by adding short-term androgen deprivation therapy to radiation, and how this came into commercial space when it was tried on more than 9,000 patients in multiple randomized controlled trials. And this is the revolutionary kind of biomarker, trophoblast cell surface antigen TROP2, which is a novel computational pathology based biomarker for a new drug for lung cancer. And this particular biomarker actually quantifies membrane expression versus membrane and cytoplasmic expression, and it has the potential to be the first biomarker and the first computational pathology biomarker for predicting clinical response to new drug in non-small cell lung cancer. It is revolutionary because here it is just pathologist has to perform IHC, and then computational pathology AI takes over the entire process. And why it was introduced? Because simple IHC and human interpretation was unable to offer this kind of prediction, and that's why the entire process is now computerized and AI based. So now this brings me to the adding something else to histopathology, and that is histopathology, immunohistochemistry, and molecular data, and improving outcome information still better. This is a study where 15 cancer subtypes were included, and it was shown that the data fusion improves prognostic models for majority of cancer types. So coming to generative AI, these are last few slides. So coming to generative AI in pathology, this helps in image analysis, enhancement, synthetic data generation, diagnostic support, workflow efficiency, education, and research. And I'll just give you an example. This is a FDA breakthrough device designation, which was offered to Modella AI on Jan 28, 2025. This particular patch chat, it is called, it reads the slide, it writes the description, it gives the diagnosis, it offers it tells the pathologist which immunohistochemistry markers, and it actually keeps everything ready for the pathologist to go further. So these are the range of current applications in pathology, right from whole slide image itself as a biomarker, molecular prediction, education, training, morphologic features, IHC quantification, and basic laboratory workflow management. There are serious limitations, and this itself is a 1 hour long talk. And a serious limitation is this: clinical context is most important. Your watch is telling you that you have lost 79 kg, but ground reality is something different. Okay, so clinical context is the most important. Apna intelligence or apni intelligence is very important. Ethical concerns of AI. So this is basically AI-enabled transformation of histopath workflow, right from accessioning the samples to signing out. And this is a part to multimodal precision oncology, where not only pathology-related information, but also correlation with collating data wherever it is being produced, like radiology, radiotherapy, medical oncology, and making sense out of that and making something which is unifying. So basically, what we believe is real opportunity lies in AI with humans. That is, AI processes data, augmented intelligence creates meaning. So human in the loop or human on the loop, that is very important. but not human out of the loop. And this is at least as of now, as far as AI in medicine is concerned. And as far as precision oncology is concerned, is convergence of precision oncology, digital path in AI, and future of oncology lies now at the intersection of pixels, patterns, and precision. With this, I end my talk. Thank you very much for patient hearing.
Thank you, madam. Very comprehensive and very informative AI in pathology. This is very important. This is the artificial intelligence, not this is the augmented intelligence. See, in pathology, this is very critical. This is how your grossing should be first take a good image and image quality. See, we will not discuss the what is the limitations of what artificial intelligence AI will give you best to diagnose and give a pinpoint diagnosis in like in oncology, or for like in the renal pathology or any transplant pathology rejections. At the moment, you can see lot of data at a time, like cellular features, morphological features, like the differentiation, like the cell transformation, all these things keep into the AI that can give you the diagnosis that whether it is a malignancy or not. In borderline, that is always a problem. Like when we are going for a like margin negativity or margin positivity, this is the way AI can help from diagnosis, on-table decision, and most important when you go for the prognosticate and the decision for the therapeutic decision. These are the things, not only oncology, in all like in now recently any NCD or other things, even infectious diseases. A lot of data are coming, but which is the right, which is not, which pathology will give correct diagnosis, always AI will be a boost. They say like augmented intelligence definitely is the right word, and you have put it. This is thank you so much. We will discuss later on after this two more presentations. Sure. But AI will definitely change whole giving a diagnostic pathology and prognosis and like the think that the right research. Like you, I am telling you just an example. This is the micrometastasis when you diagnose in a sentinel lymph node. You cannot see each sections like 16 sections. You will give you like things. But with all features, you will put into the all features with clinical everything, and simultaneously you will see this is the immunohistochemistry features and all these things. You can give the micrometastasis in the lymph node. Then that will go in the same thing. Always AI will be a boon to the diagnostics, and definitely good image is important. This is like pixel pathway. Thank you, madam, for your things. We will discuss a lot of things, and you can, for the students or all the faculties, they can interact. Dr. Desai is very eminent pathologist in TMS. They have vast experience. You can know this is with the slides you will speak. This is, we can go next.
So as Madam alluded to in her talk that we need to integrate genomics, we need to integrate molecular data with the image, with the information that we are getting from the images. We need to integrate all this along with the clinical information so that we make better sense of what is coming to us. To proceed in the same line, it's now my privilege to call upon Dr. Sanjay Deshpande, who will be talking on scaling genomics with AI, smarter storage, faster pipelines, and better insights. So Dr. Sanjay Deshpande is a scientist at the Regional Center of Biotechnology, DPT. So it's my pleasure to call upon you, sir, for your talk that we are waiting for.
So thanks AIIMS Bhopal and NAMS for giving me the opportunity. So it's being very, I can tell as an outlier. There are very few outliers here. The outlier means that I'm an engineer, I'm not a doctor. So the conference is having most of the doctors and very few engineers. I think some of the speakers after me are engineers. So I'm an outlier. But having said an outlier, I would talk why it's important to be an outlier. Okay. So starting like Dr. Gupta just told before some time that we need to have a data center where we have all the data together. So it's my responsibility to introduce my center because I think very few of them know. I'm from Indian Biological Data Center. It's funded by Department of Biotechnology through Government of India basically. It's located at Regional Center for Biotechnology, Faridabad. So we are, if people have been doing genomics and structural biology. They know about NCBI, EMBL, and a lot of international databases. But there was no such database in India where you know, archive the biological data. So we started it. So it's the first biological data center in India, set up at Regional Center for Biotechnology. We started functioning from 2022. It's just 4 years that we have been fully functional. So the map just clearly shows that we have been interacting with a lot of users across India, like starting from the north of Ladakh to south of Kanyakumari to northeast to the west. So we've been slowly trying to build our user base. So it's good opportunity for me to come to AIIMS Bhopal and talk about more about my center as well as what we do. So these are the primary resources what we do. We build biological data resources. That's for basically you get what you want for your all research parts. Then we are a data hub for a lot of national projects of importance. I'll talk about that in next slide. So then we do also give the compute facility. If somebody has data, if they want to analyze the data, they can get and compute access and run their analysis on our systems. Like it's currently it's free of cost for academicians. So that's what we are trying to build, the capacity building also. So we do a lot of trainings on data analysis, basically the biological data analysis, and we do give a lot of user resources. So we have developed a suite of data portals where we collect a lot of different data types. Like starts from the nucleotide data, followed by the structural data, then we have phenotypic data, then metabolomics data, proteomics data, images data, as well as array data. So now having said that, why it's important, like I think we just talked about, ma'am was talking about the integration of data, integration of multiple types of data. When we have all the data at single place, we can apply it for AI in future. The next part is the AI, right? Like we want the data to be having, it's a single place. So that's what we do. So few projects of national importance I want to tell about. There is I think most of them have heard about the Genome India project. Like it's the 10,000 genome sequencing. That data is being stewarded or archived at IBDC, that's Indian Biological Data Center. So we are a data steward for it. Okay, we are data steward. So and also we played a very critical role during the pandemics. I'm happy that AIIMS Bhopal was also part of it, INSACOG. So where all the variant data across India, what you used to see in the news, like alpha, beta, gamma, omicron, whatever you might have heard, was coming from IBDC. IBDC used to analyze the data centrally and used to give to the healthcare agencies that would be get distributed across the news channels and the media. So that we did, and there is something called one day one genome. So there are a lot of microbes produced, like isolated in India. So the unique microbes. So every day there was one microbe released with the data available, like annotated data available. Then there is something very, very important, pediatric rare genetic disorder mission mode project of DBT at CDFD Hyderabad. So where the the mission of the project is to counsel the parents as well as sequence the genomes of the triads, basically the parents as well as the kids, basically to understand what are the disorders. Then Dr. Desai's institute, there is cancer image biobank, so that data is also stored at IBDC at central server. Then we have Indian human microbiome initiative. So as we know that equally microbiome is important when we talk about genome. Microbiome actually tells how healthy you are. Basically the genome is fixed, but microbiome changes based on your food habits. Not just for life sciences, we do all for the crops also. A lot of crop based studies also been there. The most important thing when we talk about the data is the data sharing policy. Is there any data sharing policy in India? I think as far as I know, for the biological data center, the biological data policy, it's very minimal in nature. It's just to be very frank, I haven't seen any policy which talks about biological data. Most of the policies are just talking about the data. There is no biological data, but biological data has its own challenges as well as own problems with it. Basically, that's why there are something called biotech pride guidelines and feed protocols set by DBT with in consultations with other ministries also. It's not just DBT, in consultation with Home Affairs, Ministry of External Affairs, with Human Ministry of Health, Agriculture, and every ministry. So they have decided that there are two types of data. One is open access data. That means that the data can be accessed by anybody. Then there is managed access data, where people should tell that why they need data. Because it's not that, for example, the Genome India data. The Genome India data is having a lot of biological information talking about the phenotype of the the population where the population comes. So it's very important to understand why they want to access the data. So that's the controlled access data. So we have been increasing our data collection basically for the betterment of Indian public, and it's an basically there is a federated model as an open access model. So we have reached around 6 lakhs of submissions, currently 6 lakh data points of different data types with around 1.2 petabytes of data. So petabyte, if anybody doesn't know petabyte, 1 petabyte is 1024 terabytes. So everybody knows terabytes. So 1 petabyte is 1024 terabytes. So we have around 1.2 petabytes of data. So with this, now I come to the most important part, scaling genomics with AI. So everybody thought that initially, like the most important thing is one sample of human genome data is around 200 GB. One sample, if somebody wants to sequence of complete genome, it's around 200 GB. So now I think it's very routine to have a NGS data analysis. Like everybody gets analysis done. It's with the sequencing is very easier now. But whether is it a burden or whether will you get a good output out of it is very important. Like because when you have large lot of data, it's normally overwhelming. It's not always a good thing to have. So the most important, the clinical reality. So now NGS is routine, but turnaround time still takes weeks. It's maybe even months also. In some cases, it takes months also. But and also just coming to one like variants. The way when we talk about the mutations, they still remain a severe bottleneck. Like that's very important. And also incidental findings. Sometimes what happens, the person analyzes the data, they feel it's very rare variant, but practically that's just an casual variant which has discovered with a lot of low quality. So that is very important to understand. So just to give a very nice infographic where like I want to tell why it's important to have storage, good storage. Okay, so one patient data is around 200 GB, right? Then one panel, there are onco panels nowadays. It's you need not to sequence the whole genome. There are onco panels. It's a small panel where you sequence the panel. It's around 1 to 5 GB. So if you take around 500 patients in a year, it's 500 patients here, it's 2.5 terabytes. If you want to have a biobank, like 1 million genomes, like for a population of so large, 1 million is a very minuscule number, but even that is not happening in India. I don't know why. It's like we have enough funding, but it's still not happening in India. So for 1 million, we need 200 plus petabytes of storage. So then, just to give an analogy, there are 4 types of storage. The first storage is called hot storage. Terms of clinical analogy, it's an emergency room where all the analysis happens on that particular storage, and it's very costly storage. It's not cheaper in size. With the war going on, the storage prices have rocketed, like which was supposedly like 1 crore, for example, 1 petabyte. Now it's 5 crores for 1 petabyte, like the hot storage. Similarly, when we have something, the secondary storage is called SSDs or SDDs. That's very common nowadays in everybody laptops. So that's an outpatient records where the secondary data is stored. Like it's you can use it for your reanalysis purpose. The cost is moderate in nature. Then there is something called cold storage. It's an archive basically. The data which you have generated, you can archive it there. Then finally, there is something called tape library. So tape libraries are like the cassettes where you put all the data in the cassette and keep it outside. So what happens is that's for a long-term storage. That's very important to have. So now finally, the most important thing is the financial impact. So for having a 500 petabyte data center, it costs around 750 crores. Are we ready for it? When we talk about AI, we need a data center. Is the ecosystem ready for it? Are we going to spend 750 crores for a data center in a public funding manner? It's privately they are funding. You might be talking about Google. Everybody do Google. They talk about Google setting up a data center in Visakhapatnam. They are investing around 2,500 crores or like in thousands of crores. Why they are doing it? Because they get benefit out of it. They are commercially viable for them. But for government setup, is it viable to have a 750 crore investment? And you don't really get anything out of it directly, right? Like you don't get any profits out of it. You are basically serving the public. Are we ready for it? That's very important. Also, once we have the data center, who will manage it? Again, you have to outsource it. Do you have a capacity to manage the data center. These answers and questions are coming with experience of handling the data center currently for 5 years. So it's not easy to handle a data center, especially when there is a biological data involved with it. Coming to the next part, like just to give an analogy, that's how the traditional pipeline works, the analysis pipeline works, where you you do a sample preparation for 1 or 2 3 days, basically the biological sampling. Then once you do the get the analysis, you do variant calling, basically checking the variants. It takes again 24 hours for one sample. I'm talking about one sample. Okay. When you talk about 500 samples, 500 days per sample. Do you have enough ecosystem to parallelly analyze the data? No, we don't have currently. Then finally, the most important parts, the most important bottleneck is the interpretation. I have raw data, I have analyzed, I got the results, everything. To how do you interpret it? Like, do you have the capacity? First thing. Unless we have a capacity, it's very highly unlikely that we can get a good positive result out of it. So if you see, the stage 3 is very most important bottleneck, like, because clinical interpretation and annotation takes a lot of time. Then finally you see the output, it's a drop. We started with a bunch like a data which was in like plethora of data. Finally we got a drop. So that's how the flow is. So we need to understand this. Based on this, finally, if we start using AI, so it's been already being used, it's not that it's not being used, it's being used, but it's not widely propagated or not widely used because we don't have infrastructure for that. The accelerated AI, basically, if everybody knows about NVIDIA, right? Like everybody talks about NVIDIA GPU cards and everything. There is something called NVIDIA Parabricks. The analysis time, what I told about like 1 day, with NVIDIA Parabricks, it becomes in 45 minutes. Where is 1 day and 45 minutes? But for that, you need to have the GPU. One single GPU costs, like the latest one costs around 20 lakhs. One GPU. So how much can you invest on that? It's very important to understand. So finally, ultimately, after I've been talking about pipeline and everything, like this is possible. Okay, everything is possible. Like we have good software engineers, everybody can do it. But finally, the most important part is, the data. What Dr. Gupta was talking about, the data transparency, like which data is trained on. So it's very hard to know. It's very hardening to know that the human genome reference, what we use currently, has no Indian or no South Asian reference to it. So it's all European reference. So whatever we do, it's always not going to be 100% accurate. So we need to understand that. And also Dr. Asthana told in his talk regarding silos, regarding the silos in organ transplantation. Similarly is happening with the data also. So we have been I think all the AIIMS generate data. Do each no, like all DBT institutes share generate data. No, it's not. But with the IBDC, it's been slowly started. Like I think the best example was, I think Dr. Debashis was part of it, the INSACOG, where there are around 65 institutes across India. They've deposited data at one place. So that made job easier. So that's very important to know. So coming to the very important part, the diagnostic paradigm shift. And this is from a reference from a Mercy's Hospital in Kansas. Okay, there is a pediatric genomic medicine division. So they did something called 26 WGS. What does mean is there is a 26 hours turnaround time. Okay, they traditionally, the first part is the traditional workflow. It takes weeks and months. But in the 26 hours workflow, what happens is a new baby is born. They feel that there's an epilepsy kind of symptoms happening. So then what they do is they do a rapid WGS. Okay, they do a rapid WGS with a priority queue, AI priority queue. They find out there is a gene called SCN1A. It's a sodium channel gene, basically, which is generally known for Dravet syndrome. Basically, they find out that is mutated. That's mutated in the baby. So then they make sure that the baby gets a treatment based on the genomic changes. It's basically a genetic treatment. It happened within 26 hours of the baby. Like there are 5 or 6 hospitals across the globe which they are doing with this 26 hours. And like I'm not happy that there is nothing from India. So there is from Korea, US and UK people are doing this. So what this does is this gives an immediate therapy. What people were talking about, the immediate attention, giving the attention to the detail. So this happens immediately. This is done because the data is trained based on their data. It's not in India. It will be very hard because the data is not trained with our kind of data. So the most important thing, I think, starting with what ma'am talked about. So we have multi-omics, something called multi-omics. Multi-omics is different types of studies. So we start with the clinical data or the EHR records, what we have, then metabolomics data, proteomics data, transcriptomics, genomics. You club all together, you get an outcome. Basically, you can train a model basically based on all these data types. So here the best example is we can predict Alzheimer's. We can you can understand whether the Alzheimer's is gonna come after some years or not. Also, even kidney disease trajectories. These are all there are some test cases already being in. There are papers already published on this. It's not like any random thing. But only thing is getting to clinical setup, how viable it is. Very important thing. So yeah, data now I think it's already covered. The data harmonization, it's very important. Like there are two parts basically. There is one called something called biased pipeline. There is a ancestry aware model. So we need to understand what we want, then we should take that. So I'll not go in detail about it. There is a different tools which have been being used using AIs. Like there is something called deep variant. Everyone might have heard about AlphaFold. AlphaFold is one of the Nobel winning AI algorithm. They won Nobel Prize last year. So that's from a company called DeepMind, and it's funded by Google. Okay, so you see the bigs and bigs are investing in AI for health, like including NVIDIA also. If you just Google NVIDIA healthcare, there are around 10-15 open source tools which are available for usage for anybody, including for imaging, even for patient records, everything. So very recently, DeepMind published a paper in 2026 January. It's called Alpha Genome. Okay, so what is, you just give 1 million base pairs of DNA sequence, like ATGC, that's it. That's your job, that's it. Everything else it does, it gives you the whole data with annotated. Like there are 15-16 types of annotation. It will tell if there is a gene, what is the modality, what is the morbidity, like everything. Like it talks about everything. It gives you basically to talk about, it gives you the kundali of the particular, that mutation. So but again, this is trained on the data from the east or west, not on our data. So we can't directly use it, but the algorithm is there. The data should be trained better. Like that's the whole important. So this is the applications for this. This is variant interpretation. You get synthetic biology and GWAS augmentation. These are primary, but there are definitely challenges, because if the sizes goes beyond like 100 kb, it gives you wrong. There is a wrong information possible. Also, cell to cell type regulation is very rare in the context, and integrating with epigenetics, as the genetics is how much the genome is important, epigenome is equally important, but it's not taking consideration in this. So the last, I think this is coming to the end. So responsible AI. So I think everybody had heard about the AI summit which happened in February. During that time, there was something called India AI governance guidelines. So it talks about the 7 pillars of guidelines, where they are called 7 sutras. So it talks about trust in the foundation, and people first policy. Then we have the innovation, then fairness, accountability, safety, then understandable by design. So this is very important to understand. Also, when we talk about the patient data, so if you see, I have just kind of created a model where the model stays at one place. Okay, only the raw data doesn't leave the hospital. Only the relevant information has to pass to the model. It's not that I'm giving everything to the model to understand, because I don't want to give the patient information to the model. I just want to give the disease information to the model. So it's very important to have this model in place everywhere where the patient information is not shared. So the most important part, I think we've been hearing that whether AI will replace us. So here I've just tried to create something like AI is your, like, it's at the base. Okay, it's not like it will not come at the apex anytime. Like it's not a point. So there is an institution in between. It decides what you want to do with the AI. Okay, it's not that AI will decide what it will do. Okay, there should be an institution or a regulatory policy which will decide what AI should do. Finally, at the apex is the clinician. Clinician will decide whether what the AI has given is correct or wrong, because he is seeing the patient, he is seeing what's happening with the patient. AI cannot tell that. AI is just giving an extra added information. So at the apex is always a clinician. So my addition to what Professor Gupta was telling, person knowing AI will replace you, not AI. Okay, I can just tell that. The person knowing AI or person using AI can replace you, but not the AI. So that's the whole point. So finally, I think this is very important to know. Like, I think it's very optimistic in nature. Maybe after 10 years or 5 to 10 years, we'll have something like, we'll have routine cases where we use AI in our day-to-day practices. Then we should understand a champion. Champion in the sense the best way scenario where how to use a responsible AI. So finally, that's like we try to build on our data. That's my wish that we should build our own data sets and train the data on that. So with that, I think we should scale the genomics to every hospital with responsible AI. Thank you.
Thank you, Dr. Sanjay. Thus, I'll summarize three things. There's one Socrates told to the audience that I am the wisest among all of you, means that I know that I don't know anything. That's why he is the wisest. That's the way what we are propagating, like Sanjay presenting this is the petabytes things. Once I was in a brain cancer research center, brain center in IIT Madras, Dr. Jayakishan told one slice of brain. He wants to decode the data. The computer hanged. And he gave the example, till date, no computer has been evolved that we can, that one slice data of the brain we can preserve. Means that much of data in one slice of our brain is handling. That means this is the way. But that doesn't mean we will be so nihilistic or so depressed that we cannot do. If you see our treatment in oncology, if you see this is the people survival was 5% in pancreas, now voting the 45% because we are moving once. This is a stepwise development. That's we should not be nihilistic that we cannot do anything because the computer is not there. Petabytes we cannot develop. Everywhere like the centralized one thing, like in Visakhapatnam they are creating. This is the way of development. We have to put into the line that we have to be aware that AI is coming in a big way to our system and we have to adapt. That way we have to take the help of like this, the engineers who have to focus on the data evaluation. That's why when we develop the data, we has gone through 4 to 5 stages. Data collection, then further data cooking. Cooking means lot of permutation and combination, whether this data is right or not, wrong things, like so many data is coming. Then you have to go to the validation, means standardization, that utilization. Then you will coming into the output. These phases we have to go through all data. People are always discussing output, but how they are keeping the data is more important. So where you are keeping, who is keeping, we are putting data entry operator for the data, what he is putting, we are analyzing and giving the data. That's why over the years, even if you see Watson Crick failed, IBM created the Watson Crick, the things it will change everything, therapeutics, all these things. That's the most important. This awareness is important. That's why this AI awareness by the NAMS is coming into things. All of you have to empowered with AI. If you are not making yourself AI trained, tomorrow you are illiterate in medical science. That is the way we have to move. Thank you so much, Sanjay.
Thank you, sir.
The next important thing, the next speaker will be K.N. Bhagat, who is the chairman and managing trustee, Odisha Trust of Technical Education and Training. He is really the practically involving the AI in day-to-day life. What we will see that how he interpreted in the field, and this AI will listen to him. Then Dr. Bhagat. K.N. Bhagat. Sorry. Sorry. This is the wrong giving this session. Next speaker. Yes, sir. We'll giving it. Welcome. Next session we'll giving the one you.
Yes. Good evening. I'm sorry, my throat is not all right, but however, I'm grateful to the organization NAMS and as well as the AIIMS Bhopal for giving this opportunity to stand before you. And first, I would like to put about the organization that what we are doing, we'll play a video on this. Then again, I'll talk to you. And I will also request Mr. Indraprasad Singh, who is our technological partner, to go ahead with this presentation.
So, good afternoon to all of you. We are going to present the scenario of telemedicine practices which we have evolved and implemented to achieve the okay.
Sorry for this break, but may I please invite the chairperson for this session, Dr. Aneet Arora, Professor and Head Forensic Medicine and Toxicology, AIIMS Bhopal. Dr. Sanjay Kumar, Additional Professor, Anesthesiology, AIIMS Deoghar. Dr. Vaishali Vakye, Professor and Head Pathology and Dean Examination, AIIMS Bhopal. And Dr. Balakrishnan, Professor and Head Department of Pharmacology, AIIMS Bhopal. Sir. Okay. Yeah, we will first begin with the talk by Dr. Rakesh Agarwal. He is National Chair for Disease Elimination, Indian Council for Medical Research, and sir would be speaking on using AI in clinical medicine, opportunity and challenges. Over to you, sir.
Good afternoon. I know the afternoon siesta is here, and obviously a lot has already been said, so I'll try and minimize repetitions and try to give you some different perspectives compared to what you have heard. May I have a slide, please? ये मेरा नहीं है. मेरे से किसी ने पेन ड्राइव में लिया था आपकी. लिया था किसी ने, राकेश अग्रवाल. हाँ, ये सही है. So, you've all heard what AI is. In summary, we use computer systems to learn, comprehend, reason, solve problems, make decisions, and create things. So, really speaking, it is thought that artificial intelligence or a lot of computing power has come to us at the right time, because this is also the era of precision medicine. As we heard that you are going to have something on that topic also later this month. So these two things together can help us personalize care, that can possibly help us diagnose disease early, can help make medical decisions and track disease progress. But let's see, whether there are only opportunities or there are also some challenges. So if you really look at how AI can be used in clinical medicine, these are some ways that I have listed on this slide. We can use AI for better diagnosis, for more personalized, which means focused, more specific, more safe, more effective treatment recommendations based on data from a patient. As human beings, our brain has limitation that we cannot consider more than 6 or 7 facts at a time. On the other hand, computers can consider many more facts and hence may allow us to make better decisions. They can be used for developing predictive models. By combining various kinds of data about a person, they might be able to tell us whether a person's disease is more likely to progress or less likely to progress. And you heard from Dr. Sangeeta Desai some examples of that. They may help us stratify the risk of complications, risk of mortality, risk of hospital admission in a person. They can also be used for real-time patient monitoring and treatment administration. So there could be wearable devices, sensors. For instance, we could have a continuous glucose measurement device connected through a software to something that delivers insulin continuously, and we could get better blood sugar control, or for that matter, get better arrhythmia control, better seizure control, etc. And then there are low-level activities. So there can be chatbots that can support a patient's simple questions, that can educate patients. We are all familiar today. If you want to book your ticket, if you want to change your ticket, you go to the website and there will be a chatbot and you just put in your questions and it will solve your questions. And there can be simpler systems which can automate patient appointments and scheduling. But if we look at the higher level things, the first 3 bullets here, these applications could also vary by the field of medicine: diagnostic imaging, clinical decision support systems, pathology and molecular biology, surgery, and drug discovery. I'm not going to talk about drug discovery. I removed those slides because Professor Gupta has talked to us about that in detail. Now let's first come to imaging. Imaging is possibly the best application, the most developed application of AI as of today. That is pattern recognition. If the computer systems can recognize my face in DigiYatra when I walk in and say, "Welcome, Rakesh Agarwal," then what is the problem? Why can't we have an image and say, "Hi, that's neuroblastoma"? So that's where we are. We have systems. We have systems for chest x-rays. They've been used for diagnosing COVID-19, and that's possibly where the maximum literature is available. We have softwares which can help us diagnose tuberculosis, not as good. We have things which can help us diagnose small fractures that may not be easily visible to an orthopedician or at least to a lay doctor such as you and me. We have systems for looking at CT scans, ophthalmology, fundus photographs, dermatology, and also we could use that for teaching purposes. For these applications, at least some of them, AI seems to work very well. However, the question is, can this be relied upon 100%? And the answer would be no. This is helpful possibly for improving efficiency. If you have a lot of normal x-rays and you want to see which ones the radiologist should focus on, yes, this could be a good application. If you have some x-rays where the diagnosis is already, you want to triage, it's a good thing. But ultimately, it has been realized that we will always need human supervision. Though there are challenges, today we have people who are human trained supervision people who can supervise and do this. And I'll come to some problems with continued use of AI, what is going to happen. And I think one thing that we need to remember for this also is the black box phenomenon that I'll come to a little bit later. Then more complex things are something called clinical decision support systems, which means we use a computer algorithm or models to a range of clinical data. Now, these data could come from your electronic health record. This could be your vital signs. This could be your, continuous ECG recording, continuous EEG recording. These could be lab tests, including the images that we talked about. And people are saying, why not even unstructured notes or doctors speaking something into the software and that could be recorded? And the serial follow-up data while you are in the hospital. And that could be used for several things. It could be used to predict whether a person is developing sepsis. So maybe it picks up a small change in temperature, a smaller change in some biochemical and hematological parameters, and say this is a person who's going to go on to develop sepsis. This is a person who's going to develop kidney injury. He's going to deteriorate. He's going to have a longer hospital stay. You better be prepared. He's going to be before discharge that he has a high risk of coming back. So you might keep him for another 2 days in hospital, and so many things. And it could also help you tell you between the 3 alternative treatments that are available, which one is more likely to work or which one is more likely to be toxic. It can predict pharmacokinetics, it can predict pharmacodynamics, and therefore it could help you in choice of treatment. Now, the thing is, there are softwares and they have been shown to augment clinician judgment. But does it make a difference in the clinical situation? Today, we are controlling blood sugar by measuring a person's blood sugar 4 times a day and giving 3 injections of insulin on a day. If I were to instead get a continuous glucometer, which is feeding data into a software and controlling a continuous insulin pump, I may be able to prevent some fluctuations in blood sugar. But does that change clinical outcomes? Does that mean I'm less likely to develop complications? Does that mean I'm less likely to get a coronary artery disease, or for that matter, neuropathy, retinopathy? Unless we show that, that AI, we are not very sure is useful. And that's something that we need to bear in mind. The aim of all this is to improve human health, to improve outcomes. And unless we can show that all this AI might actually be useless, it might be like fashion. I decide to wear something, but whether that really helps me live longer or live better, we are not very sure. Sorry. Now, let's go to the next one, and that is pathology and molecular medicine. I'm going to try and skip this because, already Dr. Sangeeta has talked about this. Again, there is a likelihood of increased diagnostic accuracy and prognostication, but does picking up those micrometastases, does picking up those specific subtypes of the cancer change prognosis? Unless we can show that there is clinical benefit, I think the jury is still out. For some situations, it's yes, but for other situations, for each situation, we'll need to show that it works. There are a lot of applications in surgery. Surgeons initially thought that there will not be much application of AI, but it seems that there are ways softwares may be able to predict in which patient surgery is going to be more difficult, in which patient there is a higher risk of complications. Can we know beforehand whether there is a higher risk of lymph node involvement, tumor resectability? Then maybe we decide beforehand what my approach is going to be. For orthopedics, it might be able to tell us what implant size would be better. If there are 3 implant types, which one would fit into the bone better? There could be, during surgery, it could help make sure that the lights and the camera focus at the right place automatically. It can judge by looking at your movements which part to focus on. It can filter out if a surgeon has some tremors and still is operating. It can optimize whether the instruments move. If the instrument starts to go in a certain direction, it gives you an alarm. Robotic surgery, of course, is a distant example. But again, this is an area which is evolving and we cannot be very certain. I've still talked to you about the positive things, but every coin has 2 sides. Fortunately for us, the coins, both the sides are useful. However, for technology, the other side can actually be harmful or can be a challenge. So with AI, you've already heard from the previous speaker that we need large data sets. Not only do we need large data sets, we need these to be accurate, clean, and complete. If you do not have, for some people, observation on one parameter, those people can then not be included in generating the AI model. There are issues about data security, data privacy. You take everybody's data, put it into a model, and try to develop a model. Those data are available. The speaker before me said only the patient's disease data will be sent to the software. How do you do that? You'd have to tell the person's age, you have to tell the person's sex, you have to tell the person's place of residence, you have to talk about whether the person has hypertension, diabetes. You tell 20 of those things, I can identify a person. There are instances in the US where they put in de-identified genomic data in a public database, and by just looking at a person's genome, they were able to say the person has to be a male because he has Y chromosome genes. He has this particular gene, so he's an Ashkenazi Jew. He has this. The only place they knew was in which city. Unfortunately, in that city, there was only one Ashkenazi Jew living, and they knew who the person was, and there was a big lawsuit, and the person won. Are the data generalizable? Any data that are obtained from patients coming to AIIMS Bhopal, based on those x-rays, the decision that you arrive, do you think that applies to patients who come to Gandhi Hospital in Bhopal? Possibly not. Do they apply to the hospital in Indore? I don't know. Do they apply to a patient in Srinagar? Of course not. Those data may not apply, and I'll show you some examples. There are biases, there is discrimination, and I'll give you an example. There is data drift. Today you have patients, a large proportion of whom have tuberculosis, and the prior probability goes into your algorithm. If you were to look at 20 years down the line, the same algorithm will not work because the tuberculosis prevalence is going to be different. Those models that we generated for diagnosing COVID 3 years ago, 4 years ago, can you apply those today? They don't. The data drift over time. And so there is no generalizability over time. Lack of explainability, I'm going to go into details of that. Do you trust? Do you as a physician trust somebody else to take decisions for you? On the CT reading by AI says that this is a brain tumor. You've been seeing those CTs for 30 years and your brain says this is not. How do you do? What do you believe? Unfortunately, the problem is if your radiologist says that this is a tumor and you do not believe it is, you can go and discuss with your radiologist. You can override your radiologist. What do you do when the AI does this? Can you try and discuss with the AI? It's going to be extremely challenging. And the problem is the human brain, the way we treat computers, when the computer gives you an output, inherently we have greater faith in it than what we have in something that comes from a human being. And that's going to be a challenge. There are issues about regulation and approval process. Before you use a device, it is to be approved by somebody. Who's going to approve AI? Who's going to say that the diagnosis given by AI is reasonably okay and you can base your decision on it? If you, and how do us, even if they approve it, how do they say that the software will continue to be, the software is supposed to learn over time as they treat more and more people. How do we say that in 2 years it will still be reliable? How's going to be a regulatory process for things that change over time? If somebody were to tell you that there is a drug that is produced and they'll keep changing the amount, would the Drug Controller General of India give approval for that? No way. There are transparency and liability issues. The software says this is this tumor and we don't need to resect it. You decide not to resect and it turns out to be something different 2 years later. Who's responsible? You, the pathologist who gave the report based on digital pathology, or the company that made the software. And there are those issues. So let me come to this black box problem that I referred to. So sorry for too much light. So on the left, actually, you have a picture of a butterfly. And when you put a data into an AI image software, it says this is an insect. You have no idea how does it say that this is an insect. Is it based on its pink color? Is it based on that it flies? But then why is it not a bird? But you'll believe this if it were to tell you that because it has 6 legs, I believe that this is an insect, because other phyla, other families don't have 6 legs. So the problem with this is if you put in a CT picture and it says it's COVID infected but doesn't tell you why, in medicine, we are not going to believe this. On the other hand, if it can tell you, I think it is COVID because I have found disease in this particular part, you're going to believe it more. If it tells you in this part that image shows something like this, you're going to believe it more. But does that become a problem in real life? This is a study published in 2021 when COVID was around. And if I were to ask you to focus on the right side of the slide, what they did was there were 2 different models. They had a so based on a training images, they made a neural network and they tested it with other samples that had been collected from the same sources. And there was a second model trained using a second set of this thing. And so these were also validated by each other. When you validate a model with the same software and the other with using x-rays from the same source, they perform very well, and you can see ROC curve with an area under curve of more than 0.9. But when it is tested with the other database, with the other data, you see the ROC curves change totally. The performance deteriorates. Each model works well with data from the same source, but does not work well with the data from the other source. And they tried to look at it and they said, which are the areas which help the model distinguish between COVID and non-COVID? And dark areas are the ones where it makes a difference. They found that those areas were lay within the lungs, but a lot of those areas were in those shown in this red images, red part. Now, basically what was happening was COVID x-rays were taken on one machine in the hospital, non-COVID x-rays were taken in the other part of the hospital. In one, they were placing things like the markers for right and left on one side, in the other one on the other side, and the software looked at this and they started looking at that. So we need the AI to be explainable. The other thing is there are problems. So I am a gastroenterologist. They asked people to do colonoscopy without using AI and with AI on the same people, and these are about 2,000 people. They found high risk polyps in 9.5% of people using the current guidelines in the US. But when AI is used, it picks up smaller polyps, and now there were nearly double the number. Now, these additional people, you can say, are early pickups. But on the other hand, these are people who possibly are not at a risk of malignancy and will undergo unnecessary colonoscopies through their life. And is that a problem, a benefit, or is that a disadvantage? And when they tried to change the threshold in AI to bring it down, they found a large number of those who actually needed colonoscopy were now going out of colonoscopy, and there was a problem. We are talking about automated devices. So the faulty glucose, this is very recent, last month. In the US, faulty glucometer monitors have been linked to 7 deaths and more than 700 people who got injuries. Now, if this glucometer is connected through a software to an automated insulin injecting device, you're going to have problems. There'll be many more deaths. Another problem, we are in medical education. They asked people who were doing colonoscopies, and they looked at their record 3 months before AI was implemented. Then they implemented AI for 3 months, and then they asked people to again do colonoscopies without AI assistance. Earlier, they were able to pick up polyps in 24% people. After spending 3 months using AI, when they went to colonoscopies without AI, they could pick up only 22%. They lost 1/4 of the people. Now, if you were to have residents who were to be trained in a setting where AI is used, when they go out into the field and work without AI, as a teacher, I dread that day when I send out students having trained them using AI and they were to go and practice in the field. What are they going to do? Forget that. There's going to be hacking into your system and your AI is not going to work for 4 days. What is going to happen at that time? You're going to have challenges. Even more interesting, this is a paper that appeared about 10 days ago. Now, this is not from the field of medicine. They asked people to write a paragraph on a topic, something like, do you agree that there should be death penalty? And while they were typing, just like when you type in Google or you type in Gmail, you get autocomplete suggestions. They changed the software so that it gave you suggestions slightly tilted to one side. And they asked people to write. When they asked them to write without any assistance, when the AI was not trying to do anything, if this is what they wrote, on the other hand, when the AI was giving them suggestions, if you see, the score towards in favor of death penalty increased. And if they gave suggestions, which were 3 possible suggestions, but they were not given in continuation with your text, things did not change as much. Then they did it with 4 other questions, not only about death penalty, and they found things change. Even when people were warned that AI can change your opinion, so be careful, even then their opinion changed. Even when at the end they were asked, are you sure what you have written is your opinion and not AI's opinion? Even then they found what they wrote was wrong. So AI can change, and even after a few days after they had done this, now their opinion on the same subject had changed. This is something as social experiment we should understand. If this can happen on those subjects, why can it not happen on, do you think a person has tuberculosis or does not have tuberculosis? Your opinions could change. And to me, these are scary things that we need to think of. And when they ask them, do you think that the suggestions provided by AI were reasonable? Majority of them thought it was providing reasonable suggestions, though there is clear evidence that what they wrote had changed. Finally, the speaker before me referred to costs. Let's just look at, there are multiple costs. If you just look at the power use, in 2023, it is seen that the data centers were using more power than the whole of France uses for everything together. And if we look at what is projected for 2030 around the world, this is IMF data, so this is not from a private website. They have said that by 2030, AI around the world would be using as much power as the 1/6 of the humanity living in this country uses. What would happen in India? Where would we get all this power from? So we have additional challenges in India. Where are our large databases? Individual patient or at population level? No patient's data is at one place. The data are in different places. Every time a patient comes to me, he brings me such a big bunch of papers and I have to go through them. There is not, they are incomplete. They are of variable quality. Half the times when I put a hand on the patient's abdomen, I find liver and spleen, which 2 days ago the previous person had not even detected. They are biased data sets. These are data sets that belong to rich people. They don't cover a large proportion of a healthy people. The hospital systems have to be same. They are very different. They're different patient population, this different quality. Our hospitals lack in IT networks, they lack computing power. You heard what kind of computing power and storage we need. Lack of expertise in AI and information technology. In this room, I don't have internet connectivity. What are we talking about? If we can't have internet connectivity here, how are we going to work on AI? This is how our hospitals are. We are not like the US hospitals. There are regulatory processes are not there, liability issues are there, costs are there. So I think, yes, we should understand AI, we should understand its capability. But to think that we will be using it tomorrow, we will be using in 2027, or we will be using in 2030, for some isolated things we may use. But to think that our hospitals are going to be computerized, or we are going to be rendered redundant, not in my lifetime, very likely not in the lifetime of many of you. Thank you.
Thank you, sir, for a lucid
Sorry,
talk.
I exceeded my
It's okay. Thank you, sir, for a lucid talk on the translational aspect of artificial intelligence. So far, we have been listening to lab-based AI. Thank you so much, sir.
Before I announce for the next speaker, Dr. Saikat wants to give some information. The next speaker I will just introduce.
With the permission of the chairpersons, one of the major aim of this workshop was to disseminate the task force reports. So I would now request President NAMS, Professor Digambar Behra, to officially hand over the task force reports to representatives of the region, that is Madhya Pradesh, Maharashtra and Jharkhand. So on behalf of Madhya Pradesh, I request Director AIIMS Bhopal and Director BMHRC to please take the task force reports. And sir, we have also distributed it to the participants. And representatives from AIIMS Nagpur, Dr. Nilesh is here. And from Deoghar, Dr. Urmila Sinha. Madam is here. Thank you. Now we'll continue with the sessions.
May I now invite Dr. Atreyi Ghosh, IITI Drishti CPS Foundation, Indian Institute of Technology, Indore. He will be delivering a talk on human digital twins as clinical decision support system, the next step in AI-driven healthcare. Welcome, Dr. Atreyi.
Ma'am, for want of time, we would restrict you to 10 minutes of person. Thank you so much.
No, I think I've put the. A very good evening to one and all present here. I think my work has been made a lot easier by our previous esteemed speakers. So I would just hop through some of my slides, but most importantly, I would like to begin with a little introduction about who we are and what we do. So again, I am one of the outliers amongst the crowd of clinical experts. I am a biomedical engineer. I did my PhD from IIT Indore, and currently I'm working at the Technology Translation Research Park set up by Department of Science and Technology, Government of India at IIT Indore. So a little on yes, a little on what we do. So IITI Drishti CPS Foundation, the Technology Translation Research Park in Digital Healthcare. So we are pretty new. We were set up at 2020, but we became fully functional and operational at in the year 2022. So we are a technology innovation hub under the aegis of National Mission on Interdisciplinary Cyber Physical Systems, NMICPS, working along the technology vertical of system simulation, modeling, and visualization. So we are committed to fostering technology development and commercialization, skill development, startup support, and employment creation in the field of cyber physical systems. So it is then we have an ecosystem where we are very closely working with faculty members, researchers, students from across the country for bringing relevant technologies from lab to market. So our effort majorly goes into helping the technologies traverse the journey from build, deployment, validation, and commercialization. We involve relevant industries, state government departments, line ministries, PSUs, and startups in our ecosystem. That is what our ecosystem looks like. We have couple of medical institutions spanning from primary healthcare centers to tertiary medical institutions working with us while developing predictive models, models for personalized medicine, which I will be quickly covering in my next slides. And our key focus is something called developing the human digital twin. We have then a testing and validation network. So I remember one of our previous speakers, Dr. Gupta, mentioning about this domain, AI in artificial intelligence in healthcare being an interdisciplinary domain. So if you look into our ecosystem, that is how our work proceeds. It goes through testing and validation with our healthcare medical institutions, our industry partners, and then the commercialization pathway is something that is supported by our startup system. Moving on to a little on the direction that we have set in today's CME, artificial intelligence in digital healthcare. We have now understood that clearly in India, we do not have shortage of AI innovations. What we are facing instead is translational challenge. So we have powerful algorithms, promising prototypes, and a rapidly growing body of research. Yet, very few of these systems are meaningfully embedded into clinical workflows. These remain, therefore, there remains a gap between what is technically possible and what is clinically usable. From the perspective of a technology translation research park, working in digital healthcare, we constantly encounter a few systemic challenges. A validation gap. Our previous speakers have actually given some very important examples where AI models lack multi-center real-world clinical evidence. The last mile translation gap, where innovations do not progress from prototype to deployable solutions. Third, the workflow integration challenge, where tools fail to align with how clinicians actually work. Fourth, persistent data silos, limiting scalability and generalizability. Lastly, but most importantly, questions of trust, accountability, and clinical ownership. So the question then probably that we might want to ask is, not just can AI work, but can AI work within the constraints of our healthcare ecosystem? So it is within this context that the idea of digital twin becomes particularly relevant. I will just cover some quick slides on what this concept is all about and what we are trying to develop. The concept of digital twin and a standard architecture, it exists in the field of manufacturing, but we do not have a standard architecture yet in the field of healthcare. So as per ISO 23247/2021, a digital twin is defined as a fit for purpose digital representation of an observable manufacturing element with a means to enable convergence between the element and its digital representation at an appropriate rate of synchronization. The word rate of synchronization, that's the most important thing here. How fast and how often the physical system and its digital counterpart or digital representation are brought into alignment. Not necessarily in real time, but at a rate that is sufficient, efficient, and meaningful for the use case. This concept of a digital twin is something that we are trying to apply in the field of healthcare. So industries are investing heavily in research and development of DTs to leverage the benefits of real-time monitoring, estimation, prediction, and optimization. So a couple of key characteristics when we talk about digital twin, because it is clearly very different from certain confusing terms like digital model, digital shadow, and digital thread. So a digital twin, it should represent the physical asset as it is. Not just that, it should evolve. One of our previous speakers said pointed this out. So that is an important feature of digital twin. So consider a human body. It is not the same every minute. We are evolving, though we have a genetic blueprint, but we are evolving based on the lifestyle, the food we intake, our workplace environment. If I do not probably have the same hours of sleep on an everyday basis. The moment the noise decibels increase, my body responds differently. The particulate matter in the air differs from city to city, our body's response differs. So as our body is evolving, my digital counterpart, my digital twin also has to evolve. Therefore, these predictive models that we have been talking about, the AI ML models, there has to be a framework where these models can eventually learn and evolve as the physical counterpart, which is an important aspect of digital twin. So coming to the framework, this is what I am here to talk about, the only slide probably that I will be focusing on. So the architecture. What does a digital twin platform or architecture look like? So the proposed framework, we tried mapping one for the healthcare. So the one that you see on the right-hand side is the one that we have proposed recently for healthcare, which got accepted in one of the journals. So this architecture consists of 5 important layers. The digital twin user entity, and that is where the expert never goes out of the loop. We cannot do without the clinical expertise here when we talk about the healthcare domain. So a digital twin always incorporates the user entity. The user entity can be the patient, the individual himself or herself, and can also be the stakeholders. Stakeholders being doctors, medical device manufacturers. When we go for drug testing and optimization of drug dosages, even that can benefit from a digital twin architecture. The second being the digital twin core entity. That is where the entire analytical module comes in. We then have the device control and data collection, because when we talk about the healthcare domain, there is data coming from different sources. How do I make a digital twin of a human body? I have to take into account data coming from smart watches maybe. The moment a person is in a critical care, is put on a mechanical ventilator, there is data coming from mechanical ventilator, paramonitor. That has to be taken into account. There is so much of unstructured data, clinical notes. They have so much of our medication records, symptoms, diagnosis written. That needs to be captured. The nursing charts that are made. So bringing together both structured and unstructured data, that pipeline is a core aspect of the digital twin framework. And what we have introduced majorly in healthcare is, it's not just a replication of what existed in manufacturing. In healthcare, there are 2 important entities that we have introduced here. One is a learning module, and the other is a rule-based engine. So the application and the service layer in the functional entity, we have replaced it with a rule-based entity. This entity is one of the most crucial component of the digital twin. It incorporates clinical guidelines and techniques that are defined and used by healthcare experts. And that is where it is an expert-in-loop decision support system that is being built. So the expert never goes out of the loop. This particular layer ensures that the system's decisions are based on the best practices, up-to-date medical standards. This entity further analyzes patient data against already existing rules to detect the presence of risk of a particular condition. This allows prompt generation of alerts and recommendations, enabling healthcare professionals to take immediate informed decisions. So the rule-based functional entity therefore enhances the core entity by providing a robust framework of data analysis and decision making. Secondly, and the second most important one, is the synchronization entity in the manufacturing domain, which now we have replaced with a learning module. This makes it easier for the decision support system to continuously improve. Today, a neurosurgeon in a critical care might consider some 5 parameters to take a decision on whether a risk is about to manifest or not on a patient. But tomorrow, when the patient changes, or maybe with the patient response, there is also a need to incorporate parameters 6, 7, and 8. And the decision-making person, the expert, might not agree with the model's decision. So this is where the learning module comes into play. It has to take into account the extra parameters that the expert considered to take a decision, and has to train the model and return a feedback that matches next time the expert's decision and is much closer to the decision every time. So that is how the digital twin becomes intelligent with more and more testing and validation on prospective cohorts. This is finally what it would look like and how then we can define a DT for healthcare. So it is a virtual represent and behavior, not just virtual, but most importantly, a behavioral representation of a person, organ, or a biological process generated by the continuous collection, storage, and modeling of a person's health-related data for creating decision support systems for personalized and preventive healthcare. So if you can see the from the real world, data can be captured from so many different aspects. That goes into the virtual world, the digital twin world, wherein the analytical pipeline is only so much, where the data analytics, AI, ML aspect comes into being. But this analytical pipeline cannot exist in isolation without the user entity, where the decision making actually happens. So who are the beneficiaries? The beneficiaries, so the application services look like this. The digital twin can be used for surgical planning. It can be used for personalized medicine. It can also be used for medical education and training, medical device design and optimization, as well as drug dosage optimization and in silico testing. So our team has been working on a couple of decision support systems implementing this architecture that I just talked about. So then if you see, we have categorized. We have certain decision support systems that we are working on. We have a couple of integrated data collection systems that we have put up. Then there are digital models that are getting built. And ultimately, there are disease diagnosis and management systems coming up. So all of these have to follow the architecture that I just talked about. And it is only when all of this come together that we will be able to go for disease progression modeling, environmental and lifestyle impact analysis, infectious disease outbreak prediction, personalized medicine and drug response simulation, tumor evolution and drug resistance prediction, as well as pandemic prediction and mitigation. One of my last slides, we work on a multi-institutional framework where these are a couple of tertiary healthcare institutes which we have collaborated on to develop a couple of applications of the digital twin. We started with AIIMS New Delhi, where we are majorly working on building a critical care digital twin. The current work is also on integrating whole genome and morphometric profiling for digital twin-based prognostic modeling in severe traumatic brain injury. We have a good collaboration with AIIMS Bhopal, wherein I would just mention one of them probably. We recently have an ICMR-funded project with Dr. Saikat, where we are trying to develop a tool where informed decision-making can be done for cancer patients. And also, we have a couple of other diseases, other aspects of the human body for which we are trying to build decision support systems. So I had a particular example on the critical care digital twin where we are trying to detect the onset of one of the risks. We have picked up ventilator-associated pneumonia, but this can be scaled up for multiple such conditions. So it is not just important to identify the risk or predict the risk. The digital twin should also recommend personalized ventilator recommendations for that particular patient maybe. Lastly, it's important to tell why. Why did the model say that this particular patient is about to develop a ventilator-associated pneumonia? What is the reasoning behind it? Can I make the model much more intelligent? Can it identify patterns and give an explainability? So that is what the critical care digital twin work looks like. We have been able to validate it on unstructured and structured data, so that there is a data collection pipeline that we had to build initially, and the validation is still going on. it's important we have a multi-institutional framework, because it's again important that a model that has been validated on patients at AIIMS New Delhi, it needs to be validated on different regions and areas in India, because we have so much of diversity. So more the prospective cohort, better the models are trained, and that is how they become the standards for the Indian system. So that is how these are some of the images, some of the glimpses on how the data collection platform looks like. This is some of the work that we have done on maintaining the data, the way the pipeline has been created. Some results on the model. We were able to compare different models, and we have one champion model. We have been able to talk about the sensitivity and specificity trade-off, because that is very important. And then coming on the personalization aspect of things, with interest of time, I would probably skip, but that is what the work looks like. We have to define the patient state, the patient profile, objective function, reward function, both patient state and patient profile. This is where the expert comes into loop. It's the intelligence of the doctor, the experience of the doctor, where the parameters are decided. Which are the parameters I want to build the model on, and how the model should then evolve. What kind of demographics, physiological compatibilities do I want to involve? So that is how the objective function and the reward function is also then decided. So finally, moving on to the last slide. So here we are then also able to address some of the stretch goals. Stretch goals being the digital twin architecture, the example that I took, which is critical care. It will be able to also optimize resources for me. Maybe the intention is just not to predict or personalize something, but also can I manage resources in a critical care better? If I know that over a period of time, what are the lab tests that are absolutely necessary for a particular patient, the resources can be optimized accordingly. I would know how to manage the shifts of the working professionals, the nurses in the critical care. So cost reduction, better asset management is something that is the stretch goals, the extended goals of a digital twin. So I will probably now come down to how, so this is how my team looks like while I get to do all the talking here, but I am backed by a very strong team of, I have a development and analytical team. I've mentioned a couple of them who have been working on the projects that I showed on the multi-institutional framework. I have two of them who have accompanied me here, Muskan and Harsh. We also have, we take advantage of IIT Indore academic pool. But most importantly, at Drishti CPS, we have software engineers, the analytical team, so a team that is multidisciplinary, and with the academic backup that we have. But then our collaborations with medical institutions is important, so that we develop solutions that are actually needed by the Indian population here and are validated on Indian data sets. Couple of our collaborators in this particular work that I just took you through. So Dr. Deepak Agarwal, Dr. Bhupesh Kumar Lat, he's from IIT Indore, Dr. Vibhor from IIT Bombay. We have Dr. Deepika Malik working with us from SAMES, and we have our software development team. Many of our work has been funded by ICMR, DST, and Royal Academy of Engineering, UK. Thank you for your patient hearing.
Thank you, Dr. Atray. That was very nice, the human digital twin, and it stimulated a lot of thought amongst us. And we are very thankful for your presentation here. And does any of the chairpersons have any comments? Thank you so much. Next one. I would like to now invite Dr. K.N. Bhagat, who is Chairman and Managing Trustee, Orissa Trust of Technical Education and Training, who will be speaking on utilization of telemedicine and artificial intelligence towards universal healthcare and health technology assessment.
Good evening. We are thankful for giving this opportunity. And this, regarding this telemedicine, what all we have learned, how it can be delivered at the grassroots level, and how it can reach, the benefit can go to every part of the country, the villages, and that is what OTT is doing, and how we can achieve universal healthcare through this system. We make a small presentation. I feel guilty that I'm not well to speak, so I just put some videos and some presentation. I may be excused. Thank you.
So just to introduce ourselves, we started this project to achieve the universal health coverage in the year 2006 in technical collaboration with the
Excellence Award in e-health and telemedicine.
This project in the year 2006 on a PPP mode with the government of Odisha to provide the healthcare
OTT-ET. It is engaged in extending healthcare services to the rural poor in Odisha by establishing telemedicine centers in rural areas. It employs a PPP model that involves the state government and some of the most prestigious tertiary care hospitals in the country. It promotes micro-entrepreneurship by providing training to local unemployed youth on telemedicine technology and creating employment opportunities for them. OTT-ET is the winner of Times Health Excellence Award in e-health and telemedicine. OTT-ET. It is engaged. OTT.
So this video will give you the whole idea about this project.
India is a vast country with a huge disparity between urban and rural infrastructure. The people in rural and remote areas are found struggling to access timely medical treatment. Under the guidance of Bhagwan Shri Satya Sai Baba, with a vision of national development through education for all, healthcare for all, service for all, moral and spiritual regeneration of mankind, the Odisha Trust of Technical Education and Training, OTET, headed by Shri K.N. Bhagat, designed the e-health and telemedicine project in 2009.
Health for all is not possible due to the mismatch of doctors and facilities. Through this project, quality healthcare made accessible at the grassroots level, and it reduces the direct cost to government and out-of-pocket expenses for the general people.
It involves training of local youth in e-health and telemedicine services and enables them to set up e-health centers in government-run primary healthcare centers, PHCs, community healthcare centers, CHCs, and subdivisional hospitals. At OTIT, local youths are trained for a month in an e-health program, after which they can start an e-health center in PHCs and CHCs. OTET has tie-ups with government hospitals as well as private hospitals such as Apollo, Global, Asian Institute of Gastroenterology, and Narayana Hridayalaya, amongst others.
होने के कारण से रेटिना में गड़बड़ हो सकता है, उसको हम डायबिटिक रेटिनोपैथी बोलते हैं.
So far, 127 such centers have been opened in Odisha at the village and district levels. These centers have created job opportunities for over 500 youth in Odisha and reached out to over 5 lakh patients.
Teleconsultation and telefollow-up. जो पेशेंट माने बहुत दूर रे रहउछंती सीएससी पीएससी गाँ रहउछन तांग डॉक्टर जाई पारु नांती एठी बसिकरी हमर टेलीकॉन्फ्रेंस रूम रे बाहर छोट छोट जगह रे इवन कोरापुट रे बसिबा लोक मध्ये हमठो हेल्प नै पारिबो.
This project creates huge employment, thereby helps for all-round socio-economic development. A person need not move from his village unless until a surgical intervention is required.
OTET's e-health and telemedicine model has been recognized as world's first viable approach to incremental and sustainable implementation of ICT-based development project based on local ownership and PPP model of governance.
So, this is the video which covers the activity of how OTET telemedicine centers delivering the healthcare access to the rural populations. In order to achieve the universal healthcare crisis, we have rolled out this project. So, the key systematic gaps we have initiated the identify the gaps which are the critical shortage of doctors and healthcare workers in rural and tribal regions, poor diagnostic infrastructure and lack of specialist referral systems, financial barriers and fragmented healthcare data, poor continuity of care and missing the STA framework. So OTET rolled out as a response, including the telemedicine and AI, most scalable, cost-effective path reaches the 51,000 villages with the zero capex on the government, and 53 operational centers across the 15 districts of Odisha and 7.4 lakhs patient already served and documented as a hub and spoke model. So roadmap of OTET to achieve the universal health coverage is we have just started the agreement with the NAMS and OTET, AIIMS Bhubaneswar, and the joint representation to the Ministry of Health and Research and Publications programs. The artificial intelligence in healthcare, AI is not about the robot, it is about the empowerment, giving the frontline workers as a smart tool to serve with more care and less delay. We have augmented the AI, artificial intelligence, in the OTET solutions for the diagnostic AI, clinical decision support system, predictive analysis, and virtual assistance. The healthcare technology assessment has been done through the process of clinical efficacy, economical evaluation, ethical and social equity, organizational and legal regulatory framework, and technical qualities done by the Ministry of Health and Family Welfare, Government of India. And the telemedicine is the delivery of healthcare services using the information communication technology to overcome the geographical barriers, increase the access of healthcare as per the WHO definitions. So under this, we have roll out the modalities for teleconsultation, teleophthalmology services, teleradiology, telepathology, creation of EHR, which is the ABHA enabled now, and training for the accredited health assistant who is the operator for this OTET telemedicine centers, which is validated and certified by the National ISO Center located at SGPGI, Lucknow. These are the 7 pillars why this model is unique. It's a zero capex cost to the government. EHR at the village level, we are creating the electronic health record and maintaining it at sub-center level. Training of unemployed youth through the government process to make them technically enabled to operate the telemedicine centers at the rural areas. advanced diagnostic center like a point of care diagnostic, it is attached with this e-health solutions, specialist teleconsultation from different institutions of the country, and AI enabled scale up to meet out the national AI mission for pan India development, and ABDM integration is also part of this solutions. So these are the impact, proven impact, which has reflected in our data. So this is the kind of solution through which we are imparting the healthcare solutions at the doorstep level. This solution is also meeting the vision of Honorable Prime Minister of India. We are in process to develop the agreement with the NAMS and AIIMS for further scaling up the AI enabled solution for pan India deployment. We are also in process to launch the certification program for the paramedical staff and the operators who is working for operating this telemedicine platform in a hybrid mode. So these are the global recognitions and endorsement as a proven national asset for this solution.
On awards, and this is for e-health and telemedicine, and the winner is OTTET. A round of applause for them, ladies and gentlemen. Requesting Managing Trustee KN Bhagat and Mr. Ellen Agarwal, the trust member, to please come on stage and collect the award.
OTTET. It is engaged in extending healthcare services to the rural poor in Odisha by establishing telemedicine centers in rural areas. It employs a PPP model that involves the state government and some of the most prestigious tertiary care hospitals in the country. It promotes micro-entrepreneurship by providing training to local unemployed youth on telemedicine technology and creating employment opportunities for them. OTTET is the winner of Times Health Excellence Award in e-health and telemedicine.
On awards, and
this is the last slide. Thank you.
On behalf of all chairpersons, we thank Dr. K.N. Bhagat sir for such a novel initiative from the year 2009, which is a OTT telemedicine services to serve the grassroots level, and not only the primary consultation, but follow-up, point of care testing, teaching and training. We are very thankful to the speaker and their co for their such a novel presentation to us. Thank you, Dr. K.N. Bhagat sir.
Thank you to the chairpersons. Now we arrive at the intellectual centerpiece of this afternoon, the panel discussion on the practical implementation of artificial intelligence in Indian healthcare. For this, may I please invite the panelists on the stage. Dr. Sangeeta Desai, former professor and head pathology, Tata Memorial Hospital, Mumbai. Dr. Sanjay Deshpande, scientist at Regional Center of Biotechnology, DBT. Dr. K.N. Bhagat, Chairman and Managing Trustee, Odisha Trust of Technical Education and Training. Dr. Aitre Ghosh, IITI Drishti CPS Foundation. Dr. Khushali Pandey, Associate Professor and Head, Biological Science and Engineering, MANET Bhopal. Dr. Vijayshri Chaurasia, Associate Professor, Department of CEC, MANET Bhopal. And Dr. Nilesh Srivastava from AIIMS Nagpur. May I now request Professor Y.K. Gupta sir to kindly moderate this session.
I think we have a very learned list of panelists and relatively less number of audience. Why is relative as compared to in the morning, because such a learned panelist, and I think it deserved to be full jam packed. But by AI, you can predict that this hall is full, right? It is not the crowd which matters. It is the interest of the limited people, of quality people, which matters. So clap for you. So what we are talking now, with the learned panelist and with the background of all ifs and buts which everybody has given, and particularly when Dr. Rakesh Agarwal told about the limitation of that, and somebody said कि AI तो जाएगा नहीं, लेकिन AI नहीं जानने वाले चले जाएंगे और कुछ दफन हो जाएंगे, कुछ दफन होके भी अमर हो जाएंगे. मगर those who have clinical sense will never disappear. जो क्लिनिकल सेंस है जिसको हम कहते हैं खत्म होता जा रहा है, तो एक टाइम ऐसा आएगा जिसमें क्लिनिकल सेंस होगा, वही सबसे धुरंधर माना जाएगा और एआई वाला उसके नेक्स्ट ही होगा, क्योंकि भीड़ मरीजों की एआई देख के नहीं लगती है. पब्लिक सेक्टर में, प्राइवेट सेक्टर में भीड़ मरीजों को देख के नहीं लगती, भीड़ लगती है डॉक्टर के बिहेवियर को देखते, हाउ ही कनेक्ट्स विद द पेशेंट. ये हिंदुस्तान में है और हिंदुस्तान का डॉक्टर दुनिया में किसी भी दुनिया में कहीं चला जाता है तो जिसे कहते हैं हिंदी की लैंग्वेज में छा जाता है. यही होता है ना. और बाकी सारे जो विदेशी डॉक्टर हैं वो अपॉइंटमेंट पे अपॉइंटमेंट, इन्वेस्टिगेशन पे इन्वेस्टिगेशन, और एआई जनरेटेड ने ये कहा है वो पहले ही लेके आता है. मरीज तो खुद ही एआई जनरेटेड रिपोर्ट लेके आता है, तो उसको एआई जनरेटेड की रिपोर्ट से नहीं हरा सकते, उसको आप अपने स्किल से ही हरा सकते हैं. तो मे बी आई विल जस्ट रिक्वेस्ट डॉक्टर संगीता देसाई. Dr. Sangeeta, I am sorry I am speaking in between Hindi. I hope all of you understand Hindi.
I enjoyed
Wow,
your comments.
great.
And I enjoyed your talk without any slides.
So nice of you. I am honored. So I am really humbled and honored with. So Dr. Sangeeta, you are in the top hospital of the country, where Tata Memorial Hospital, where the most tough cases, most depressed cases, most complicated cases of cancer come. And how do you feel कि AI, देखिए हम इसलिए पूछ रहे हैं कि टाटा में जब कोई जाता है तो वो लास्ट होप की तरह से जाता है, तो उसमें भी अगर आपने AI लगा दिया तो इससे वैल्यू बढ़ेगी या वैल्यू कम होगी पेशेंट के व्यू पॉइंट से, आपके व्यू पॉइंट से नहीं, पेशेंट के व्यू पॉइंट से.
See, I'll just give you an example because I am a dispassionate observer of any new technology. It's not like I develop digital path or molecular and AI, and that's why I'll say this is everything. That is not my my take. But what I would say is wherever there is enormous workload, and for pathologists in our routine day, there are many such mundane, repetitive, boring tasks. And if the volume is very high, and if there is some assistant in the form of AI is coming up and it's going to help us, I would welcome it. But I don't mean that I wouldn't, as of now, because with the technology is continuously evolving, I don't want AI to diagnose for me that kind of I still I'm not in the position to accept that point. And I can cite one example. In my talk I mentioned the first US FDA approved algorithm for grading of prostate cancer.
that was employed by a very eminent pathologist in the US. He's also a pioneer of digital pathology AI in the globally. So he himself cites this case that so there was a prostate case and he used the algorithm, and algorithm said prostate cancer 3 plus 3 is equal to 6, whatever. He was, when he went home, he was extremely uncomfortable with the case. So he revisited it on the next day. And what it was rectal cancer invading the prostate, which the algorithm, and that's the reason why you need human oversight. So for me, wherever there is volume overload, AI is there to ease the pressure, is there to enhance the workflow. It's going to reduce variability. So that example I gave you in HER2 low is the latest kid on the block for us, and there the interpretation is very, very difficult. So there again AI has some role. So these are certain examples, not run of the mill, not carpet use of AI.
I think Dr. Sangeeta has given one last sentence and was the initial sentence. It should not be as a carpet, right? That's one thing, very, very strong message. The another message which Dr. Sangeeta said, that she will not like AI to diagnose for her.
Yeah.
She will like AI to help her in diagnosis. So how many of you will agree with this, that AI should not diagnose for you? Everybody is raising hands. How many of you will like that AI should help you in diagnosis? Everybody. So AI की किसी ने importance नहीं कम करी, as you said. Now my one question to you again, maybe I will ask others also. Suppose you said भीड़ अगर बहुत ज़्यादा है या बहुत crowd है, then AI can be a good help. Suppose a minister, chief minister, or maybe comes to you, टाटा मेमोरियल में या एम्स भोपाल में तो आएंगे वो 3 जगह से रिफर्ड कर होके, ऑलरेडी उसके पास AI जनरेटेड रिपोर्ट है फ्रॉम वन सेंटर व्हिच सेज दैट दिस इज द कोलोरेक्टल कैंसर और दिस इज व्हाट यू से कैंसर कोई टाइप है, एंड यू से नहीं ये हम मानते ही नहीं है. सो हाउ यू विल पुट पॉइंट अक्रॉस? वो तो एक टॉप साइंटिस्ट, टेक्नोलॉजी बैकग्राउंड, वो कह रहा है कि ये this type cancer, and your clinical acumen says no, I don't agree with this AI generated, I go with my clinical decision. So how we handle such situation, and what will be your, because वो तो ये याद रखिए बैकग्राउंड में जो बड़ा स्ट्रांग, पावरफुल, पॉलिटिकल, एडमिनिस्ट्रेटिव पर्सन है, दिमाग भी है, अकल भी है, और बैकअप में उसका AI इंफॉर्मेशन भी है.
See, at this point of time, even if the report is AI generated, the physician or the pathologist who is using this particular algorithm has to take complete responsibility for it. So it's not like the machine had generated the report. So the doctor is responsible for that particular report. And I think patients do understand that even between the two human doctors, there can be difference of opinion, and there can be difference of opinion with them between them. First of all, it's not machine generated. That is also signed by a doctor who has to take responsibility even if it is machine generated. So I think this is not very difficult to explain to the patient that this needs to be re-examined by another pathologist. That's my take on it. It's irrespective of
Wonderful. I would just like to have opinion of the house, because this is the exact situation I have faced with one of my so-called powerful friend, जो कि भटकते रहते हैं एक डॉक्टर से दूसरे डॉक्टर के पास, दूसरे डॉक्टर से तीसरे डॉक्टर के पास, फिर टाटा में चले गए. उसके बाद की स्टोरी हम साइलेंट रखते हैं. Please, sir.
Sir, one first thing you are asking, he is coming to you means he wants the second opinion.
Second opinion concept in India is so much increasing now.
Yeah.
सेकेंड ओपिनियन बोलते हैं, लेकिन वो थर्ड फोर्थ भी होती है.
Yes, sir. That is the things.
Correct.
Like suppose someone is coming to me and already with having the diagnosis, means first is the second opinion. He has to accept some opinion from my side. Means I may be using my what I am using the AI algorithm with my own findings, my own data I will put, and I will be convinced this is my data. I will tell. I cannot take their what they are using data. They are generating their algorithm. They see the things I cannot use. That is things when you are in the top institute like a TMH in AIIMS, you cannot go with the data someone is coming to you. This may be AI generated, this may be algorithm they are using, but that data, how they are putting into their algorithm, and how my data I will put into mine, that is maybe same algorithm, but that analysis should be mine.
Dr. Rakesh? No, I am not giving you hypothetical situation. This is slightly modified, but ऐसा हुआ है.
See, every time a patient comes to me with asymptomatic gallstones, comes with an opinion from somebody get gallbladder removed, and I disagree with that, and so this is a part of clinical medicine, as she said, and there are people who accept it. There are people who accept it on your face and then go away and do what they want to do. There are people who disagree with you. At the end, the last sentence is exactly what she said. Sir, you have come to me because there was a reason why you came to me for another opinion. Now that you've come to me, I can only give you my opinion. My bigger challenge is something very different. Today we have people who have learned all this without AI and we are able to do it. In Australia, some 30 years ago, they decided that there was no need to teach grammar in schools and they stopped teaching grammar. Now they have realized that they need to teach people grammar. And the problem is they can't find teachers for teaching grammar because 30 years nobody has taught grammar. How are we going to do things 30 years down the line when Dr. Sangeeta is no longer around and people of that genre are not around? How are we going to manage? This is something that is where my brain is not able to digest things. Today, my residents are not able to take history. I'm not able to rely on their. Sorry, I know some of you are residents here, but I'm not talking of you. I'm talking about my residents. Maybe I have not taught them well. We are not. They don't know how. So a lot of these language skills, argumentative skills, are going away because we are not asking them to do that. Pressy writing was something that you and I did at school. Today they don't do that and they cannot summarize the patient's history in 5 sentences. These are the skills that AI is going to take away and it is taking away. There is a problem. And that is something that we as a generation need to realize and we as medical teachers need to talk about it. Same way cost, he talked about it. We are not realizing what it costs. Though incidentally, I disagree with him. If one is 200 GB, 500 will take actually 100 TB, not 2.5 TB. There was a minor error, but that's okay, fine. You have some other features. But what I'm saying is, so there are problems. These are not panaceas. And we will have to learn to disagree and say, and this is where the problem is, what I was trying to say. When AI comes, people are more ready to believe it than an individual opinion. And that is something that we'll have to realize is a problem. If you are speeding and your meter shows only 80, you are ready to believe that it is 80, even though everybody else might tell you that it is not so. That is where the problem is.
I would ask Dr. Tandon to respond to this, but I will add another dimension to this, and I think you can add your answer to this. So usually, in places like AIIMS, Tata, or other referral hospitals, people come as a complicated case. Simple case होगा तो वो primary, secondary में filter हो जाएंगे. यहाँ पे तो rare या AI जो बनता है based on the large data which is based on algorithm. So now this is each patient is a individual patient, is a new case study. और rare हो गया वो. तो ऐसे पेशेंट को हाउ AI विल हैंडल, दैट्स व्हाई आई सेड इन माय टॉक कैविएट्स जानना जरूरी है, इसकी स्पेसिफिसिटी जानना जरूरी है, और उस डोमेन के बाद 85% तो आपका बेल शेप में आ गया, जो इधर इधर जो 3SD के बाहर आया उसको हम कैसे अकाउंट फॉर करेंगे अपने डिसीजन मेकिंग प्रोसेस में. द सेम क्वेश्चन विल फॉलो नाउ. यस.
So, a day, one referral case came to me in microscope. I just clicked the image and posted on something called as a Google Lens. We are familiar with. The tissue is having glands and tissue belonged to prostate. Some diagnosis was given from outside and Google Lens said it is testis. Have some glands. Again, after 2 days, same picture I posted again on the Google Lens, said breast. Again, some glands. So, Google Lens is identifying a tissue which is having glands, but which organ it belongs to, not able to identify. When it is coming, the pathologies of that given organ, not able to identify, therefore some limitations. These limitations we are making smart our AI by the putting lot of images. I think Dr. Desai ma'am is agreeing. And we are at a very early level of our pathology journey. Therefore, including her and me, we always see slide afresh as an independent pathologist, and we will definitely keep second opinion in our own department whenever some case is coming as a challenge. Most of the time in our institutional reporting system, we use multi-header. Opinion from the junior most to the consultant who is signing out the report, everything is taken into the consideration. And that thing is right now missing in the AI system. AI don't give a multiple consultant opinion. It will give just an opinion like testis, like breast, like prostate, any tissue like gland. So in my view, what we are presently handling, man behind microscope is more important than man with or without AI.
A study was done in ILBS, Institute of ILBS जो है ना दिल्ली में, उन्होंने एक सिंपल 20 क्वेश्चन बनाए और वो क्लिनिकल केस सिनेरियो, और उन्होंने अपने सारे डीएम स्टूडेंट्स को दे दिया कि इसकी डायग्नोसिस इन्वेस्टिगेशन क्या क्या करोगे, डायग्नोसिस क्या होगी, ट्रीटमेंट क्या होगा, इस पे लिखने के लिए, और उसी को उन्होंने एआई प्लेटफॉर्म पे दे दिया. जनरेटिव एआई के बाद में उन्होंने कहा कि इसके आंसर को कंपेयर करो, उसका रिजल्ट अभी डिटेल है, बट नियरली ओनली 60% कोऑर्डिनेशन वाज देयर. दैट मींस 40% से ज्यादा उसमें डाइवर्जन था. हमने उस स्टडी की उसमें बड़ी सारी कमियां थी, लेकिन उसको नहीं बता रहे ब्रॉडली. तो ये भी एक, तो हमारे एक इसमें से निष्कर्ष ये निकलता है कि हमने पहले ब्लैक बोर्ड से पढ़ाई शुरू करी, उसके बाद में हमने पीपीटी बनाना शुरू कर दिया, और कुछ लोगों ने पीपीटी बनाने के लिए भी नेट पे से पीपीटी आती है, अपना दिमाग नहीं लगा के वो पीपीटी दिखाना शुरू कर दिया. अब वो भी खत्म. अब हमने एआई से, लड़कों ने कहा यार इनको क्या लेक्चर उनका सुनना, एआई में सारा कुछ बता दिया, सारे वीडियो टेप हैं. द थिंग विच इज मिसिंग इज एबिलिटी फॉर स्टूडेंट फॉर डूइंग क्रिटिकल थिंकिंग. वो क्रिटिकल थिंकिंग कहाँ चली गई? वो कहीं एआई से के बोझ में अगर दब गई तो हमारा एम्स जैसे संस्थानों की जरूरत ही खत्म हो जाएगी. मे बी आई कैन गिव अ चांस टू द पैनलिस्ट टू स्पीक ऑन दिस, देन डॉक्टर राकेश कैन गिव a final comment on this.
Yeah, just one point I would
on
like
the same,
to
anybody
add.
now, all the panelists can take mic one by one from
Yeah,
that side.
just one point.
Please, madam.
Critical thinking and empathy, which AI doesn't have.
And empathy. Absolutely correct. Sir, maybe Dr. Sanjay Deshpande, some? Yeah. हाँ ठीक है. हाँ एक जना इधर भी आ सकता है.
Yeah. So one aspect in terms of like coming from the data analysis point of view. So you talked about the critical thinking, like we have lost it. So just to give an example, when I was studying or when I was doing my masters, so we had to install a tool on a system to which analyzes the data. Okay, for example. So to install a tool, it would take days. The reason is for to install that particular tool, you had dependencies. First, you need to go and understand the dependency, solve that dependency. For that, there is another dependency, like there's a chain, cascade. So it would take days to install a particular tool. Okay. By the time you install the tool, you already understood the logic behind what's it's working. But today, what happens is the like my junior who has joined as a bioinformatician, there is a ready set environment. He just gives one command. The tool does it by itself. Like it takes everything what's required. So you ask the junior about what the tool is doing. He just tells the output that it does so and so. If you ask what is behind it, nobody knows it. That's the challenge what you're talking about. It's the AI or the automation has stopped the critical thinking or stopped the logical reasoning and the aptitude behind it. So I think I've been hearing with the engineering fellows, like my fellows who have been teaching students. So they said that the current generation doesn't want to understand the engineering behind the engineering. Like that's the thing what I've seen.
Maybe Dr. Bhagat.
I fully agree with him. Whatever he said, I think that is what is the logically correct and it should be followed.
Madam Ghosh, Dr. Ghosh,
Yeah.
Ghosh.
Hello, sir.
Yeah.
What I would like to put up here is maybe we are trying to, because I was talking about human digital twin. So more than building a predictive model or a personalized decision making system, maybe we are trying to preserve the intelligence of multiple experts. The day we are able to capture in these AI models and preserve the way multiple neurosurgeons in our country are making a decision on a particular condition, what parameters they are considering, because for each one of them, there will be a difference in the parameters. Maybe one would consider some, the other would, depending on the age category, would consider some more, depending on the lifestyle. Not all of our lung capacity maybe is the same. So again, one thing that goes missing in these AI models is consideration of the baseline. Coming from the technical aspect of things, that is again something that we are trying to work on. Can we understand or define the baseline for each patient first? Whether the patient is in critical care or it's in the field of cancer, and then the AI models are built. So it's more of building the digital twin of the experts' decision making capacity, so that tomorrow, if an expert neurosurgeon who is available in Delhi is not available here in Madhya Pradesh, I am still able to use the capacity of the human digital twins decision making power, who has captured that neurosurgeon's intelligence over a period of time to give a decision. That is what my thought process tells me.
Absolutely. I think there may be some people may agree and some may not be agree, but I fully agree with you that the पहले तो कुछ आपको आइडिया लगाना पड़ेगा उस पेशेंट के बारे में before you put this into AI. But there are videos, particularly from China, and there are also hypotheses that if this is a critical patient, and I also see one of the chart here, the जो posters लगे हुए हैं, if a critical patient enters an emergency, then it must immediately get scanned by AI, and then it will give some algorithm. So there are both. One is that you put into an algorithm which has to be turn around time of this algorithm has to be quick, in minutes, not in hour, and then the expert will take final call. Yeah, alternatively, there is something which is, and this has been done an ICMR project where stroke, ischemic stroke, or hemorrhagic stroke, the project was, and the treatment can be started much earlier. Then you go for MRI or PET scan results available. So this is again an issue. Maybe I can have a comment from Dr. Pandey.
Thank you so much. Sir. Yeah, thank you so much, sir. As an academician and bioinformatics background, means I would like to add few things, because as a teacher, I agree with conventional practices cannot be overlooked because human experience is involved there. As ma'am has mentioned that in every human being is having very different case, every human being is having different case. I'm not from medical background, so I'll not be using medical terminologies because there I may be wrong. But if I say about the cell, genome of every cell is very different, so variation at genomic level is there. So even if we are doing drug designing practices using AI, again the bioinformatics is saying that this drug will be doing good with the patients, but when we go for in vitro and in vivo studies, there we feel fail. So it's not like that computationally we have done, so it's now the drug is ready to go for the market. We cannot overlook all these in vitro and in vivo practices. The same thing applies for medical diagnosis and other clinical practices. The conventional practice will not go away in any case, and it should not go. But only thing is AI tool, AI I use for augmented intelligence only, because artificial intelligence is just a prediction and prediction is having 50-50. So augmented intelligence will work for the clinical practices, and this clinical practice, again the doctor will put their intelligence and their experience, the way they are analyzing, they are interpreting the diagnostic reports, only that is going to be the more authentic way. Otherwise, only depending upon whatever tool has given you the decision, they are not giving the decision, they are just mimicking with the decisions, but you are the only right person to take the final call upon that, yes, this is what the diagnosis should happen, and based upon that treatment guidelines should be there. Thank you so much.
So मुझे ऐसा लग रहा है ना कि at the after this you can add your comment also on this. मुझे ऐसा लग रहा है कि at the end as the session progressing, हमने सुबह से लेके दोपहर तक तो AI की तारीफ करी. अब सडनली हम डिफेंडिंग हो गए, डिफेंसिव हो गए. यार AI को मारो गोली, हमको तो खा रहा है. सब डिफेंसिव हो गए अब तक. मतलब किसी ने भी AI की भरपूर तारीफ नहीं करी, सब डिफेंसिव हो गए. जैसे लगता है कि AI हुआ है, बट यू कैन नॉट लिव विदाउट हुआ, बिकॉज अब
Sir, I
आपने
would like to add one point, sir.
डेफिनेशन भी चेंज कर दी. इन्होंने माना ही नहीं कि AI इज आर्टिफिशियल इंटेलिजेंस. इन्होंने कहा ऑगमेंटेड है, गुलाम ही रहोगे तुम हमारे.
Sir, I would like to add one thing. One experience is there in our classroom teaching. We do have this practice to give the assignments. And nowadays, what students are doing, just opening the chat GPT, writing the question without understanding, they are copying from there. So in that case, means AI is not good.
But sometimes the answer by chat GPT is better than what teaching in the blackboard. तो ये भी एक समस्या है ना. हमारे को चैलेंज हो गया है कि हाउ यू रिटेन योर रेलेवेंस इन प्रेजेंस ऑफ चैट जीपीटी. टीचर के लिए बड़ा चैलेंज है ये कि चैट जीपीटी में तो सारा आंसर है. जब तुम पढ़ाने जा रहे हो, सेंटेंस कंप्लीट नहीं किया, उसके पास आंसर है. सर
Sir, my comments on this is we are taking always the absolute things. That is the problem. You never think that life is not yes and no. In between things we are not accepting. That's why we are defeating one is no, yes. And human brain from beginning, from birth is 90% negative. Only 2% positivity. This is the truth. When we are talking this like artificial intelligence, someone is telling no, there is no empathy, nothing else. But if you will see, go and clearly the development in science, you will see now, see Elon Musk putting the chips, and how you think that will give the direction. That there is artificial empathy. Now this term is coming, artificial intelligence with the empathy. There is artificial empathy. He can study your emotions. That's why the science is always evolving. We cannot stop that. That is not right. That is wrong, because we always think this is the absolute. Absolute things is not on the day one it will come. This is the evolving. We have to take it as a tool We cannot deny it. Artificial intelligence, if you say that there is no immunotherapy, patient are living. Patient were living now with immunotherapy, and stage 4 lung cancer is living more than 25% survival is going up. What we are not thinking 10 years, 20 years before. Why? This is the development. This is the science. We have to accept that is there. But problem comes when you will think it is absolute. Yes or no? You cannot compare like that way.
Yeah. तो इस खोपड़ी का दिमाग तो हमेशा रिलेवेंट रहेगा ही रहेगा, चाहे वो कितना भी आर्टिफिशियल हो, चाहे ऑगमेंटेड हो, वो रहेगा ही रहेगा. I have one relatively young Dr. Chaurasia.
Yes, sir.
So I said relatively. So I take it back. You are not relative. We are young. So what you feel about it?
Sir, actually, I am from the engineering background and I have expertise in the computer vision and pattern recognition.
एक चीज का, because you are for engineering department, and
Yeah.
what he said, artificial empathy. Can you really develop a program?
Yes, yes. That is what I would like to add from the point of technology. Actually, everyone is talking about that AI is predicting not accurately or some way, some wrong interpretations and all. So AI is basically based on the pattern recognition. And whatever input sample is given to it, it extracts a pattern out of it. That pattern may contain n number of information into it. So it depends. Just we are talking about like Google Lens that is trained on certain data, working well on something, may not be working well on the specialized task like predicting cancer or somewhat like that. So it's like how you taught and how you made the architecture of any AI system that we used to call a model. So pattern contains n number of features, we can call it. So how many precise and how many number of large relevant features we would be adding in the pattern. And any AI actually feeded by the pattern, not by the sample. We extract the patterns out of the sample and we feed it up. So how enrich and based on the domain knowledge, I would like to explain it like this, that I have to identify the face by AI, that I have to recognize who the person is. So if we talk about, so green color or blue color content in a face plays very irrelevant role into it. So that's why it is also very important that what feature, what pattern you have made and decided and given it to the AI machine. So as empathy or history of the patient, if we would be adding these things to teach the machine, might possible AI will be able to make better decisions on the specialized task. Second thing, which is like, can we replace everything or human intervention by AI? So that is not at all correct, because ultimate decision has to be taken by intelligence, not by the artificial intelligence, because artificial intelligence is also developed by some human. So this is how it is, that how well we train it, how well we make a pattern, and how well we design an architecture. And another good thing which is coming currently in the technology, that is multiple instance learning. 3 years back, some different situation was there. In 3 years, we may got similar kind of more 1 lakh samples. So we may train the same machine with the new samples. And larger samples is not the only requirement. Variability in the sample is the requirement. Like if we have 10 lakh samples of same type, no meaning. If 1 lakh sample with the 1 lakh different kind of variability will be used for extracting the pattern and then to feed it to the AI model, it will be doing better. But certainly humans could not be replaced. Thank you so much.
Good. I think you agree, and nobody will disagree that human will always be there. And you mentioned that it is a pattern recognition which AI does. But important thing is how many variables it is capturing, so that it becomes more accurate. The question which I will pose to Dr. Srivastava and English, which is offshoot of this, you have in many times outliers. See, अगर एक line खींचे हैं, तो इधर एक point है, इधर एक point है, इधर एक point है, इधर एक point है, इधर, and then you put what line is called as a best fit line. And this best fit line is the AI generated information कि ये AI है, ये हमारे variables हैं, इसके basis पे ये AI है. But there are certain outliers in clinical practice. These outliers, usually when the residents are here or the physicians are there, they publish this as a case report. The case report usually are the outliers. That's why it become case report. So how, Dr. Nilesh, you think this issue is addressed in this? Otherwise, the case report तो बनेगा ही नहीं. Publication तो कम हो जाएंगे हमारे.
Sir, artificial intelligence is the thing we can think like it is like what input you are giving to that specific system. So thing is that whatever you are feeding him, it will come to you also. If you are giving the right information, definitely you will get the correct information. If you are putting some wrong information, you will not find out the expected outcomes. So in these situations where you are putting what is your main input, that is the only things which will decide that what best you are getting from that artificial intelligence. Compared to what you told, sir, that points that is not coming in your lines. So that everything is depend what is your input is there actually, or what you are going to be feed there, sir. So everything is depend on your expertness. So it is not only the data what I have feed it. It is the data that what they feed it, or 100 people feed it, or 1,000 people feed it. Maybe some points is there which everybody is lacking, and that point is there which is going against that perfectness, and that comes to human intelligence, not for the artificial intelligence. So that is the area where where AI can't defeat the human intelligence.
I think, please.
See, as you were telling from the beginning, we are praising the AI like anything, and coming to the end of the day, we are like restricting into it. But I would like to add that of course, I am not advocating that replacing the human, but certainly AI or any technological development is anyway contributing. It's up to how you use it. Just for example, I would like to add into it that just a slide. Just take an example, because I am basically doing image analysis in my research. One image is there, just say pathology people are here, so pathology image is there, that is a staining is there, and one pattern has been formed. It could be viewed by the human, or for the biomarker, it could be treated chemically. Chemical agents or their research is somewhere restricted with the physical aspect. If we convert it to a digital slide, so we can deal it mathematically. We can deal it mathematically. We can apply any kind of transforms into it. We can, you can say, modulate and recast images in some other way, or any other signal, which is not possible manually. So like involvement of technology will anyway enrich the system, but with the support of the experts of the domain. Not like a black box. If we are using AI or anything as a black box, it will not help. But if with the intelligence and the knowledge of the domain expert, it will certainly a great help for the mankind. Thank you so much.
There is no disagreement what you said. The AI is basically what she said is augmented. तो वो आपको मदद ही करेगा, and you can get lot of analytical inputs from
Sir,
that.
I want to add some 1 or 2 points, sir. Although we are going here, or we are debating against the AI here, like human intelligence is better than AI, or it can't replace. But I am telling it is not totally against. We are not totally against it, because as a surgeon, I am a surgeon. As a surgeon, what I want the precision. I want the expected outcome, sir. So like there are much more examples is there. One examples I am putting here, sir. One European study is there. That is very interesting study where what they have done, they have used AI based stimulators, sir. Simulators was there. What they have done, they have compared two groups. One groups where the student trained by the experts. One group where the student trains by the simulators. So what they have done, simulator groups, first they have given the simulation training for the residents for a neurogenic tumor excisions. After that simulations, once they have seen that the resident is perfect in doing that surgery, second step that they have given the second simulation like same brain tumor you are excising, and if you are passing that second phase, third phase they have given the live experiment for neurogenic tumor excision. What they have find out, the students which is teased out by the experts and the students which have taken the VR training with simulations, they are comparatively having 10% more efficacy, sir, for precision of excision, less complications, more expertness, more following the pathways or path or during the surgeries. So it is not like that AI is always and always on the wrong side. It is somewhere is right side also.
Most of the time, AI should be on the right side. It should not be on the wrong side. तो AI का मतलब ही तब है जब हमको हेल्प करे, तो राइट साइड में होगी तभी हेल्प करेगी. दैट इज व्हाई algorithms are developed. So I think the time is almost up, 1 or 2 minutes, and what I feel that such intelligent remaining people. So any question, any comment from the floor, particularly from the back benches and then on the first bench?
Can I give one comment?
Sure.
Sir, we have to remember that what I shared that time in brain center, one section means one slice of the brain data cannot kept the computer we have already produced. All this why I discussing this is by the computer generator. Means you cannot compare the human brain with this the computer. We are developing definitely. This would that replacement word remove, but we have to definitely the augmentation like this is the augmenting. Another thing what doctor you were telling, you are a surgeon, you are telling this the simulation study, this is the comparison. Means that is comparing this is the trained by one artificial, but trained by a expert surgeon, the same thing. Because the expert surgeons are less, we are making it like the artificial intelligence we are taking it this training. I will train the someone my trained by someone. This definitely there is a difference. That study is telling that we have to support. This is the universality. Can we objectify? That's why the simulation we are keeping, because some Dr. X will not be available every time, but that simulation will be available. That's why that comparison coming like that. That is the way we are taking help of the simulation or AI. Like now, this is the robotic is coming. Initially, tactile sensation was not there, but when AI coming, the tactile sensation are putting like the robotic. The Da Vinci is coming 5th generation. You can feel the tissue. That's the development is going. That doesn't mean it will replace my tactile sensation. That is the objectify our things. We are gradually going. If I am not there, the surgery will not be done. Like big surgeon is not there, that the same quality surgeon we cannot give. That is the like augmenting. We cannot think absolutely that we are replacing. This is the always we are discussing like the allopathy, Ayurveda replaced. The same thing. Computer came, human replaced. That itself comparison is wrong. My point is that.
I fully agree. हमें अपने दिमाग को और आर्टिफिशियल इंटेलिजेंस को कंपेयर करना ही नहीं. वो कंपेयर because they are complementary to each other. They have to be supplementary and complementary to enhance.
Then many questions you can answer by that way, sir. If you will compliment.
Sir,
And,
excuse me, sir.
please.
Just on
Last
the
comment.
lines, yeah, just one point. You talked about outliers, right? And then this discussion on replacing experts and trusting AI more. So this can be actually thought about by taking into consideration neural networks, the concept of neural networks. So how these outliers actually can be taken up, and then what solves the, and definitely then why this replacement can't happen is, when we talk about neural networks, suppose we want an 8 at the end. That is what the decision we want. So there are certain parameters that are selected and weights are assigned to these parameters so that they work and they return an 8 to me at the end. Maybe I'm getting a 5, not an 8. Again, the weights have to be rearranged so that it again runs, the algorithm runs and returns from a 5, it returns me an 8. Assigning these weights to these parameters, these nodes, have to be done by an engineer sitting with a doctor. Those weights cannot be, because we lack, as an engineer, we lack the ones who are developing the algorithms, we lack the clinical explainability of things. So assigning which parameters should be at the top, should have more weights, that has to be done by the clinical expert. And that definitely justifies why that replacing the clinical mind is never possible. But building a neural network, a CNN or a DNN model, can assist a clinician to take a decision, can support.
Yeah, that's what I'm telling. That's what I'm telling. If he see, everyone will be like Elon Musk. No, everyone will like. See what we are doing. We are always thinking that why this discussion and replacement word itself is wrong. When our computer, one slice of brain cannot hold that data with the computer we have till produced. Even tomorrow, supercomputer cannot hold the whole brain data. How can we compare this? That this will replace our human brain? This comparison is wrong. But simultaneously, while comparing, we are neglecting the benefit of these things. We have to complement, because always the subjective thing gives you error. There is a bias. We always try to give a objectify anything, anywhere. That means you have to remove the
Dr.
bias.
Wadbad,
Yeah.
You won the debate.
No, sir. Won nahi, sir. Not
No, you won the debate because I'm also. If I am judge, you won the debate. Because it cannot replace.
Yeah.
No doubt about it. So, but if you can see 1, 2, 3, 4, 5, 6, 7, 8 panelists, how many are engineers? 1, 2. Bioinformatics भी आधा engineer हो गया, तो 2.5. Do you think the engineers are replacing doctors? They will eat our job? आप बताओ, हाथ रेज करो, खतरा है क्या आपकी नौकरी को?
Sir, फिर again we comparison you are telling, sir. Sir, you are comparing the same thing. Now this is a clinical engineering separate department.
So now, when they cannot replace doctors, they are here to support you, and therefore artificial intelligence is also to support the clinical judgment. तो डरना नहीं है इनसे. अभी तो 2.5 हैं, अगले पैनल डिस्कशन हो सकता है सिर्फ 2.5 डॉक्टर रह जाएं, और उसके बाद 10 साल के बाद सिर्फ 1 डॉक्टर हो, 8 आर्टिफिशियल इंटेलिजेंस.
Sir, that's why new branch is developed in US. That's a clinical engineering.
So yes,
that's a clinical engineering, not MBBS, biotech, and medtech is going. Now this is clinical engineering. New branch is developed.
Changing scenario hai, and this changing scenario we have to adopt this changing scenario. Engineers will never take our job. The AI will always support the clinical judgment, and therefore we have to remain contemporary, and as final said was, those who do not know AI will be replaced by those who know AI. ये तो पक्की बात है. लेकिन at the same time, ये जो हमारी critical thinking है, empathy है, ये कहीं गुम न हो जाए, क्योंकि इसके लिए empathy और critical thinking ने गाना भी गाया, ऐसे वीराने में एक दिन, सुना है ना, घुट के मर जाएंगे हम. तो ये घुट के कौन मर जाएंगे? AI, सारा AI कर रहे हैं. एम्पैथी और क्रिटिकल थिंकिंग कहीं घुट के ना मर जाए, तो इसको जिंदा रखना है. क्यों? आई थिंक.
Sir, I would like to say one thing over here with your beautiful song. That is why we like this way. Why doctor need to learn AI? That is not important, because some way if they try to learn AI or anything technology concept, that will like restrict somewhere their domain where they have this expertise. So I would advocate more the better alliances, more making a team, rather than engineers are learning medical and doctors are trying to learn technology.
Another debate maybe next time. This is an interesting debate कि इंजीनियर न मेडिसिन में घुसे न मेडिसिन वाला इंजीनियर बने, दोनों आके दोस्ती करो, शाम को कैरम खेलो, शतरंज खेलो, और बाद में नहीं, बाद में कुछ भी और होता है interaction. So I think wonderful. Thank you very much, all the panelists.
Thank you.
It
Thank you
was-
so much, sir.
And thank you very much, all the audience. We can continue this next debate. What you said, the title तो मिल गया उसका.
Thank you. Thank you so much, sir, for steering this panel discussion and keeping it engaging till the end. May I now request our Executive Director, sir, to please give the concluding remarks.
Good afternoon, all. Though thin, but I think interested crowd is there. But over the things we cannot expect that house will be full always. But I think the whole day after organ donation, transplantation section, then artificial intelligence section with this is not only the creating the awareness, I think create the interest. The someone so intensely involved and listening and sharing the views. That is just like a beginning, but I think that is I will give credibility to all the faculty involved with this so short span. They organized, they take this responsibility, which all NAMS office bearings and the executive councils, they are so happy. I congratulate my faculties, the staffs, and the stakeholders who has organized this thing. And simultaneously, we are grateful to NAMS also to give this responsibility. And starting at AIIMS Bhopal, that indicates this AIIMS Bhopal shows the credibility. And simultaneously, thank you all the deans, directors, faculties from 4 states medical colleges, IIT Indore, BMC Gwalior, all medical colleges from Madhya Pradesh, Jharkhand, Chhattisgarh, and Maharashtra. That is give a tremendous inspiration to our own faculty, students, and the staffs that we look forward to monitor these things, take into the next level what NAMS is expecting, and created this task force CMEs, keeping in view that what the Professor Paul told us from Niti Aayog, that gap we have to address. We may innovate many things we can share with the NAMS functionaries to take these ideas to next level, and we will contribute in a better way, and we will definitely tell that NAMS cell has already inaugurated in AIIMS Bhopal by the president of NAMS, and we will make it a nodal center for this region where we can take or give the feedback to NAMS and take this to other CME faculty also. But already Bhopal is doing so tremendously during the organ transplant. Even our AI has also already started so many things, new innovations in AMC. We will do good for the next innovation workshops here. To boost our AI in innovation and by the research. I'll give another responsibility to the research dean who is sitting in front of me that is there. But this, I am happy that this happened within short period of time, and definitely create a good impact among all in this region. and giving the feedback to NAMS. Thank you all who are here and who have attended, and especially to my faculties, my staffs who is taking this responsibility. Do it. They have done it. You have done it. Thank you so much. Thank you all. Thank you.
Thank you, sir. May I please call Dr. Saikat Das, organizing secretary, to give a vote of thanks.
So I think it is my duty to give vote of thanks to this event, and it is said that all is well that ends well, but it is not always that the final outcome defines the thing. And we had a great deliberation throughout the day. National Academy of Medical Science is one of the pivotal institutes of higher education in medical science, and as an institute of national importance, the mandate was given to us to conduct a workshop on organ transplantation and artificial intelligence. And I am very happy to share with you that all the 4 regions which were included for this workshop, we got lot of participations and almost 300 registrations, sir. And most of the institutes from the region, the institutes from this region, like I am very grateful to all the directors. Madam is here, the director of BMHRC, and then director of MPRI, director of ISER, and director of NIRE, and all the deans of the medical colleges in the state. They either attended physically in spite of their very busy schedule, or sent their representatives and faculties and scientists. So all of them attended in large numbers. The representatives from AIIMS from the other states, that is Maharashtra and Jharkhand, even Jharkhand, in that short notice, they came. And we were able to get great help from NAMS. I must put on records the guidance we have received from the Council of NAMS and as well as the NAMS Secretariat. And all the resource persons of the NAMS, the task force chairman, in spite of their busy schedule, they attended, they enriched us with the knowledge, and we distributed the task force reports of NAMS. As far as the local organizing party is concerned, I think organizing chairman Dr. Joshi would agree that we got very less time to organize this, but we could do it because we had dedicated people, and and we had great organizing team. Like all the co-organizing secretaries, Dr. Bhushan, Dr. Ketan, he could not come today because he had some family issues. Then Dr. Vikram and Dr. Gunjan, they worked throughout the last 3-4 weeks. The registration committee, Dr. Seetal, then Dr. Neha, the research office, particularly Sir Rehan sir and Sunita madam, they extended all supports. The medical superintendent office, administration, all of them extended support to us so that we can make this event happen. I do not know what is the motivation, how they got all the motivation for past so many weeks. They left their personal commitments and all the other things. But I must salute that Gangotri of motivation, what is there, because otherwise such an event is not possible to happen. All the faculties who have participated, because of shortage of time, we could not include, and the reason being we already had the technical consultation yesterday where some parts were discussed. But we are going to bring out the report also as a white paper, and there is a team led by Dr. Sunita who is working on it, and we will circulate that, and we will try, and sir, as sir has told, that we will submit that report to the Niti Aayog also with some of the points of deliberation. So if I have not mentioned anyone, all the support teams, the audio visual, the people who arrange the stage decorations, the media cell, administration, everybody I acknowledge and I thank. And with this, we conclude this event. Thank you very much. And all of those who have come from outstation, I wish them a very safe journey. Thank you, sir. Thank you.